Good evening, Namaste, and welcome to RCC 2023. On behalf of Respiratory Conclave Conference, I Abhishek welcomes you all. पिछले एक दशक से लगातार ब्रिटिजी द्वारा रेस्पिरेटरी कॉन्क्लेव कॉन्फ्रेंस का आयोजन किया जा रहा है। प्रत्येक वर्ष हम लोग विभिन्न विभिन्न टॉपिक पे जो कि बर्निंग टॉपिक्स होते हैं उनको चुनते हैं और हमारे देश के विख्यात स्पेशलिस्ट द्वारा हम आपके माध्यम तक पहुंचाते हैं। हमारी जर्नी कोरोना में भी नहीं रुकी थी। नियमों का पालन करते हुए हम इस कॉन्फ्रेंस को वर्चुअल किए, जिसको काफी सराहा गया। इस काम को काफी सराहा गया था वर्चुअल के माध्यम से। और अब जब ऊपर वाले की दया से सब कुछ नॉर्मल हो चुका है तो हम इस कॉन्फ्रेंस को हाइब्रिड मोड में कर रहे हैं, यानी कि वर्चुअल और फिजिकल दोनों। तो जैसा कि हम जानते हैं कि किसी कार्य की शुरुआत अगर हम काशी में कर रहे हैं तो हम सभी को जय घोष करना पड़ता है महादेव का। तो हर हर महादेव, शुरुआत करते हैं महादेव के साथ। और मैं कार्यक्रम की शुरुआत जो है प्रेस कॉन्फ्रेंस के जरिए हम लोग का होगा और मैं सभी अपने फैकल्टीज को अनुरोध करूंगा कि वो कृपया डायस पे आए। डॉक्टर राजेंद्र प्रसाद सर प्लीज करो बताएं। डॉक्टर के गुप्ता सर, डॉक्टर के त्रिपाठी सर, डॉक्टर अंशुल मित्तल सर, डॉक्टर राजाधर सर, डॉक्टर विनोत्तम तोमर सर, डॉक्टर एस के पाठक सर। मीडिया बंधुओं, जैसा कि हम जानते हैं कि आपके माध्यम से हम एक चीज की रफ्तार को 4 गुनी स्पीड से कर सकते हैं और इस 4 गुनी स्पीड को आज हम जो हमारा मुख्य टॉपिक है वो है डिस्निया। मेडिकल की भाषा में इसको बोलते हैं डिस्निया, यानी कि सांस फूलना, ब्रेथलेसनेस। ब्रेथलेसनेस की कई प्रकार होते हैं, कई तरह से हो सकते हैं और इसी के ऊपर आज का पूरा जो कार्यक्रम है रेस्पिरेटरी कॉन्क्लेव कॉन्फ्रेंस वो आधारित है। विभिन्न विभिन्न विषयों पर विभिन्न विभिन्न किस तरह से इसको मैनेज किया जाए, हमारे पैनलिस्ट हमारे साथ हैं। और डॉक्टर एस के पाठक सर को भी मैं अनुरोध करूंगा वो भी आज करें। आज का जो टॉपिक है डिस्निया, ब्रेथलेसनेस, इसी पे आप लोगों को संबंधित सवाल पूछने हैं। और हमारे सीएमओ साहब अभी आ रहे हैं, ऑन द वे हैं। डॉक्टर संदीप चौधरी सर जो आ रहे हैं, हम लोग अपना कार्यक्रम शुरू करेंगे। हेलो, ओवर टू डॉक्टर पाठक सर। नमस्कार, गुड इवनिंग एवरीबॉडी। हमारे मीडिया के आए हुए प्रतिनिधि बंधु सभी का यहाँ स्वागत है। हमारे साथ ही हमारी फैकल्टी है और इसी कॉन्फ्रेंस के लिए हम लोग हमारी टीम है जो उसको काम लगातार कर रही है। आज वो दिन है जिसका हम लोग प्रेस कॉन्फ्रेंस कर रहे हैं और उनको कार्यक्रम करेंगे। और इस कार्यक्रम की शुरुआत हम लोग लंग्स की बीमारियां लगातार बढ़ रही हैं, फेफड़ों की बीमारियां लगातार बढ़ रही हैं, इसलिए इस पर हमें जागरूक रखना जरूरी है। और हमारे मीडिया प्रतिनिधि के द्वारा ये एक सुगम माध्यम होता है जो हम लोगों को जागरूक करने की कोशिश करते हैं, बताने की कोशिश करते हैं कि बीमारी को कैसे आप सही समय पर सही कंट्रोल कर लें तो शायद सही इलाज हो जाएगा और आपका जो जिंदगी की जो कुछ अच्छे पल होते हैं वो गुजर जाते हैं। जैसे अगर सिंपल उदाहरण दें तो अस्थमा जैसी बीमारी है, नाम तो सिंपल सा लगता है लेकिन इस व्यक्ति को होती है, जिस घर में होती है उसके लिए काफी खतरनाक स्थिति पैदा करती है जब वो अटैक के रूप में आती है। तो हम चाहेंगे कि हमारे साथ जो हमारे चीफ गेस्ट हैं डॉक्टर राजेंद्र प्रसाद सर, डॉक्टर के त्रिपाठी सर, डॉक्टर के गुप्ता सर, डॉक्टर अंशुल मित्तल, डॉक्टर राजेंद्र और डॉक्टर तोमर, और शेखू साहब अभी आ रहे हैं, तो उन्होंने स्पेशली अनुरोध किया था कि हम इस प्रेस कॉन्फ्रेंस में रहेंगे, तो मैं उनका इंतजार कर रहा हूँ। लेकिन मैं शुरुआत के लिए डॉक्टर से बोलता हूँ सब कुछ आप इसके बारे में हम चर्चा से
मंच पर बैठे हुए हमारे साथ सभी लोग, जिनको मैं बहुत दिनों से जानता हूँ, और हमारे दो पुराने, हमको कहें मित्र ही है। एक हमको एक किस्सा याद आ रहा, मैं एक डायस पे बैठा था, उसमें सुल्तान जी बैठे थे, बहुत लोग थे, तो मैंने कहा मित्र, मेरे मित्रों, मैंने कहा, तो सुल्तान जी ने डायस से क्या बोला कि सर आप मित्र नहीं, आप हमारे। तो मैंने ये कहा कि एक समय आता है जब स्टूडेंट जो है वो मित्र होगा। तो आज उसी कैटेगरी में डॉक्टर साहब तो मुझसे सीनियर काफी, और मैं शायद उसके बाद सीनियर लोगों में एक हूँ। और आप लोग मैं तो 5 दिन में लखनऊ में बताऊं तो आपको बड़ा आश्चर्य होगा। मैं पिछली इतवार को 4 बजे लखनऊ छोड़ा था, और कल शायद 4 बजे मैं लखनऊ था। मैं ये तो बहुत बहुत दिनों बालों में लखनऊ के प्रोग्राम काफी पाठक जी जानते हैं, एक्सेप्ट होता है, लेकिन ये कि अब धीरे धीरे जरा उम्र थोड़ा हम लोग भी शांत रहना चाहते हैं, बट स्टिल थिंग्स आर। पाठक जी ने जब याद किया तो हम इनको मना नहीं, क्योंकि पाठक जी पिछले मेरे ख्याल से 10वां है 10वां इनका जो ये कॉन्क्लेव करते हैं। और हमारे सीएमओ साहब भी हमारे बीच में हैं। सीएमओ साहब के बारे में एक बार बता दें कि मैं भी किसी से कह रहा था, सुबह में कोई दोस्त आए थे मुझसे मिलने, तो उनसे कह रहा था कि मैं बहुत ही, मेरा बैकग्राउंड जो फैमिली बैकग्राउंड है वो मंदिरों में, इसमें ऐसा नहीं कि हम पूजा नहीं करते हैं, लेकिन और मुझे भीड़ भाड़ में जाने से बहुत अच्छा नहीं लगता है। पिछली, हाँ, अभी पिछली बार हम आए थे लगभग 1 महीना पहले, क्योंकि डॉक्टर साहब हैं, तो मेरे बेटे भी मेरे साथ थे, तो उन्होंने कहा पापा चलिए मंदिर, और सीएमओ साहब ने जो है इंतजाम कर दिया। हमने कौन है सीएमओ था, तो बोले वो आपके भी हैं और हमारे भी सीनियर हैं, और इनके सौजन्य से मोदी जी ने इतना अच्छा बनवाया हुआ है, पहली बार मैंने देखा। वैसे बनारस आने का तो मौका बहुत लगता है। ये सब एक साइड बातें मैंने कही, लेकिन मैं पाठक जी को धन्यवाद देना चाहता हूँ कि मेरे ख्याल से पाठक जी बहुत पहले हमारे साथ केजीएमसी में इन्होंने एमडी किया था। उस वक्त भी ये होनहार थोड़े लगते थे, कि क्योंकि टीचर को तो अपने स्टूडेंट का हर गुण पता होता है, तो मुझे लगता था ये बंदा कुछ आगे बढ़ेगा, तेज लगता है। वो इन्होंने बिल्कुल प्रूव कर दिया। हमारे ख्याल से जब इनका पहली बार हुआ था 10 साल पहले, समय बीतते हुए तो पता नहीं लगता है कि उन्होंने तब से, मेरे ख्याल से इनके हर उसमें, ये मेरे को अब की बार मेरे को बड़ा मुश्किल हो रहा था, मैं श्रीनगर में था और काफी दिन से बाहर निकला था, फिर भी इनके अनुरोध को मैं ठुकरा नहीं सका। और मैं, क्योंकि ये लगता है एज ए टीचर, एज ए मेंटर, हमें भी लगता है अगर हमारे बच्चे अच्छा काम कर रहे हैं तो उनको किसी में जरूर शामिल होना चाहिए। तो थैंक यू डॉक्टर पाठक फॉर इनवाइटिंग मी वंस अगेन। और पाठक साहब की एक खासियत और है, क्योंकि देखिए ना, रेस्पिरेटरी डिजीजेस मैं हमेशा कहता हूँ, आज से नहीं, मुझे 50 साल हो गए लगभग रेस्पिरेटरी डिजीज में काम करते हुए। मैं सन 76 में आफ्टर कंप्लीटिंग माय एमबीबीएस, मैंने उस वक्त ये सब्जेक्ट ट्यूबरक्लोसिस और चेस्ट डिजीज हुआ करता था, उसमें मैंने एमडी सन 76 में ज्वाइन किया। वो लगभग लगभग अब अभी 26 आएगा तो 50 साल पूरा हो जाएगा। तो मेरा अनुभव ये है कि बहुत ही मतलब स्पेशलिटी बहुत ही नेग्लेक्टेड थी। ना तो पब्लिक को ज्यादा ज्ञान था, डॉक्टर लोग कोई उस ब्रांच में जाना ही नहीं चाहते थे। हमने जब ज्वाइन किया था तो हम आज भी कहते हैं कि हमारी मेरिट केजीएमसी में ऐसी थी, मैं कोई भी सब्जेक्ट ले सकता था, वो तो मेरिट का एडमिशन होते थे और बहुत ही स्ट्रिक्ट मेरिट सिस्टम था। लेकिन जब मैंने सोचा कि मैं ट्यूबरक्लोसिस और चेस्ट डिजीज टीबी के नाम से जाना जाता था, तो आप मानोगे नहीं कि मेरे बैच के कुल लोगों ने कहा, क्या डॉक्टर साहब आपका दिमाग खराब हो गया है तुम्हारा, बैच के लोग कैसे बात करते हैं आप समझ सकते हैं। मतलब उन्होंने गाली भी दी और बातचीत करने में बताया कि तुम अपना जिंदगी क्यों बर्बाद कर रहे हो इसकी बारे विभाग में जाकर। लेकिन हमारे जो बॉस थे उनकी जब हम लेक्चर लेंगे तो उसका फोटो दिखाएंगे, वेरी टफ मैन। वो 5 हमारी एमडी की सीट थी और 5 साल में एक कैंडिडेट को एमडी मिलती थी। तो लोगों ने कहा ये तो जिंदगी बर्बाद हो जाएगी, पता नहीं कितने साल में पाओगे, समझ आ रहा है। गंगा साहब का साहब बड़े बड़े मजदूर यहाँ, वो हर जगह बड़े मजदूर थे। फिर मैंने कहा मैं एक कैलकुलेटेड रिस्क लेता हूँ। मैंने कहा देखो, मैंने डिसाइड कर लिया कि मैं इस चीज का, और मेरा रिस्क ये था कि उस विभाग का मेरी मेरिट और मेरे और नंबर 2 के बीच में एक बहुत लंबा गैप था। और मेरे दिमाग में उस वक्त ये था, मुझे थोड़ा सा पढ़ाने लिखाने में शुरू से ही, आल्दो आई वाज स्टैमरर, मैं खासकर बच्चों को बताता हूँ, अपने पीजी स्टूडेंट को बताता हूँ कि जब मैं इंटरमीडिएट में पढ़ता था तो मैं बहुत बड़ा स्टैमरर था, अपनी अटेंडेंस बोलने में सक्षम नहीं हो पाते थे। हमारे बैच में 2-3 लोग थे, हम क्रिश्चियन कॉलेज लखनऊ के हम पढ़े हुए हैं, तो वहाँ हमारा एक दोस्त ऐसा था जो आजकल तो काफी बड़ा बिजनेसमैन है, उसका नाम था अमृतपाल सिंह। तो आप मान सकते हो उसका पहला नाम आता था पेरेंट में। तो वो मैं देखता था, वो 5 मिनट पहले तैयारी करता था यस सर बोलने के लिए। तो हम भी, लेकिन हम उतने नहीं थे। कहने का मतलब, आप, मैं हमेशा कहता हूँ, उस विभाग को हमने ज्वाइन किया, खासकर हमारे दो हमारे बड़े प्रिय मित्रों में से बैठे हुए हैं, तो मैं थोड़ा इसलिए बताना पसंद करूंगा। हम लोगों ने काफी, हमारे जनरेशन को एक्चुअली काफी मेहनत से करी। तो आज आप, हमें बड़ी खुशी होती है कि रिस्पिरेटरी मेडिसिन और पल्मोनरी मेडिसिन जो भी कह लें इसे, आज बड़े अच्छे मुकाम पर हम देखते हैं, और इससे हमको स्वयं को भी बड़ी खुशी, क्योंकि मेरा उस वक्त यही था। खासकर 2 लोगों को मैं शेयर करना चाहता हूं, अगर मैं क्लिक कर गया तो मैं क्लिक कर पाऊंगा। And exactly God has helped and that has happened। कि हम लोगों ने मतलब टेस्ट, क्योंकि हमारे जो भी टेस्ट में प्राप्त हो सकता भगवान ने लगभग सब। मैं पाठक जी को मैं हमेशा कहता हूँ, फिर कहूँ, ये बहुत पुण्य का काम है, विद्या को बांटना। और हमेशा हम कहते हैं, विद्या देने से ही विद्या बढ़ती है। विद्या को बांटना यानी पब्लिक को एजुकेट करना, डॉक्टरों को एजुकेट करना, ये मेरे जीवन में हमेशा बहुत बड़ा थीम रहा है। हम आज भी करते हैं, और पाठक जी ने यही चीज इस एरिया में, खासकर हमारा जो ये पूर्वी क्षेत्र में कहेंगे, उत्तर प्रदेश का पूर्वी क्षेत्र में रिस्पिरेटरी डिजीजेस को तो कोई जानता ही नहीं था। तो इन्होंने पिछले 10 साल में इतना ज्यादा अवेयरनेस क्रिएट किया है कि आज मुझे कहने में बड़ा फक्र होता है। पाठक की मैम साहब भी बैठी हुई है, विद्या कुमार दिख रही है मुझे? कहाँ? अच्छा, उधर उधर दिख के पूरे परिवार को मैं जानता हूँ। और आज मुझे फक्र के साथ कहना पड़ा कि इन्होंने अपना एक मुकाम बना लिया इतने सालों में, जिसका मुझे आभास जब ये एमडी कर रहे थे तो मैं अक्सर कहता था ये लड़का आगे जाएगा, कुछ करेगा। पता लग जाता है क्योंकि पढ़ने वाले जब आते हैं 3 साल साथ में रहते हैं, बहुत क्लोजली साथ में रहते हैं। पीजी स्टूडेंट तो बहुत क्लोज रहता है और सबके उसके क्रियाकलाप, उसके गुण, उसके अवगुण सब सब जो है लगभग लगभग पता लगते हैं। तो आज मैं पाठक जी को कहता हूँ, इन्होंने इस क्षेत्र में एक रेवोल्यूशन पैदा चाहिए था कि भाई जो सब्जेक्ट के बारे में जो मरीज इतने परेशान होते हैं, क्योंकि मेरा मानना है, मेरा स्वयं का मानना है, जब तक मरीज का ज्ञान नहीं बढ़ेगा तब तक अपनी सही डॉक्टर को नहीं पकड़। मैं अक्सर एक बात कहता हूँ, जब मरीज लोग मेरे पास आते हैं कहते हैं तो नहीं साहब कुछ गड़बड़ है, क्या करें? हमने कहा देखो भाई, दो बातें मैं उनको ट्रेन करता हूँ। हमने कहा देखो, पहले जो बीमारी है उसको समझने की कोशिश करो, पाठक जी उसके लिए इतना कर रहे हैं। मेरी कोशिश एक और करो कि उस एरिया के, उस क्षेत्र के, उस सब्जेक्ट के जो तुम समझते हो अच्छे डॉक्टर हैं उनको पकड़ो, तो आपका भला बिल्कुल होने की संभावना बहुत ज्यादा है। कभी कभी हम देखते हैं सही डॉक्टर के पास नहीं जा पाता है, कि अप्रोच नहीं होती है। हमने इस बात को हमेशा एम्फसाइज किया है कि आप अपने डॉक्टर को सही चुनिए। दूसरी बात मैं और मरीजों को कहता हूँ, आजकल क्या जमाना बहुत बदल रहा है, मरीज भी गूगल से लेकर के डॉक्टर से डॉक्टर लेकर के सर्च करता है। फिर मैं दूसरी बात जो कहता हूँ आपके सामने भी कह रहा हूँ, अगर आपने सही डॉक्टर चूज कर लिया तो हैव ए फेथ इन, बिना फेथ के कुछ नहीं। दुनिया आप जानते हैं फेथ पर चलती। अगर आपको अपने डॉक्टर पर ही विश्वास नहीं तो फिर कैसे ठीक होंगे? तो दो बातें मैं मंत्र में अभी भी मरीजों को पढ़ाता हूँ भाई, अपने अपना बीमारी समझो, अच्छा डॉक्टर ढूंढो और फिर उसके संग फेथफुल स्टिक करो। हमें पूरी उम्मीद है अगर बीमारी ठीक हो सकती है तो वो आप ठीक हो जाए। मैं यहाँ पर एक किस्सा बता के खत्म करना चाहता हूँ। कभी कभी बीमारी नहीं ठीक होती है तो भी मरीज कितना कृतज्ञ होता। मुझे आज केस याद है अपना, हम लोग लंग कैंसर में बहुत पहले से ही तरह से कंकाली, मेरे ख्याल से पीजीआई चंडीगढ़ के बाद हम लोग ने केजीएमसी में पल्मोनरी मेडिसिन में 90 में जब मैं जापान से लौट के आया, आप लोगों की इंफॉर्मेशन के लिए, वहां सब 1989 में मैं 4 महीना रहा हूँ WHO के सौजन्य से। उस वक्त उम्र कम थी, 38 साल की रही होगी। मेडिकल कॉलेज में मैं था, असिस्टेंट प्रोफेसर ही था। तो मैं गया और देखा वहां जिस हॉस्पिटल में मैंने वो साथा थे, अभी की तो जस्ट दे यूज टू से इट इज द ब्रॉम्पटन ऑफ यूके, और है भी। तो वहां दो विभाग अलग अलग थे, मतलब इन द चेस्ट, मैं खास कर बता रहा हूँ, इन द चेस्ट हॉस्पिटल स्मॉल सेल और नॉन स्मॉल सेल लंग कैंसर के दो विभाग थे। आप सोचिए मैं 89 की बात कर रहा हूँ, मेरा दिमाग खुला। मैं आया लौट के 4 महीने बाद, तो मैंने केजीएमसी के बारे में मैं 2 लाइन ये कहना चाहता हूँ, इट हैज ऑलवेज बीन टॉप 5 मेडिकल इंस्टीट्यूशन ऑफ द कंट्री, स्टिल अभी भी 7वें 8वें नंबर पर खड़ा है। मैंने आके अपने पीजीज को भेजा कि मैंने पता लगाओ यहाँ पर क्या लंग कैंसर की एमबीबीएस स्टूडेंट को कोई एक्सपोजर है 1 घंटे का लेक्चर में, या कहीं पे कुछ? तो मेरे हम भी हमारे दोस्त थे सभी फैकल्टी, तो मैं बोले कोई टेस्ट सर्जरी वाले लेते ना मेडिसिन वाले लेते, ना मतलब हम लोग तो लेते ही नहीं थे। हमको तो लोग टीबी का डॉक्टर कहते थे। तो फिर जो है वो हमने कहा नहीं, हमने कहा ठीक है। मैंने सन 90 से, क्योंकि हम डॉक्टरों को ब्लेम करते हैं, क्या ब्लेम करते हैं कि यार इसको देखो कैंसर था, हमारे डॉक्टर ने 6 महीना टीबी की दवाई लिखी और इसका कैंसर स्टेज 4 पहुंच गया, तब वो हमारे पास आ रहा, क्या मतलब? तो मैं हमेशा कहता हूं, अगर हमने अपने स्टूडेंट्स को पढ़ाया नहीं या अपने पब्लिक को अवेयरनेस नहीं क्रिएट किया, तो ये सब तो होना ही है। मैं डॉक्टर साहब अपना 1 घंटे का जो एमसीआई उस वक्त की, अब तो एनएमसी हो गई है, 1 घंटे के जो लेक्चर डिपार्टमेंट को दिया जाता था, 10 या 12 लेक्चर थे उस जमाने, मैंने एक लेक्चर उसमें से काट के और मैंने लंग कैंसर पढ़ाना था। वो जमाना था, तब से हम लोग थोड़ी काउंटोलॉजी में हम लोगों ने काफी काम किया। जब मैंने केजीएमसी 2011 में छोड़ा तो नहीं, मैं डायरेक्टर बना, तो मैं उस वक्त हमारे पास 1000 साल में हम लोग 1000 लंग सेंटर पे बने, एंड माई विजन केम फ्रॉम जापान। हमने कहा वो देखो, वो स्मॉल सेल नाम दो दो हेड ऑफ डिपार्टमेंट थे। स्मॉल सेल वाले से अगर उधर की बात करो तो वो कहता उधर जाओ, कोई पूछता। तो वो उनका डेवलपमेंट ऐसे वर्टिकल हो रहा। अभी तो हम लोग ऑर्गेनिकली डेवलप कर रहे हैं, और हमेशा हम कहते हैं, मेरा ड्रीम होता है, हम तो हमेशा कहते हैं, देखो हम पीजी अपने जो एमडी कर रहे हैं उनको भी कहते थे, हम तुमको एबीसी पढ़ा रहे हैं। एबीसी मन एबीसी ऑफ जस्ट मेडिसिन। अब तुम्हारा काम है तुम एक्स वाई जेड तक पहुंचो, स्काई का लिमिट। तो टीचरों का भी बड़ा रोल होता है, आप कैसे पढ़ाते हैं, क्या उनको सिखाते हैं। और मैं जब फतेह चेस्ट में गया तो मैंने देखा वहां मेनली जो है वो एलर्जी और अस्थमा पे ज्यादा, तो मैंने जाके एक मीटिंग में कहा क्या हमारा फतेह चेस्ट का डॉक्टर एलर्जी अस्थमा का भी डॉक्टर बनेगा सिर्फ? उसे उसे लंग कैंसर नहीं आना चाहिए, उसे टीबी नहीं आना चाहिए, उसको आईएलडी को आईएलडी नहीं आना चाहिए। तो व्हाट आई एम सेइंग, हमारा जो पेशेंट है वो भी सर्वत्र के होना चाहिए। और चारों तरफ ये मैं हमेशा कहता था, शुरू से मेरे माइंड में था कि मैं तो तुम्हें एक जनरल चेस्ट फिजिशियन की हैसियत से पढ़ा रहा हूँ, मोटी मोटी बातें एबीसी सिखा रहा हूँ, आगे तुम्हारा काम है, स्काई इज द लिमिट, यू कैन गो टू लिमिट। तो पाठक जी को पुनः एक बार मैं बधाई देता हूँ, और समय नहीं लूंगा। इन्होंने बहुत तन्मयता से ये कार्यक्रम किया और करते रहे, और मेरी शुभकामनाएं इनके संग, उनके परिवार के, आप लोगों के संग। धन्यवाद।
थैंक यू सर। मैं यहाँ पर कई सारे मीडिया बंधु मीडिया हाउस से आए हुए हैं, और मैं चाहूंगा मेरे एक्सपर्ट हैं, थोड़ा सा लंग डिजीज के बारे में परिचर्चा करेंगे। मैं चाहूंगा कि डॉक्टर राधा सर थोड़ा सा
थैंक यू पाठक साहब। सो बहुत बढ़िया मीटिंग है। आपने सिंगल स्पेशलिटी का अस्पताल खोल के रखा है, बीडीजी। आई वाज लकी टू सी योर सेंटर एंड लकी टू हैव कम टू दिस मीटिंग। तो हम लोग 3 बीमारियों के बारे में, जब हम लोग क्रॉनिक लंग डिजीज बोलते हैं, बहुत सारी बीमारियां हैं। आपने सुना कि एक टाइम था जब हम लोगों का टीबी वाज सपोज्ड टू बी द ओनली डिजीज दैट अ चेस्ट फिजिशियन वुड ट्रीट। अभी तो टाइम बहुत बदल चुका है। क्रॉनिक लंग डिजीज के अंदर में बहुत सारी बीमारियां आ चुकी हैं। उसमें अस्थमा है, सीओपीडी है, आईएलडी है, जिनके बारे में मैं आप बात करूंगा। आपको जानने से अचरज होगा कि हमारे देश में जितने एस्मा के मरीज हैं, वो सारे दुनिया के 12%, 12% ऑफ एस्मैटिक्स थ्रू आउट द वर्ल्ड बिलोंग टू इंडिया। और उस 12% का अगर आप सोचोगे तो हमारे यहाँ सारे दुनिया के जितने अस्थमा रोगियों की मौत होती है उसमें से 43%, यानी कि 100 में से 43 लोगों की मौत अस्थमा से हमारे देश में होती है। तो आप समझ सकते हो अस्थमा कितनी बड़ी प्रॉब्लम है हमारे देश में। इसी तरह का आप सीओपीडी का सोचोगे तो सीओपीडी causes is the second most common of death cause of death in this country. So अगर आप एक नंबर पे कार्डियक डिजीज, हार्ट डिजीज देखते हो, तो 2 नंबर पे सीओपीडी आती है। हमारे देश में सीओपीडी धीरे धीरे बढ़ रही है। ये वेस्टर्न वर्ल्ड में धूम्रपान से होता है, स्मोकिंग इंड्यूस सीओपीडी होती है, हमारे देश में उससे ज्यादा 3 गुना हमारा सीओपीडी होता है, जिसको नॉन स्मोकिंग सीओपीडी कहा जाता है। इस नॉन स्मोकिंग सीओपीडी में चूहे से जो धुआं निकलती है, उससे, एयर पोल्यूशन से, इवन हम लोग तो ये तो पूजा वाली शहर है तो यहाँ पे बोल रहा हूँ, ये जो इंसेंस स्टिक होती है उससे जो धुआं निकलती है, पुजारी लोग जो पूजा करते हैं वहां जो धुआं आता है उससे बहुत ज्यादा सीओपीडी होता है। और हमारे देश में नॉन स्मोकिंग सीओपीडी का नंबर सीओपीडी से 3 गुना ज्यादा है। और हमारे विलेजेस में जो बुढ़िया हमारी माँ जैसे लोग होते हैं, वो लोग जब खाना बनाते हैं, इन सारे लोगों को सीओपीडी रहती है, क्योंकि इतना ज्यादा चूल्हे का इस्तेमाल अभी भी आज भी हमारे देश में होता है। तीसरी बीमारी जो है वो आईएलडी है, तो इंटरस्टिशियल लंग डिजीज। सीओपीडी और अस्थमा में सांस की नली की संकुचन होती है। आईएलडी में लंग्स सिकुड़ के छोटा हो जाता है और ऑक्सीजन कार्बन डाइऑक्साइड एक्सचेंज मुश्किल हो जाती है। So interstitial lung disease is the third category of chronic lung diseases. इसके भी नंबर्स सारे देश में बहुत ज्यादा बढ़ रहे हैं। इसके अंदर बहुत सारी बीमारी आती है जिनके बारे में शायद आप आज सुनोगे या बाद में कभी सुनोगे, but that's the third category of interstitial lung of chronic lung disease, which is interstitial lung disease. एक चौथा कैटेगरी भी आता है जिसको बोलते हैं ब्रोंकिएक्टिसिस। तो ये लंग में गड्ढे हो जाते हैं, वहां पे बार बार इन्फेक्शन होता रहता है, खांसी होती है, बलगम निकलती है, ब्लीडिंग होता है। तो इस ब्रोंकिएक्टिस वाली बीमारी में सारे दुनिया में बहुत ज्यादा रिसर्च हो रहा है, डेवलपमेंट हो रहा है। और हम लोग जानते हैं कि टीबी के बाद फॉलोअप के टाइम पे ये वाली बीमारी हम लोग ज्यादा देखते हैं, उसको पोस्ट टीबी ब्रोंकिएक्टिस कहा जाता है। तो 4 बीमारियों के बारे में हम लोगों ने बात की। 1 नंबर पे अस्थमा, 2 नंबर पे सीओपीडी, तीसरा आईएलडी या इंटरस्टिशियल लंग डिजीज, और चौथा ब्रोंकिएक्टिस। ये हमारा क्रॉनिक रेस्पिरेटरी डिजीज वाली बात है।
थैंक यू सर। सर डॉक्टर त्रिपाठी सर, प्लीज आपका कमेंट्स।
स्वास्थ्य चिकित्सा में सबसे शलाका पुरुष जो जब जहां बोले हम सुनने के लिए अवश्य आते हैं। आपने भी सुना प्रोफेसर डॉक्टर राजेंद्र प्रसाद जी हमारे क्षेत्र के हैं, बड़ी प्रतिष्ठा है इनकी, सरकार के साथ बहुत काम किया इन्होंने। और इस कार्यक्रम के आयोजक डॉक्टर पाठक हमारे बीच, हमारे फर्जंदाबाद चिकित्सालय के वरिष्ठ चिकित्सा अधीक्षक डॉक्टर गुप्ता, और संयोग से आ गए हमारे बीच मुख्य चिकित्सा अधिकारी काशी के चौधरी जी। अभी प्रारंभ में हो रहा था कि आप सब पत्रकार लोग हैं और हम लोग हिंदी भाषा वाले हैं, हिंदी ही बोलनी चाहिए और अच्छी हिंदी भाषा बोल रहे हैं। और विषय हमारा था आपको बताना, जनसाधारण को बताना सांस फूलने के बारे में। इसलिए इसके लिए आपने शब्द कहा, फिर शब्द बंद हो जाता है, उच्चारण नहीं उसका होता है। हम लोग सामान्य चिकित्सा वाले विद्यार्थी हैं, तो हमारे लिए सांस फूलना सांस की बीमारी तो नहीं है, ये हमारे लिए पूरे शरीर की बीमारी, ये मन की बीमारी हो सकती है। छोटे छोटे बच्चे, बच्चियां, महिलाएं हिस्टेरिकल और उनके सांस फूलते हैं। यह रक्तताल्पता की बीमारी हो सकती है। पूरा रक्त का विभाग, डॉक्टर गुप्ता साहब उसके बड़े विशेषज्ञ हैं, इसमें हो सकता है। ये समूचे हृदय की बीमारी हो सकती है परोक्ष रूप में, और कई बार रोगी नहीं जानता कहाँ जाए और फिर बड़ा दोष देता है चिकित्सक को, अस्पताल को, क्योंकि समय बीत जाता है। और हृदय में कभी भी बड़ी गंभीर बीमारी भी हो सकती है, जिसका यह कारण हो मस्तिष्क की बीमारी हो, मन की बीमारी हो, क्लस्ट्रोफोबिया, और अक्सर भीड़ में बड़ा डर लगता है, भीड़ में सांस फूलने लगती है, प्रदूषण की बीमारी हो, और फिर फेफड़े की बीमारी तो आपने सुनी, मांसपेशियों की बीमारी हो, स्नायु की बीमारी हो, जो मांसपेशियों को सूचना देती हो, मायोन्यूरल जंक्शन उसकी बीमारी हो, अमिताभ बच्चन साहब जैसी बीमारी हो, माइस्थीनिया, वहां भी सांस फूले। तो सांस फूलना एक लक्षण है, और ये लक्षण अनंत रोगों की किताब है, वहीं से आप प्रवेश करें, नाक के माध्यम से आप पूरे शरीर में प्रवेश करें और सारे रोगों के ज्ञाता हो जाए, ऐसे ज्ञाता डॉक्टर राजेंद्र प्रसाद जी। हम लोग को चैतन्य रहना चाहिए। सांस फूले तो एक पहली बात प्रारंभिक चिकित्सक से अवश्य लें। अब उसको कहते हैं प्राइमरी हेल्थ केयर प्रोवाइडर, आजकल शब्द बदल दिया गया। अब उसको चिकित्सक, अब उसको हम भेद नहीं करते, हमारे मुख्य चिकित्सा अधिकारी भी ये भी भेद नहीं करते। हमारे लिए चाहे वो नर्स हो, चाहे वो पैरामेडिकल वाला हो, चाहे वो दवा देने वाला फार्मेसी का व्यक्ति हो, कंपाउंडर हो, ये सब हमारी मदद करते हैं। आपको अपने चिकित्सक से एक बार जो, जिसको हम कहते हैं प्राइमरी हेल्थ केयर फिजिशियन, आपके सीएससी पीएससी में, उससे अवश्य मिलना चाहिए। वो बता देगा कि आपको कहाँ की बीमारी है और वो सही जगह निर्दिष्ट कर देगा। का सही चिकित्सक की तलाश होनी चाहिए। जो बीमारी हो वहां जाएं, जो चिकित्सा हो उसे प्राप्त करें और जितनी कही जाए उतनी चिकित्सा अवश्य करें। ऐसा का क्षेत्र है, अभी आप कह रहे थे, हम लोगों ने ये मान लिया था कि ट्यूबरकुलोसिस शायद अब न हो, लेकिन परोक्ष रूप में अभी भी वैसी ही हो, इतनी ही भयावह है। हम लोग अन्य अंगों का देखते हैं, रक्षा पक्ष का देखते हैं, और अभी हमारे चिकित्सा यहाँ पर मुख्य चिकित्सा अधिकारी है, जो सबसे आवश्यक बात है हमारी चेतना में ये आना कि बहुत सारे अब जो टीबी के कीटाणु हो गए, ये अब प्रतिरोधक क्षमता की हमारी बहुत ज्यादा हो गई, ये रेजिस्टेंट है। और दुर्भाग्यवश कैनामाइसिन, ऐसा बात भी है सरकार के विचार में, कैनामाइसिन औषधि अब उपलब्ध सर जगह नहीं है। हम लोग लिखते हैं, सूचना देते हैं चिकित्सा अधिकारी को, मुख्य चिकित्सा अधिकारी को, मुख्य चिकित्सा अधीक्षक को, फिर भी उपलब्धता नहीं होती। टीबी के रोग में दवा हम कई बार छोड़ देते हैं। कई बार अभी भी ये भ्रम है मन में हमारे कि अगर 3 महीना 4 महीना 6 महीना हुआ और दोबारा उसकी जांच नहीं की तो छोड़ देते, बीमारी बार बार हो जाती है, दूसरे अंगों में हो जाती है। और इसलिए जन साधारण को बताना ये हमारा कर्तव्य है। जाने सांस बहुत कागज से फूलते हैं, पर्यावरण उसमें मुख्य है। आयुर्वेद में इसको कहते हैं कि हमारा अपान वायु, प्राण वायु, उदान वायु स्पंदन देता है हृदय का, ये उसको भी संचालित करता है। हृदय पर हमारे हो जाते, उसकी गति में परिवर्तन हो जाता है। तो ये बड़ी कृपा है पाठक जी की, इन्होंने हम सबको बुलाया और आप सब पत्रकारों के दर्शन कराए। आप माध्यम है हमारी बात को पहुंचाने के लिए, सर्व चेतना के लिए। ये बड़ा पूर्ण कार्य है। दोनों कार्य, चिकित्सा करना, चिकित्सा का अध्यापन करना उससे महत्वपूर्ण है, और उसके बाद यह उद्देश्य मन में रख के रखना कि जहां तक संभव हो चिकित्सा पूरी की जाए, दवा कमी न होने पाए। और अब सब चिकित्सा सर्वसुलभ है, कम से कम टीबी की चिकित्सा औषधियां तो साधारण सरकार के पास सर्वत्र उपलब्ध है, और बिना उस चिकित्सा को पूरा किए हुए रोगी को छोड़ने नहीं देते। जितना भी समय हो, कम समय हो, ज्यादा चलता है। एक बार बनाने का ज्यादा धन्यवाद।
धन्यवाद सर। सर प्रोफेसर केके गुप्ता सर जो एग्जीक्यूटिव में भी है, वो अपने उच्च को शेयर करने दो के सामने।
जनों के सामने बोल रहा हूँ, प्रोफेसर वागेश्वर और प्रोफेसर राजेश, इन्होंने जो बातें कही वो बहुत मुख्य है, लेकिन छोटी सी बात में कह करके अपने वाणी में विराम दूंगा कि इंडोर और आउटडोर दोनों जगह हमारे सामने एलर्जेंस हैं, हमारे केमिकल्स हैं, जो कि हमारी श्वसन प्रक्रिया में कुछ न कुछ इफेक्ट डालते हैं, जिसके चलते हम लोगों के शरीर में बहुत सारी व्याधियां हुई। अभी रिसेंट पास में आपने कोविड की महामारी को देखा ही था, जिसने कि हमारी श्वसन प्रणाली को भी अफेक्ट किया। ये मेरा जनमानस को एक ही बात कहना है कि अगर आपकी सांस फूल रही है तो आप उसको हमेशा ये ना समझे कि ये एक साधारण बीमारी है और इसको आसानी से हम ठीक कर लेंगे, या हम एक ओवर द काउंटर जाकर के कोई दवा ले लें और उसको जो है चालू करके अपनी सांस को ठीक कर लें। ये ध्यान देने योग्य है जनमानस के लिए कि सांस फूलना कई प्रक्रियाओं का कंपोनेंट हो सकता है, जैसे कि वो हार्ट का बीमारी हो, चाहे वो लंग्स की बीमारी हो, और चाहे वो कोई और बीमारी जो हमारे तंत्र होते हैं दूसरे शरीर के, चाहे वो एनीमिया हो, उसमें भी ऐसा हो सकता है। कुछ बातें ऐसी है कि सांस की बीमारी खाली लंग से संबंध नहीं है। हमारा शरीर का जो श्वसन तंत्र है वो नाक से शुरू होता है, इसलिए नाक में भी संबंधित बीमारियां बहुत सारी हैं और उनका भी ध्यान देना बहुत जरूरी है, और वो भी सांस फूलने का कारण बनती है। इसी तरीके से कुछ लोगों को बहुत ही खांसी आती रहती है, तो लोग ये कह देते हैं कि साहब वो टीबी हो गई है। जरूरी नहीं है। नाक के अंदर अगर बीमारी है वो भी जो है ड्राई कफ का कारण बनता है, और वो हम सब विशेषज्ञ डॉक्टर जानते हैं। तो मेरा सिर्फ जनमानस से ये कहना है कि आपको अगर खांसी है या सांस फूल रही है या मुंह से खून आ रहा है, तो विशेषज्ञ डॉक्टर से एक बार सलाह ले करके और अपने आप ही उनसे सलाह लेके ही इलाज करें, स्वतः इलाज करने की कोशिश ना करें। केमिकल्स चारों तरफ है, चाहे आप घर में बैठे चाहे बाहर निकले सड़क पे, सब जगह केमिकल एलर्जन है। और अभी हम लोग के जो गवर्नमेंट की एक नई विधा सोच में आ रही है सीपीआरएन के तहत, कि जिसमें सर केमिकल वॉरफेयर, रेडिएशन एंड ऑल दिस, इसके लिए एक नई यूनिट आने का प्रावधान गवर्नमेंट ऑफ इंडिया बना रही है। और उसके अंदर हम लोग से भी मांगा गया है कि क्या आप ये फैसिलिटी अपने यहाँ डेवलप कर सकते हैं, कि उसकी रिक्वायरमेंट कुछ ऐसी है कि हम लोग अभी उसमें संशय में पड़े हुए हैं। लेकिन ये भी एक इस तरह की सिचुएशन है जिसके लिए मैं आगे चल के, क्योंकि कोई भी तरीके का वारफेयर हो सकता है, बायोलॉजिकल वारफेयर होता है, और सबसे श्वसन तंत्र को ही। तो इन सभी बातों के साथ में, इसी चेतना के साथ में मैं अपने वाणी को नाम देता हूँ।
थैंक यू सर, थैंक यू। डॉक्टर मैक्स हॉस्पिटल के एक्सपर्ट हैं, और जो आप परिचर्चा में चेस्ट में जो गांठ है उसके बारे में थोड़ी सी जानकारी देनी है।
तो जैसे कि सर ने कहा कि ये टेक्नोलॉजी में जो ग्रोथ है, वो जो चेंजेस आए हैं पिछले कुछ 10-15 ईयर्स में, वो काफी सिग्निफिकेंट है। तो आज की मेरे को लगता है ये जो दशक है ये डायग्नोसिस का है। वो जमाना जिसमें अंदाजे में दवाई दिया जाता है या फिर डायग्नोसिस प्रॉपर नहीं होता था, उससे बहुत आगे अब टेक्नोलॉजी या मेडिसिन मूव कर चुकी है। अब सटीक डायग्नोसिस पकड़ना, हर बीमारी को डिफरेंशिएट करना, एक एग्जैक्ट डायग्नोसिस बनना, ये बहुत जरूरी हो चुका है। हमारे मेडिकल ऑन्कोलॉजिस्ट दोस्त तो बहुत कॉमनली कहते हैं कि उनके पास जो लंग कैंसर के मरीज आते हैं उसमें से कम 30% ने कभी ना कभी किसी ना किसी तरीके से उसके लिए टीबी की दवाई अंदाजे में खा रखी होती है। तो अंदाजे से आगे बढ़ जाना ही मेरे को लगता है कि करंट ट्रीटमेंट का इम्पोर्टेंट हिस्सा है। तो मुझे लगता है कि डायग्नोसिस प्रॉपर बनना, जल्दी बनना, चाहे वो मरीज किसी छोटे शहर में हो चाहे किसी बड़े शहर में हो, वही सबसे इम्पोर्टेंट होगा, ताकि आगे तक का ट्रीटमेंट सुगम और सही हो सके।
थैंक यू सर, थैंक यू। डॉक्टर बी तोमर सर हैं, मेरठ से हैं,
थैंक यू डॉक्टर पाठक। मैं सभी का पत्रकारों का अभिनंदन करता हूँ, और मंच पर सभी जो चिकित्सक हैं, खासतौर से डॉक्टर राजेंद्र प्रसाद सर जो मेरे एग्जामिनर भी हैं पीजी में, उनका चरण स्पर्श करता हूँ। अभी जिक्र किया श्वसन के बारे में, सांस फूलने के बारे में जो चर्चा है, सभी ने बता दिया कि सांस केवल फेफड़ों से संबंधित ही नहीं, हृदय रोग से भी हो सकती है, खून की कमी से हो सकती है, गुर्दा फेल होने से हो सकती है, और फेफड़े सिकुड़ने से, जैसे कोविड में आपने सुना। ये तमाम कारण हमारे सांस फूलने के हो सकते हैं। लेकिन मैं जनमानस को आपके माध्यम से सचेत करना चाहूंगा कि मुख्य जो कारण, जैसे डॉक्टर धर ने बताया, सीओपीडी और दमा ऐसी बीमारी है जो सन 90 में WHO ने एक विश्लेषण किया पूरे विश्व में। ये इससे होने वाली मृत्यु की जो दर है, मैं मानूं संसार की जो मुख्य 10 टॉप जो मृत्यु करने वाली बीमारियां थी उनमें 6 नंबर पर थी। और ये माना WHO ने कि 2020 तक शायद ये बीमारी तीसरे नंबर पे आ जाए। लेकिन कई वर्ष पहले ही तीसरे स्थान पर 2016 में लंदन में लैंसेट जर्नल छपता है, उसमें आ चुकी है सबसे घातक बीमारियों में। और अभी डॉक्टर धर ने बताया कि दूसरे भारत में तो ये दूसरे नंबर की बीमारी है, इससे ऊपर केवल हार्ट अटैक और जो स्ट्रोक्स होते हैं उसकी वजह से मृत्यु होती है। तो इसका मुख्य कारण वातावरण प्रदूषण, और जैसा कि डॉक्टर गुप्ता ने बताया कि इंडोर पोल्यूशन, आप कहीं भी रहते हो, आप ऑफिस में रहते हैं, घर में रहते हैं, बाहर का प्रदूषण तो है ही, लेकिन अंदर का प्रदूषण 18 घंटे व्यक्ति अंदर रहता है, उसके प्रदूषण से जो कारपेट्स आपने बिछा रखे हैं, जो आपने जो पॉलिश कर रखी है अंदर, जो आपने प्लाईवुड लगा रखा है, इससे जो एलर्जेंस निकलते हैं वो बहुत घातक हैं और जो दमा रोग कर सकते हैं, खासतौर से बच्चों में। तो कुछ लक्षण मैं बताना चाहूंगा जो खास हैं कि अगर कोई बच्चे को या बड़ों को मौसम परिवर्तन पर सांस फूले, सींची जैसी आवाज आए, खांसी आए, तो कई बार हम बच्चों को कह देते हैं कि तो निमोनिया है, बचपन में निमोनिया होता या एलर्जी है। हम उसको दमा घोषित नहीं करते, कि हम समझते हैं कि अगर दमा घोषित किया तो एक बहुत बड़ा हमने अभिशाप हो जाएगा उस बच्चे के साथ या उस व्यक्ति के साथ जिसको दमा रोग है। तो जनमानस से हमें इसको इस अभिशाप को मिटाना है कि दमा रोग बिल्कुल ठीक होने वाली बीमारी है, कंट्रोल होने वाली बीमारी है, उसका इलाज भी इन्हेलर है। कई बार हम वर्षों तक दवाइयां लेते रहते हैं, इसके साइड इफेक्ट होते हैं। इन्हेलर के प्रति एक्सेप्टेंस लाना कि इन्हेलर का आधुनिक इलाज है और इसको बड़े बड़े खिलाड़ियों ने विश्व के इसको कंट्रोल में किया है, आप भी कर सकते हैं। तो कुछ ऐसी बीमारियां जैसे दमा, यूपीडी और जो बात आई हमारी प्रदूषण के बारे में, क्योंकि काशी में तो घर घर में हवन होता है। एक बात जरूर कहना चाहूंगा कि हवन अगर कंप्लीट उसका कंबस्शन ना हो, वह तब उठेगा अगर हमारी संविधा सूखी ना हो, अगर उसका अनुपात सामग्री का और घी का सही ना हो, हवन कुंड का साइज सही ना हो, हम सही जगह बैठ के अगर हवन नहीं कर रहे हैं तो वो धुआं करेगा उनको, जबकि जो केमिकल्स और जो वेपर्स निकलते हैं, जो फॉर्मल्डिहाइड निकलते हैं, तमाम तरह की वो वातावरण को शुद्ध करते हैं, निरोग करते हैं। तो हमें सीखना पड़ेगा कि हमें हवन यज्ञ कैसे कर रहे हैं प्रतिदिन, जिससे कि कंप्लीट कंबस्शन हो, घी और जो सामग्री उच्च क्वालिटी की हो, संविदा सुखी हो और इसका मिश्रण लेंगे। तो मैं बहुत बहुत एक बार फिर बधाई देता हूँ पाठक को और आप सभी को इस कॉन्फ्रेंस के लिए धन्यवाद।
थैंक यू सर, थैंक यू सर। हमारे बीच हमारे मुख्य अतिथि संगीत पर चिकित्सक जी हैं और सीएमओ भी हैं। मैं चाहूंगा कि वो अपने दो सर
मंच पर मेरे गुरु प्रोफेसर राजेंद्र प्रसाद और साइड आप सबने जो रेस्पिरेटरी इलनेस के बारे में जो डिटेल बताया उसमें मैं ऐड कुछ नहीं कर सकता। मैं थोड़ा सा अपना जो हमारा माननीय प्रधानमंत्री जी का टीबी बुक अभियान है उसके बारे में, जो वाराणसी की स्टेटस के बारे में जरूर जिक्र करना चाहूंगा। अब ये डिजीज कितनी ज्यादा अब प्रेवलेंट से अब कम होकर खत्म करने की स्थिति है, तो उसमें सभी का मैं सहयोग भी चाहूंगा। भारत सरकार और प्रदेश सरकार इसमें बहुत ज्यादा इस समय बहुत ज्यादा तत्पर है और अभी अभी नया अभियान यही से ये मार्च के महीने में माननीय प्रधानमंत्री जी ने यही से लॉन्च किया था रुद्राक्ष टीबी मुक्त भारत अभियान। इसमें हमारे जो कम्युनिटी हेल्थ ऑफिसर्स हैं जो 5,000 की पॉपुलेशन पे टारगेट हैं, उनके स्तर पर गांव में जाकर ग्राम सभा ग्राम प्रधान के माध्यम से इनकी सर्च की जा रही, उनके सैंपल ट्रांसफर्स के कारण और टेली मेडिसिन के द्वारा उनको जिले के अच्छे डॉक्टर से कंसल्ट भी किया जा रहा है और दवा भी उनके घर तक दी जा रही है। तो भारत सरकार और इस पर इतना ज्यादा कार्य कर रही है और मेरा अनुभव सभी चिकित्सकों से है जो हमारे साथ इसमें है कि ज्यादा से ज्यादा हम नोटिफाई करें मरीजों को, जितना ज्यादा हम नोटिफाई करें। और सौभाग्य से ये है कि धीरे धीरे यहाँ तक नंबर उसका कम भी रहा, पर साथ साथ हमें ये भी चेतन होना है कि जो हमारे रजिस्टर्ड ट्यूबरकुलोसिस है उनकी संख्या आगे ना बढ़े और स्टेप्स हम जो भी गवर्नमेंट के होते हैं हम लोग करते हैं। कहने का मतलब है कि जागरूकता एक टीवी के माध्यम विभिन्न माध्यम से हम लोग पहुंचाने की कोशिश कर रहे हैं और फ्री सर्विसेज में हम टीबी को मुक्त करने के लिए कर रहे हैं। साथ साथ ढेर सारी अभी बीमारियों के बारे में सभी ने जिक्र किया है और मैं ये भी बताना चाहूंगा कि हमारा CBRN लैब देश में 12 जगह पे, जिसमें वाराणसी में अकेले उत्तर प्रदेश का वो PHU में आप लोगों की वजह से वहां पे हासिल हो जाएगा। ये अपने आप में एक केमिकल बायोलॉजिकल न्यूक्लियर सबके बहुत बड़ा एक लैब हो जाएगा यहाँ पे, जो केमिकल पॉल्यूशन है उनके बारे में स्टडी होगी, उनको कैसे इंटरेक्ट करना हो सब होंगे। तो ये एक उपलब्धियां हैं वाराणसी के लिए और कोशिश सभी से मिलकर चाहता हूँ कि हम जो भी गवर्नमेंट के प्रोग्राम्स आपके साथ शेयर करते हैं उससे हमें सपोर्ट करें और इसको जैसे जैसे हम अपने देश को टीबी मुक्त करें। बाकी कोई सारी डिजीज के बारे में ढेर सारे कुछ जिक्र होगा, मैं आपको ज्यादा समय नहीं लूंगा। और हम आज मौका है बहुत अच्छे अच्छे लर्नर्स आपको मैं सुन चुका हूँ और स्पेशली आज आपको सुनने के लिए मैं आया हूँ। इट्स अ प्लेजर टू लिसन ऑल ऑफ यू और अपनी वाणी को ध्यान रखें। धन्यवाद।
बहुत बहुत धन्यवाद सर। और मैं इस मीडिया की जो पीपल्स है, अगर कोई सवाल है किसी का तो माइक से मैं दे रहा हूँ, आप उसको चाह के पूछ सकते हैं विष्णु। मीडिया बंधु से अनुरोध करेंगे, इनका अगर कोई सवाल हो तो कृपया आप हमारे पूछ सकते हैं। माइक लेना हो तो आप ले सकते
डॉक्टर साहब, जैसे कि अभी आप थोड़ी देर पहले बताया कि घर में जो प्लाईवुड है, जो फर्नीचर्स है, उसमें जो माइका लगे रहते हैं, तो आजकल हमारे जितने भी घर जो बन रहे हैं और जिसमें इंटीरियर हो रहे हैं, उसमें इस तरह के माइका और इस तरह की पॉलिश लगातार हो रही है, क्योंकि उसके बिना लोगों को घर पसंद नहीं आ रहा है, चाहे बच्चों का कमरा हो चाहे अपना खुद का कमरा हो। तो इससे क्या किया जाए? ऐसा उसमें किस तरह की कोई मेडिसिन है या फिर किस तरह का प्रोटेक्शन है कि हमारे जो बच्चे हैं वो इस चीज से बच जाए?
देखिए, अब जैसे आपने बताया, अब हम पुराने इस पे पद्धति पे आपने सुना होगा, अपने जो हमारे शास्त्र जी हैं, कवि जो हैं, उनका आप घर जाकर देखिए, उनकी जो दीवारें हैं ना, जो गोबर की लिपि हुई खुदाई से ही बना रखा है उन्होंने घर अपना जो घर बनाया है। तो हम उसी पे जाएंगे। आज जो चीजें हैं, तो इसमें रेडियो एक्टिविटी जो हमारे अंदर से जो हम तहखाने बनाते हैं, बेसमेंट्स में बहुत प्रेफर करते हैं, ऑफिस को हम बेसमेंट में बनाएंगे। तो उसमें से जो गैसेस लीक होती है, पत्थरों के, वो गैस है, रेडॉन गैस है, इतनी आप क्या करते हैं, मैं तो शाकाहारी हूँ, हमने तो जीवन भर अंडा भी नहीं खाया, हमने तो मांस भी नहीं, हमने स्मोकिंग भी नहीं, हम तो ये भी नहीं करते, कैंसर कैसे हो गया? तो ये सब तमाम कारण है जो कार्सिनोजेनिक्स है, ना केवल एलर्जी करते हैं, ये कार्सिनोजेनिक्स है जो आप यहाँ पेंट्स यूज करते हैं, लगातार उत्सर्जन होता है गैसेस का, केमिकल्स का। तो आप ऐसे पेंट्स उपलब्ध हो चुके हैं जिनमें कि ये केमिकल्स आपको पहले ऐड देखोगे आपने, इस टाइप के आते हैं कि हमारा पेंट्स इस टाइप के हैं। तो इसको बदलना होगा, घर में कारपेट्स नहीं बिछाने, उनसे एलर्जी में माइट्स पैदा होती है, छोटे बच्चों को एलर्जी होती है। सिक बिल्डिंग सिंड्रोम एक नाम होता है, सिक बिल्डिंग सिंड्रोम। कि आप जाएंगे कि डॉक्टर साहब मैं तो जाता हूँ अपने ऑफिस में, वहां जाती हेडेक हो जाता है, शरीर में दर्द होता है, मन ही नहीं लगता, दिन चलता है। तो कई बार ऐसी बिल्डिंग्स में जहाँ तेज लाइट हो, फ्लिकरिंग लाइट हो, साउंड अजीब सी आ रही हो, एसी की आवाज आ रही है, गुनगुना आवाज आपके कंप्यूटर की आ रही है, फ्रिज की आवाज आ रही है, तो तमाम मिलके सिक बिल्डिंग सिंड्रोम बनाते हैं, जिससे में दर्द पैदा, चिड़चिड़ापन, बीपी बढ़ना, एनर्जी होना, स्टफी होता, छींके आना नाक बहन। तो ये सब बदलना होगा। ऐसा ना हो कि पूरे की रोज के अंदर तक आए, तमाम पूरे दिन 20 आपके हवा का आवागमन अच्छा हो उसके अंदर। और एक ही जो फ्लैट का सिस्टम है बदलना पड़ेगा, किचन की भी धुआं उसके अंदर आ रहा है, आपका इन्वर्टर की बैटरी रखी है उसका भी धुआं अंदर आ रहा है। तो हमें ये सब बदलना सोचना पड़ेगा सबसे पहले कि हमारे घर कैसे हैं। तो ये एक बड़ा अच्छा मतलब बड़ा इम्पोर्टेंट विषय है।
थैंक यू।
तो आपने सवाल बहुत अच्छा किया, और मैं एक थोड़ा सा और आगे देखिए ना, जीवन में हम कैसे रहते हैं, कैसे क्या खाते हैं, कैसे खाते हैं, हमारी जीवन शैली क्या है। अभी डॉक्टर साहब ने बहुत अच्छी बातें बताई, सब वो हमारे रोगों के जनक, सारे रोग ऐसे ही पैदा हो रहे हैं। तो हमारा भी मानना ये है, हमें सोसाइटी में बहुत अवेयरनेस पैदा करना पड़ेगा कि कहाँ किस चीज से कैसे क्या परेशानी होती है। अभी मुझे याद है, अभी डॉक्टर बता रहे थे ये कारपेट की बात है, मैं सबसे मेरे ख्याल से जब ये इंटरनेशनल जो टर्मिनल 3 जब नया नया बना था, तो मैं शायद बैंकॉक गया था तो पुराने टर्मिनल से गया था, और जब मैं वहां से लौटा तो मुझे कहा गया अब डॉक्टर साहब नया टर्मिनल बन गया, वहां पे आपको वहां फ्लाइट रुकेगी। तो मैंने देखा चारों तरफ कारपेट ही कारपेट लगा हुआ। मैंने उस वक्त मेरे मन में ये विचार करके मैंने कंप्लेंट भी डाली कि ये जो कारपेट आज लगवा रहे हो, कुछ दिनों में इसको आपको हटाना पड़ेगा, बदलना पड़ेगा। मुझे बड़ी खुशी हुई, कल ही मैं टर्मिनल 3 पर रोज ही आ जा रहे हैं, अब बहुत से कारपेट वहां से हटा दिए गए। लेकिन ना, जो अवेयरनेस क्रिएट करने, और उसमें आप जो हमारे पत्रकार बंधु और बहने हैं, उनका बहुत बड़ा अहम रोल है। मैं एक बात और कहना चाहूंगा पत्रकारों से, खासकर बनारस से, आप लोग डॉक्टर साहब हार्ट वाले बैठे हैं, के गुप्ता भी बैठे हुए हैं, नथिंग अगेंस्ट मी। आप हार्ट की बीमारियों का खूब अखबार में लिखते हो, और चेस्ट की, ये हमने कई जगह हम कहते हैं, चेस्ट की बीमारियों के बारे में लिखती तो हो, ऐसा नहीं लिखते हो, लेकिन कम लिखते हो। और आपने अभी सुना सबके जरिए कि चेस्ट की बीमारी हार्ट के लगभग लगभग साथ ही चल रही है, अगर जितनी वो है तो, लेकिन इन सब बीमारियों के हम स्वयं जनक हैं, हमारी सोसाइटी जनक है। हम कैसे रहेंगे, ये चीजें बताना बहुत जरूरी है। और आपका रोल भी, मैं हमेशा कहता हूँ, तब तो अरे हम लोग तो किसको, एक मरीज को बता देंगे, 10 को बता देंगे, एक गाँव बता देंगे, आप अखबार में निकालेंगे तो बता देंगे तो पढ़ेंगे। तो आपका बहुत महत्वपूर्ण है। और मेरी रिक्वेस्ट यही है, जो चेस्ट डिजीज से संबंधित जितनी भी खबरें हैं उनको भी महत्व दीजिए, और जिससे हमारी जनता उससे ज्यादा।
बहुत बहुत धन्यवाद सर। जैसा कि हम लोगों ने बताया कि बेबी जी हर 3 महीने पे त्रैमासिक पत्रिका लॉन्च करती है, तो हम अपने सभी चीफ गेस्ट से अनुरोध करेंगे कि बी टाइम्स नामक जो पत्रिका है उसका विमोचन करें। इस बार का जो टॉपिक है डिस्निया है, साधारण भाषा में कहें तो सांस छोड़ना। इस पत्रिका को अगर आप ध्यान से देखेंगे तो आप पाएंगे कि इसमें एक साधारण भाषा में एक आम जनता को क्या मैसेज दिया जा सके, उसको विशेष ध्यान रखा गया है। इसके साथ साथ केस स्टडीज भी हैं, जो हमारे जनरल प्रैक्टिशनर्स भी इसको देख करके गो थ्रू कर सकते हैं। बहुत बहुत धन्यवाद। तो आपको बाइक लेना होगा आपने। थैंक यू सर। अब हम चाहेंगे कि हम इस उद्घाटन इस प्रोग्राम में करने के लिए सभी से अनुरोध करूंगा, प्लीज स्टार्ट। ये अपना पीछे
होता है और आपको बॉडी में इचिंग हो रही है, आपके आंखों में से पानी बार बार गिर रहा है, तो हो सकता है एलर्जी के लक्षण हो। ठीक है, एलर्जी को लोग अनदेखा करते हैं। अक्सर कई सारे मार्केट में दवाइयां, सिट्रीजिन और कई सारी ऐसी दवाइयां लोग सेवन कर लेते हैं, जिसके कारण उनको थोड़ी देर के लिए तो राहत मिल, लेकिन इसका जो छुटकारा मिलना चाहिए वो नहीं हो पाता। तो ब्रेथिजी हॉस्पिटल इसी पर्पस के लिए है, इसी उद्देश्य है कि आपकी एलर्जी से छुटकारा मिल सके। इसके लिए हम लोग एलर्जी टेस्ट करते हैं, जिसमें पता लगा सकते हैं कि किस व्यक्ति को किस चीज से एलर्जी है, और उसके रिगार्डिंग उसका जो भी अवॉइडेंस हो सकता है आप उससे बच सकते हैं। और कुछ चीजें ऐसी होती हैं, एयर एलर्जीज होती हैं, जिसके कारण आप छुटकारा नहीं ले सकते। उसके लिए हम लोग वैक्सीनेशन इम्यूनोथेरेपी प्लान करते हैं। ब्रेथिजी हॉस्पिटल इम्यूनोथेरेपी में अभी तक
सभी से अनुरोध है कि कृपया हाईटी रूम में चले और वहां पर हाईटी लेने के बाद हम 10 मिनट के अंदर सेशन शुरू करें, चूंकि ऑलरेडी हम सेशन लेट चल रहे हैं। पहला सेशन है रसूल मित्तल सर का, डॉक्टर स्वप्निल पाठक का। मैं चाहूंगा कि हाईटी की 10 मिनट के ब्रेक के बाद कृपया यहाँ पर हो रहा है, जिससे कि हम सेशन को स्टार्ट कर सकें। धन्यवाद।
एलर्जी की संभावना होगी। भविष्य में 3 से 5 साल के बीच में ये अस्थमा में कन्वर्ट हो जाएगा, जिसमें हम सांस की एलर्जी करते हैं, और सांस की एलर्जी होने पर इसका छुटकारा लेना बहुत मुश्किल होता है। कई ऐसे व्यक्ति हैं जो इनहेलर पर चले जाते हैं एलर्जी का। तो आप
सेशन फर्स्ट के जो चेयरपर्सन है हमारे साथ डॉक्टर मोहित भाटिया, डॉक्टर बजरंग तोमर जी हैं। मैं चाहूंगा कि स्पीकर के बाद इस हाईटी के बाद इस सेशन को हैंडल करेंगे। धन्यवाद।
नमस्कार दोस्तों, आज हमारे साथ हैं जो कि नमस्कार। थोड़ा सा हम लोग जानना चाहेंगे कि अस्थमा बेसिकली होता क्या है।
अस्थमा में सांस की नली सिकुड़ जाती है, सांस का रास्ता सकरा हो जाता है। इसके कई सारे कारण हो सकते हैं। आपके आसपास डस्टिंग हो रही है, घर में चौक लग रहे हैं, या कोल्ड एयर है, या स्मोक है, या पटाखे के धुएं हैं। कई सारे फैक्टर होते हैं जिसके कारण ये अस्थमा की सांस में जो सिकुड़ने से, सांस का रास्ता सकरा होने से ऑक्सीजन की उच्च मात्रा पहुंचती है लेकिन वो नहीं पहुंच पाती, और जिसके कारण सांस लेने में तकलीफ होती है। ऐसे मरीजों को खासकर हिदायत दी जाती है कि अगर ऐसी इमरजेंसी आती है तो आप बिल्कुल घबराएं नहीं, और आपके पास सिमिलर मेडिसिन है या निर्वाजन मेडिसिन है, उसका तुरंत सेवन करें और निकटतम चिकित्सक से संपर्क करें। ब्रेथिजी हॉस्पिटल स्पेशली अस्थमा के मरीजों के लिए बनाया गया है। यहाँ पर अस्थमा के मरीजों की जांच के लिए एक व्यक्ति मशीन है, जिसमें आप एक जांच करके पता लगा सकते हो किसी को अस्थमा है। कई सारी ऐसी बीमारियां होती है जो अस्थमा से मतलब होती है, लेकिन जांच से ही पता चलता है कि वो अस्थमा है। बच्चों में इसका प्रेवलेंस ज्यादा होता है, और सोसाइटी में इसका प्रेवलेंस है 15 से 20% है। उसमें हर 100 व्यक्ति जो है अस्थमा से ग्रसित है। तो आपको इस चीज को ध्यान रखने की जरूरत है कि अगर ऐसे अटैक आती है तो आपको संपर्क करें और सांस की दुर्घटनाओं से बचें।
आइए अब जानते हैं अस्थमा और सीओपीडी में मुख्यतः क्या अंतर होता है। विश्वास सर, ये अस्थमा और सीओपीडी, आजकल सीओपीडी बहुत नाम तेजी से सुना जा रहा है, आखिर होता क्या है अस्थमा सीओपीडी का अंतर क्या होता है।
देखिए, अस्थमा खासकर इनकी सांस की बीमारी है, सीओपीडी की सांस की बीमारी है। सीओपीडी को हम लोग क्रोनिक डिजीज कहते हैं, जिसमें आम भाषा में दमा का रहता है। ये खासकर ओल्ड एज में व्यक्तियों में मिलती है, खासकर 40 के ऊपर जो क्रॉस करते हैं, जो स्मोकिंग करते हैं या पॉल्यूशन में रहते हैं, खुले बड़े वातावरण में काम करते हैं, उसके कारण ये बीमारी होती है, सीओपीडी करते हैं। और इसमें सांस की नली सिकुड़ने के साथ साथ इसमें कफ दर्दों की शिकायत बन जाती है, कफ जम जाता है, और सांस की नली इतनी कमजोर हो जाती है कि उसमें एयर का आना जाना बहुत होगा। इसकी भी जांच हम लोग कमजोर से टेस्ट मशीन से करते हैं। कई सारे और टेक्निक होती है जिसके द्वारा पता लगे कि अस्थमा है या सीओपीडी, और उसके हिसाब से इलाज का प्रबंधन किया जाता है। लेकिन इसके लिए स्पेशलिस्ट यहाँ पर सीओपीडी के मरीजों को खासकर जानकारी और इलाज के बारे में जानकारी दी जाती है, और इमरजेंसी में इसका ट्रीटमेंट तुरंत किया जाता है। और आप अगर किसी गूगल या किसी सर्च करेंगे तो सीओपीडी डॉक्टर आप सर्च करेंगे तो you will see the Refugee Hospital Varanasi. You can search also in the Google for the patient care of the city. तो हम यहाँ पर कम्युनिटी रिहेबिलिटेशन का भी काम करते हैं, जिसमें सांस को कैसी एक्सरसाइज होनी चाहिए जिससे प्रॉब्लम को सॉल्व कर सकते हैं। क्रोनिक पेशेंट्स में हम लोग ऑक्सीजन थेरेपी और कई सारी टेक्निक होती है जिस पेशेंट को इस तरह की बीमारी से छुटकारा दिलाने की कोशिश करते हैं। स्मोकिंग में कई सारी भ्रांतियां हैं और ये देखा गया कि कुछ लोग कहते हैं कि मैं 1 सिगरेट पीता हूँ, कोई कहता है मैं 10 सिगरेट पीता हूँ, मेरे लिए नुकसानदायक ज्यादा होगा, मैं फिल्टर से स्मोक पीता हूँ और नॉर्मल स्मोक पीता हूँ। ये स्मोक है आपके लंग्स की स्थिति दोनों खराब करता है। हाँ, वो स्मोकर से उनकी लंग्स की स्थिति जो 5 साल में खराब होने वाली है वो 10 साल में खराब होगी, लेकिन खराब जरूर होगी। तो आप ये मत पाइए कि मैं 21 सिगरेट पिया, आधा सिगरेट पिया, 2 पिया, तो हमारा जो दूसरा व्यक्ति 10 पी रहा है, वो जल्दी गंभीर अवस्था में जा सकता है और उसकी स्थिति बेहतर रहेंगे, लेकिन चीज को बदलना पड़ेगा। तो स्मोकिंग बिल्कुल बंद करें और उसका परहेज करें और लोगों को हिदायत दें कि स्मोकिंग है।
नमस्कार दोस्तों, क्या आपको पता है विश्व में ट्यूबरक्लोसिस के पेशेंट कितने हैं और उसमें से भी भारत में कितने हैं? मैं आपको बताता हूं, ट्यूबरक्लोसिस के पेशेंट पूरे विश्व में जितने हैं उसके 25% भारत में। जी हाँ, ये अपने आप में एक बहुत बड़ी बात है। आइए इसके बारे में विस्तृत जानकारी लेते हैं डॉक्टर एस के पाठक से, जो कि टीबी रोग विशेषज्ञ हैं। नमस्कार सर। सर, थोड़ा सा टीबी के बारे में हमारे दर्शकों को आप बताएं कि आखिर में ऐसा क्या है कि हमारे देश में 25% की आबादी टोटल ट्यूबरक्लोसिस वाली हमारे देश में।
ट्यूबरक्लोसिस काफी पुरानी बीमारी है और इसका इलाज तभी संभव हुआ जब कई सारी मेडिसिन जो हमारे 1950 के बाद कई सारी ऐसी आई जिसमें हमने इलाज शुरू किया और कई सारे बच्चों को बचाया गया। लेकिन इसके पहले टीबी के मरीज मृत घोषित हो जाते थे, उनके इलाज कार्य नहीं हो पाते, कोई दवा नहीं थी विकसित। लेकिन अब ऐसी टेक्निक, ऐसी दवाइयां भी मार्केट में अवेलेबल हो गई हैं जिससे आप बिल्कुल बीमारी से छुटकारा ले सकते हैं। कुछ ज्ञान की कमी, कुछ नॉलेज और मेडिकल एजुकेशन के कारण सोसाइटी में बहुत सारी भ्रांतियां रहती हैं कि इसका इलाज कैसे है। अगर आपको टीबी के लक्षण में खासकर 3 हफ्ते से ज्यादा खांसी आ रही है, कफ बलगम की शिकायत आ रही है, उसके साथ साथ कभी ब्लड आ रहा है, ये कुछ कॉमन ट्यूबरकुलोसिस के लक्षण है। और इस ट्यूबरकुलोसिस की पहचान करने के बाद आप तुरंत नजदीकी सेवा चिकित्सा केंद्र में या तो ब्रीथिंग हॉस्पिटल में आप संपर्क करें और ये जानने की कोशिश करें कि ये जो आपकी खांसी है वो ट्यूबरकुलोसिस है या कोई अन्य। हर खांसी टीबी नहीं हो सकती, लेकिन कोई भी खांसी टीबी हो सकती है, ये आपको पता होना चाहिए। और अभी हमने स्टूडेंट्स के चेकअप किए थे, जिसमें ऐसे कुछ बच्चे थे जिनको ट्यूबरकुलोसिस थी लेकिन उनको पता नहीं था। तो ये मेडिकल एजुकेशन काफी इंपॉर्टेंट है और ब्रिटिश का प्रयास है कि मेडिकल एजुकेशन के माध्यम से सोसाइटी को शिक्षित करें और लोगों को जानकारी दे कि टीबी के लक्षण में होता क्या। जैसे हमने आपको जानकारी में बताया कि बुखार आना, खांसी आना, कफ बलगम और उसके बाद हम लोग डायलिसिस करते हैं। ट्यूबरकुलोसिस पूर्णतः इलाज करने वाली बीमारी है और अगर आप सही तरीके से दवा का सेवन करते हैं 6 या 7 महीने में आपकी टीबी ठीक हो सकती है। और बीच बीच में डॉक्टर्स की जानकारी और राय के हिसाब से दवा चलाई जाती है। आप इसको बगैर किसी कंप्लीट कोर्स के दवा को बंद न करें कि कभी ऐसा होता है तो कई सारे गंभीर टीबी की समस्याएं उत्पन्न हो जाती है। इसमें एमडीआर टीबी, एशियाम टीबी हो जाती है। सोसाइटी में एमडीआर टीबी, एचडीआर काफी तेजी से मिल रहा है। एमडीआर का मतलब मल्टी ड्रग रेजिस्टेंट ट्यूबरकुलोसिस, एचडीआर में एक्सटेंसिव ड्रग रेजिस्टेंट, अभी तो टीडीआर आ गया, ड्रग रेजिस्टेंट ट्यूबरकुलोसिस। ऐसी टीबी जो खतरनाक होती है, ना इलाज में जाती है, काफी एक्सपेंसिव हो जाती है। ऐसे में आप कोशिश करें कि आपकी शुरुआती लक्षण जो है उन्हीं के माध्यम से आप इलाज कराएं। और सोसाइटी में कोई मैसेज कोई है लक्षण से ग्रसित है तो आप उनको जरूर सलाह दें कि आप नजदीकी चिकित्सक सेवा केंद्र पर जाएं। और खासकर बीटीजी हॉस्पिटल में आकर अगर कहीं नहीं मिलता तो यहाँ पर सेवा आपके लिए हमेशा तत्पर खुला हुआ है। और ये सुविधाएं हमारे पास सुबह मॉर्निंग में 8:30 से शाम 8:30 तक कभी भी आप अपनी मेडिकल एजुकेशन, सांस जैसी गंभीर बीमारी की समस्या का समाधान ले सकते हैं। ट्यूबरकुलोसिस कुल मिला के 6 से 8 महीने की बीमारी
को इलाज करके ठीक किया सकता है। और इसका एक्सपेंस बहुत ऐसा नहीं है, काफी कॉस्टली नहीं है, लेकिन आप ट्रीटमेंट लेते हैं, खान पान पर ध्यान देते हैं तो बिल्कुल।
दोस्तों आजकल सुनने को बहुत ज्यादा मिल रहा है या कुछ ज्यादा से ज्यादा लोग कर रहे हैं एमडीआर एक्सडीआर। ये आखिर में है क्या? आइए जानते हैं डॉक्टर एस के पाठक सर से, आखिर ये एमडीआर टीबी है क्या? डॉक्टर साहब ये एमडीआर और एक्सडीआर है क्या?
दोस्तों एमडीआर का मतलब मल्टी ड्रग रेजिस्टेंट ट्यूबरकुलोसिस, मतलब कई सारी इंपॉर्टेंट दवाइयां जो होती है ट्यूबरकुलोसिस की वो खत्म हो गई, वो काम नहीं कर रही। एक्सडीआर मतलब एक्सटेंसिव पल्मोनरी ट्यूबरकुलोसिस, एक्सटेंसिव मतलब कई सारी ऐसी दवाइयां बिल्कुल समाप्त हो गई, आपके पास कुछ ऑप्शन, कुछ लिमिटेड ऑप्शन हो गए, काफी। अभी एक नया टेक्नोलॉजी है टीडीआर, टोटल ड्रग रेजिस्टेंट ट्यूबरकुलोसिस। इसमें बिल्कुल कोई दवा काम नहीं करेगी, आपकी किस्मत है कि आप बचे या ना बचे। तो ये एक टीआर एमडीआर ये सब जो है हमारी सोसाइटी की ही देन है। इसमें कई सारे ऐसे मरीज होते हैं जो दवा को अधूरे में छोड़ देते हैं, 2 महीने या 3 महीने इलाज करते हैं, उसके बाद गैप कर देते हैं, दवा का इलाज पूरा लेते नहीं और कांटेक्ट में आ जाते हैं, एक दूसरे को स्प्रेड करते हैं। ट्यूबरकुलोसिस फैलने वाली बीमारी होती है, सांस के रास्ते से फैलती है, लेकिन अगर आप दवा इलाज ले रहे हैं तो आप बिल्कुल कैरियर नहीं बन सकते, किसी को फैला नहीं सकते। आप कोशिश करें, अपने लिए रिस्पॉन्सिबिलिटी है, सोसाइटी के लिए रिस्पॉन्सिबिलिटी है। तो एमडीआर ट्यूबरकुलोसिस को पनपने ही न दे। गवर्नमेंट की कई सारी स्कीमें चल रही हैं जो एमडीआर इख्तियार की है, लेकिन ये काफी एक्सपेंसिव है और काफी अनअफोर्डेबल है, और कई सारे ऐसे मरीज होते हैं जिनको इलाज नहीं कराने की स्थिति में होता है। तो ट्यूबरकुलोसिस को बीमारी सिंपल बीमारी होते हुए ये कॉम्प्लिकेटेड बन जाती है। तो आपको ये सावधान रहने की जरूरत है, जब भी आपको लक्षण हो तो तुरंत इलाज कराएं। और एमडीआर एक्सडीआर की कई सारी ऐसी डायग्नोस्टिक टेक्निक आ गई कि आप उसका पता कर लगा लें कि एमडीआर एक्सडीआर टीडीआर है तो नहीं, तो उसके द्वारा आप इलाज की मैक्सिमम संभावना तला सकते हैं। और बीटीजी इसके लिए अस्पताल है, यहाँ पर सारे तरह की टीबी का इलाज संभव।
हेलो दोस्तों, एक ऐसा वर्ड जो हम लोग सबको ही जानता है, मेडिकल वर्ड, उसका नाम है निमोनिया। नाम तो बहुत सुना होगा, लेकिन होता क्या है, इसकी शुरुआत कैसे होती है और इसका इलाज कैसे होता है, ये हमारे लिए जानना बहुत जरूरी है। आज हमारे साथ है डॉक्टर एस के पाठक, वरिष्ठ श्वास रोग फेफड़ा रोग विशेषज्ञ। डॉक्टर एस के पाठक सर, ये आखिर निमोनिया है क्या?
नमस्कार दोस्तों, मैं डॉक्टर एस के पाठक, ब्रीथ टीबी स्पेशलिटी केयर सेंटर अस्सी वाराणसी से। आज निमोनिया के बारे में जानकारी, जैसे अभी चर्चा चल रही थी, निमोनिया काफी आम बीमारी हो चुकी है। और निमोनिया में होता क्या है? निमोनिया एक तरह से सांस की जो फेफड़े की नली होती है उसमें सूजन आ जाती है और लंग्स कंसोलिडेट हो जाता है, सॉलिडिफाइड हो जाता है। हमारा लंग्स हमेशा स्पंजी होता है, लेकिन निमोनिया में सॉलिडिफाइड हो जाता है। उसमें जो एयर होती है बिल्कुल जा नहीं पाती, जिससे सांस फूलने की शिकायत हो सकती है। इसके निमोनिया की पहचानने के लिए तेज बुखार, ठंड के साथ बुखार होगा, खांसी आना, कफ बल्कों की शिकायत के साथ साथ कमजोरी होना, ये कुछ लक्षण है जो निमोनिया को दर्शाते हैं। कभी चेस्ट पेन की शिकायत भी हो सकती है। तो निमोनिया अगर आपको है, कफ बल्गम और सांस लेने की शिकायत साथ साथ चेस्ट पेन हो रहा है, तो हो सकता है निमोनिया हो। और निमोनिया के इलाज के लिए संभवतः आपको एक्सरे की जरूरत पड़ती है, तो सिंपल तरीके से हो सकता है। कफ बल्गम की शिकायत पर की जांच करके निमोनिया का पता लगाया जा सकता है। और इस जानकारी के बाद इन्फेक्शन जब भी होता है उसके लिए कुछ ब्लड टेस्ट होते हैं, वो पता करके आपका जो निमोनिया का इलाज किया जाता है, इसमें कई सारे स्पेशल ट्रीटमेंट देते हैं, एंटीबायोटिक्स वगैरह देते हैं, जिससे आपका निमोनिया बिल्कुल ठीक होता है। निमोनिया कई तरह का होता है, कम्युनिटी एक्वायर्ड, हॉस्पिटल एक्वायर्ड निमोनिया। कम्युनिटी एक्वायर्ड जो आपके कम्युनिटी के अंदर, सोसाइटी के अंदर निमोनिया होता है। हॉस्पिटल जो हॉस्पिटल के ट्रीटमेंट के दौरान या इन्फेक्शन से होता है, उसको हॉस्पिटल एक्वायर्ड निमोनिया कहते हैं। कभी कभी वेंटिलेटर एसोसिएटेड निमोनिया भी हो जाता है, जब पेशेंट वेंटिलेटर पर आते हैं उसको बैक निमोनिया कहते हैं। वो खासकर काफी रेजिस्टेंट निमोनिया होता है, इसमें कई सारे स्पेशल ट्रीटमेंट देने पड़ते हैं और थोड़ा हार्ड होता है, जिसके ट्रीटमेंट भी काफी एक्सपेंसिव होता है। तो आपकी निमोनिया की पहचान कहाँ पर कब कैसे होता है वो आपको जानना जरूरी होता है। और अगर बुखार आ रहा है अस्पताल के अंदर एडमिशन होने के बाद, और तो ये अस्पताल रिक्वायर्ड होगा। अगर सोसाइटी में या समाज या आपके गांव घर में कई निमोनिया का लक्षण है तो वो कम्युनिटी एक्वायर्ड निमोनिया है। तो इसका इलाज सिंपल है, ओरल ट्रीटमेंट हम देते हैं। अगर काफी गंभीर बीमारी है निमोनिया की, उसमें इंजेक्टेबल ट्रीटमेंट देते हैं। कई सारे ऐसे टेक्निक आ गए जिससे ट्रीटमेंट देके आपका निमोनिया 7 से लेकर 14 दिन की ट्रीटमेंट में बिल्कुल ठीक हो सकता है। और ये निमोनिया कई सारे कारण होते हैं निमोनिया के, कभी आपकी इम्यूनिटी कमजोर होती है, कभी डायबिटीज के कारण ऐसा होता है, बच्चों में कभी इम्यूनिटी का कमजोर उसमें शिकायत हो जाती है। तो निमोनिया की पहचान के लिए आपको बिल्कुल एक्सरे की जरूरत होती है और एक्सरे करा के वेलकम की जांच करके ब्लड की जांच करके निमोनिया को पहचाने और इसका इलाज कराएं, जिससे निमोनिया से काफी काफी गंभीर स्थिति भी आ जाती है, जिसको पेशेंट को वेंटिलेटर पर भी ले जाना पड़ता है। ऐसे कंडीशन में आप बचें और कोशिश करें कि निमोनिया की पहचान करके उसका इलाज तुरंत कर सकते हैं। पूरा ट्रीटमेंट से ट्रीटमेंट है, कई सारे ट्रीटमेंट ऑप्शन अवेलेबल है, जो भी हॉस्पिटल 80 से संभव है। आप कभी भी इसका इलाज संभव और जो भी जानकारियां हैं ले सकते हैं और ट्रीटमेंट इलाज कर सकते
नमस्कार दोस्तों, जैसा कि हम जानते हैं कि भारत में सबसे ज्यादा मनाने वाला त्योहार, चाहे वो हिंदू हो या मुसलमान, वो है दीपावली। दीपावली बहुत जोर शोर से मनाया जाता है, पर क्या आप जानते हैं दीपावली के बाद क्या मनाया जाता है? आज मैं आपको बताता हूँ दीपावली के बाद क्या मनाया जाता है। जी हाँ, दीपावली के बाद मनाया जाता है पोल्यूशन, प्रदूषण और एक बहुत बड़ी मात्रा में प्रदूषण। उसका एक कारण है, आइए उस कारण को डिटेल में जानते हैं। हमारे साथ आज हैं डॉक्टर एस.के. पाठक, वरिष्ठ श्वास एवं फेफड़ा रोग विशेषज्ञ, ब्रेथ इजी हॉस्पिटल।
मैं डॉक्टर एस.के. पाठक, ब्रीथ इजी टीबी कैचुअलिटी के सेंटर 80 वाराणसी से सभी दर्शकों को दिवाली की शुभकामनाएं। दिवाली पटाखों का त्योहार होता है और इसमें आपको सजग रहने की जरूरत होती है कि पटाखों में कई सारे गंभीर स्थिति हो जाती है और इसमें कितने सारे उत्पन्न होते हैं, जिसमें अस्थमा का अटैक होने की संभावना ज्यादा। कई सारे हानिकारक ऐसे गैस होते हैं जो वातावरण में घुल जाते हैं, सांस के मरीजों को काफी गंभीर समस्या देते हैं और सांस का अटैक के कारण हो जाती है। दिवाली में आपको ध्यान रखने की जरूरत है, आप क्या करें, खासकर सांस के मरीजों के आसपास पटाखे न छोड़ें, किसी भी इंडोर पटाखे का उपयोग न करें, खुले वातावरण में या आंगन या छत या बाहर पर करें, जिससे कि जो धुएं हैं वातावरण में घुल जाए, जिसका कंसंट्रेशन आपके रूम या घर के अंदर पहुंच सकते हैं। इसके काफी कई सारे सांस बीमारियां उत्पन्न हो जाती है। पॉल्यूशन लेवल नेक्स्ट दिवाली बहुत ज्यादा होता है, हवा में बहुत सारे ऐसे खतरनाक रसायन होते हैं जो उत्पन्न हो जाते हैं, सांस के कारक बन सकते हैं, अस्थमा के। तो आपको अपने इनहेलर मेडिसिन, नेबुलाइजर मेडिसिन जो भी है आपके पास, उसका सेवन लगातार करते रहे दिवाली के एक हफ्ते पहले से, और दिवाली के आप बिल्कुल स्टेबल है तब भी आप उसका सेवन करना जरूरी है। और अगर कभी ये दिवाली के आसपास आप अस्थमा का अटैक या सांस की बीमारी उत्पन्न होती है तो डॉक्टर से चिकित्सा संपर्क करें। काफी ये देखा गया कि लोग स्मोकिंग करते हैं और यंगस्टर खासकर, इनको मैं एक सजेशन देना चाहूँ कि बिल्कुल स्मोकिंग न करें, क्योंकि अपनी जिस एज यूथ में आप स्मोकिंग करते हैं उसका इफेक्ट आपको एज में आता है 40-45 के बाद। तो आप अभी एंजॉय करने के लिए स्मोकिंग करें, तो वही आपका एंजॉय कारक ऐसा हो सकता है कि आप दमा की बीमारी से ग्रसित हो सकते हैं और वो ऑक्सीजन और आदि हो जाएंगे और जरूरत पड़ेगी तो आपको गंभीर अवस्था में स्वामी भक्ति होना पड़ सकता है। तो आपने भविष्य की चिंता करते हुए आज से ही पान का सेवन बंद करते और आसपास जो ऐसा सोसाइटी में उनको भी सेवन करने से मना करें, क्योंकि ये स्वास्थ्य के लिए हानिकारक है। जो बजट है पॉकेट खर्च को भी कम करता है और ये जो आपके लिए काफी हानिकारक स्वास्थ्य के साथ साथ अभी चर्चा हम लोग कर रहे थे कि स्मोकिंग से क्या नुकसान हो सकता है। जैसे हमने बोला दमा बीमारी हो सकती है, कभी कभी आपका कंसंट्रेशन भी डिस्टर्ब हो सकता है, आपकी न्यूरोपैथी, हार्ट डिसीजेज हो सकती है, प्रॉब्लम हो सकती है, कई सारी और बीमारियां, ब्लड कैंसर किसी बीमारी हो सकती है। तो आप उसमें बचे रहें, कोशिश करें कि आप स्मोकिंग बिल्कुल ना करें और दूसरों को फ्रेंड सर्किल से हाथ से कसम खा ले कि मैं खुद नहीं करूंगा और अगले जो फ्रेंड सर्किल है उसमें 10 से 15 व्यक्ति जो भी होंगे उनको ये स्प्रेड करेगा कि वो स्मोकिंग ना करें। ये आप आज से भी समझ में पड़ेगी।
नमस्कार दोस्तों, क्या आपको पता है खर्राटा भी एक प्रकार की बीमारी है? जी हाँ, ये एक प्रकार की विशेष बीमारी है। आइए जानते हैं खर्राटा आखिर है क्या। और हमारे साथ हैं डॉक्टर एस.के. पाठक, वरिष्ठ खर्राटा रोग विशेषज्ञ, ब्रेथ इजी हॉस्पिटल। सर नमस्कार। सर ये खर्राटा आखिर में है क्या?
खर्राटे इसको हम लोग स्नोरिंग भी बोलते हैं, तो आम में लोग जो काफी गहरी नींद में व्यक्ति सो रहा है, खर्राटे नए रिसर्च जारी है उसमें
कराटे गंभीर बीमारी है। अगर आपकी कराटे ज्यादा तेजी से आ रहे हैं और सांस भी रुक जा रही है छोटी से, इसका मतलब कि आप प्रभाव पड़ सकता है। और कराटे किसी बीमारी से हार्ट अटैक, ब्रेन स्ट्रोक, यहाँ तक कि हाई ब्लड प्रेशर, डायबिटीज की संभावना में बढ़ जाती है। तो जिस भी व्यक्ति को कराटे आ रहे हैं, इनको इलाज के लिए स्लीप स्टडी टेस्ट करते हैं, स्लीप टाइट करते हैं, नाइट में कुछ मशीन लगाकर पूरी टेक्निक से जांच की जाती है और इसमें खराटे का कारण पता लगाया जाता है, खराटे के दुष्प्रभाव के बारे में पता लगाया जाता है और उसका ट्रीटमेंट भी उसी लाइन में काम करता है। इस खराटे के निजात के लिए आप वेटरनरी हॉस्पिटल स्पेशली इस सेंटर को रिकॉग्नाइज किया गया है। मार्गदर्शन सेंटर में जहाँ पर स्लीप लैब है, जहाँ पर हम जांच करते हैं, खासकर उन मरीजों के लिए जो कराटे गंभीर कराटे से पीड़ित है। और ये देखा गया कि कराटे के व्यक्ति में जो लक्षण होते हैं, शुरुआती लक्षण में स्नोरिंग तो आती है, साथ में वो डे टाइम स्लीपलेस होते हैं, दिन में बैठे सो जाते हैं, आप टाइम पे बैठे कार्य गाड़ी चलाने में गंभीर एक्सीडेंट होने का भी चांस रहता है और काफी लेजीनेस लेथार्जिक होते हैं और उनकी जो एनर्जी को भी काफी डाउन होती है। यदि आप कराटे के इलाज सुचारू रूप से करेंगे तो कई सारी इस समस्याओं से छुटकारा ले सकते हैं और आपकी जो ब्लड प्रेशर की शिकायत या ब्लड की शिकायत है उससे भी छुटकारा मिल सकता है। अगर सही तरीके से आप कराटे का इलाज कर रहे हैं तो ये जो मल्टीपल पिल्स ले रहे हैं आप उनसे छुटकारा मिल सकते हैं। और ब्रीथिंग जी इसके लिए एक्सपर्टाइज है और ब्रीथिंग जी हॉस्पिटल आपको पता है इससे लोग जीवन के सामने है, फिर गूगल पर सर्च करके के बारे में जानकारी ले सकते हैं, यहाँ अपॉइंटमेंट भी ले सकते हैं और लोगों को जानकारी विस्तृत कर सकते
सर स्पीकर का बायोडाटा को हाँ 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 तुरंत तुरंत बुला रहे हैं, ठीक है, अपना इंट्रोडक्शन दे दे। दोस्तों, आप गूगल में सबसे ज्यादा सर्च करने वाली चीजें हैं वो है एलर्जी। आखिर एलर्जी है क्या? हाँ, हमारे साथ हैं डॉक्टर एस के पाठक, एलर्जी रोग विशेषज्ञ, ब्रेथ इजी हॉस्पिटल। सर, ये एलर्जी है क्या आखिर में और इसका इलाज कैसे होता है?
एलर्जी
When we start,
हाइपर रिएक्शन बॉडी का होता है इसमें
so once again, good evening, everyone.
कई सारे लक्षण ऐसे होते हैं जिससे आप
On the behalf of Respiratory Conclave Conference 2023, I welcome you all. Now I would like to call upon Dr. Sakshi Pathak. She is MBBS, doing MBBS from BHU. Intern, sorry. She is going to tell you about Respiratory Conclave Conference in brief.
Good evening and namaste everyone. First of all, I would like to thank Dr. S.K. Pathak sir, Organizing Secretary, Respiratory Conclave Conference, for giving me the opportunity to be the Program Coordinator for Respiratory Conclave Conference 2023. I, Dr. Sakshi Pathak, am an intern currently working at Sir Sundarlal Hospital, BHU. I would like to welcome all our respected speakers, chairpersons, panelists, delegates, and our online viewers to the 10th Respiratory Conclave Conference, which is being organized on 25th of June at Radisson Hotel, Varanasi. Since a decade, RCC has been organized by Breath Easy Chest Foundation for Humanity and co-sponsored by Breath Easy Chest Super Specialty Hospital, Assi, Varanasi, and Breath Easy Multi-Specialty Hospital, Ramnagar. At this RCC, we are aiming to bring upon light on recent advances in the field of respiratory medicine by having heated discussion on topics like EBIS, thereby giving every one of our attendees an extra edge in patient care in pulmonology. It gives me immense pleasure to introduce to every one of you our chief guest, Mr. Brijesh Pathak sir, Deputy Chief Minister, Uttar Pradesh, who couldn't be present here with us due to some unanticipated reasons. Our guest of honor for tonight is Dr. Sandeep Chaudhary sir, Chief Medical Officer, Varanasi. Now let me introduce to you all our honorable speakers for tonight. Dr. Rajendra Prasad sir, Organizing Chairman, RCC, Professor and Head of Department, Eras Medical College, Lucknow. Dr. K. Gupta sir, Medical Superintendent, IMS, PHU. Dr. Rajadhar sir, Senior Pulmonologist, Fortis, Kolkata. Dr. A.K. Pandey sir, Senior Cardiologist, Varanasi. Dr. Viruttam Tomar sir, Pulmonologist and EBIS Expert, Chest Specialist, Meerut. Dr. Anshul Mittal sir, Senior Pulmonologist, Max Super Specialty Hospital, Saket, New Delhi. Dr. Swapnil Pathak sir, PMD Pulmonology Resident, Max Super Specialty Hospital, Saket. Thank you. And now I would like to call Abhishek for discussing with you all the Shri for tonight.
Yeah. I would like to call the session chairperson for the first session. Please come on the dial, Dr. Viruttam Tomar sir, and Dr. Mohit Bhatia sir, and Dr. K.K. Tripathi sir.
Yes.
Good evening, everyone. So, starting with the first session of today's respiratory conclave, which is a very important topic. The topic is based on endobronchial ultrasound. And without wasting time, I will invite our first speaker, who is Dr. Sabir Pathak. He will be talking about the role of levers in transbronchial needle aspiration and PPCLM in difficult undiagnosed malleable intrarenal. So, Dr. Sabir Pathak.
Just I would like to call the speakers, please come on, guys. Dr. Sansilukum, Dr. Sabir. Permission of chairperson, please start the.
Sure. Hello to all the chairpersons, all the seniors, faculty, all the delegates, and great good evening to all of you. I myself, from Swapnil Pathak, I'm currently pursuing my DMB residency, public medicine from Max to Japanese Active. So the topic for today is EBUS bronchoscopy. Yes. Yeah. Correct. Just wait. History and background of EBUS. So what is EBUS? So it is an endobronchial application of ultrasound. It has been described first in 1992. The following years, the technical difficulties had to be resolved, and a clear view of the indication and diagnostic properties of endobronchial ultrasound had to be developed. Many pathology of the airways involve the bronchial wall and the parabronchial structures. Radiologic imaging has been proven to be unreliable in diagnostic evaluation of these structures, and bronchoscopy appears more useful for this application. Since 1999, EBUS has been commercially available and gradually introduced in the bronchoscopic practice. It has been broadened the view of bronchoscopists and augmented the diagnostic technique for both bronchial and mediastinal apnea. So what is EBUS? Again, using the bronchoscopic technique that uses beam or ultrasound to visualize structures within and around the airway at the lung. So endobronchial ultrasound basically combines bronchoscopy with ultrasound to enhance definition of mediastinal structures and aid in visualization of parabronchial anatomy. So two major barriers were there to EBUS development. Ultrasound probe size and sound wave transmission in air-filled structures. So ultrasound engineering advances allowed the former barrier to overcome, while the later surmounted by the integrated fluid-filled balloon system that is around the EBUS probe, thereby for a sound wave transmission medium interface to exist between ultrasound probe and the airway wall. So basically, an ultrasound works on the principle of acoustic impedance. So what is the impedance? Impedance is the resistance offered by a soft tissue against the ultrasound wave. So, to get an ultrasound signal between two soft tissue, the difference is the acoustic impedance of two soft tissue gives the ultrasound signal. So basically, what is ultrasonographic coupling is around a probe of EBUS, there's a balloon integrated in it, which is normal saline or saline water. So thereby, there's a medium that will be created between the probe and the airway wall. So therefore, providing a better impedance. So that's the scientific basis of ultrasound to the piezoelectric effect. So once from the ultrasound probe, the transmission, how the ultrasound wave is produced goes to soft tissues and then comes back. So basically, works on piezoelectric and reverse piezoelectric. So depends on the frequency from frequency of the ultrasound wave and the transmission size. So lower ultrasound frequencies provide better penetration depth with lesser resolution, and higher frequencies provide better spatial resolution but less penetration depth. So for EBUS application, the frequency of ultrasound wave used are in the range of 7.5 to 40 megahertz. Currently, there are two types of EBUS probes that is utilized for diagnostic application. Ultra miniature probe 20 to 30 ultra miniature radial probe, which are in the range of 20 to 30 megahertz, and another probe is convex or curvilinear or linear probes. So, as you can see, this is the radial probe, and with the integrated balloon system with filled and this is a curvilinear probe with a transducer that is a curvilinear shape, and it is integrated in a special type of bronchoscope that is called as endoscope. From this endoscope, from the working channel of this scope, insert PVL needles of high group. So what is the comparing radial Probeavers versus linear probeavers. So rotating mechanical transducer is there in radial probeavers. In linear probe, fixed array of electron transducer aligned in a curvilinear pattern is present. So radial even gives a 360 degree view of the long axis of the scope, and linear probe is 60 degree parallel to the long axis of the scope. Frequency that is delivered is 20 megahertz, and in linear probe the comparatively lesser frequency is elaborated. So there is a tissue penetration is around 4 to 5 centimeter, and in linear probe is around 5 centimeter. In radial probe, the image quality is very good as compared to linear probe. Currently, not possible to identify airway layer, but we can identify airway layers in radial probe. That is what the difference is. In radial probe, even we can differentiate between the layers of the airway wall, and but in linear probe we cannot do that. Real time imaging is not possible with radial image, but we can go for we can do that in the linear probe. So Doppler can be integrated in a linear probe, but we cannot do it in radial probe. So radial probe passes through the working channel of flexible fiber optic video bronchoscope, enabling the evaluation of peripheral lung nodules, where convex probe incorporated into a tip of a dedicated bronchoscope allows the real-time imaging and sampling of the tissue. So we will not go into details of ultramillimeter radial probe. We will focus on the convex probe levers. So convex probe levers bronchoscope available have a built-in curvilinear ultrasound transmitter with a larger distal diameter around 6.7 to 6.9 mm compared with a standard bronchoscope. White light video bronchoscopy occurs at an oblique angle with levers at 90 degrees from the longitudinal axis. The dedicated biopsy needles are available in the market that are called at 3D and needle around 19 gauge to 25 gauge with a variety of tip styles are inserted through the 2 mm working channel to perform aspiration of the target lesion. That can be a mediastinal lymph node, that can be mass. Real-time EVAS imaging displays needle penetration through the tracheobronchial valve into the largest into the target during the biopsy maneuver. So there is a difficulty in achieving adequate EVAS images because of poor ultrasonographic coupling. A saline-filled balloon surrounding that we discussed earlier that a saline-filled balloon can be already integrated in the flow. So it can surround the transducer and can be used to improve the imaging quality. In addition, Doppler capabilities allow a vascular structure differentiation, which minimizes the risk of unintended vascular puncture in case of curvilinear probeavers. So basically, this is the reverse TBN and needle showing this DB short tube system, and we can see the curvilinear reverse with the TBN and needle integrated. So it's a full reverse console with the bronchoscope and various kind of needles that are being used. So what is the clinical application, and we say the indication of reverse bronchoscopy. So for evaluation, basically it's in general, but we focus more on the indication of reverse TBN. So what is reverse TBN? Endobronchial ultrasound guided pan-bronchial needle aspiration. So evaluation of mediastinal masses and mediastinal hilar nodes more than 1 centimeter. So via reverse TBNA or via reverse TMC or via reverse IFB. Diagnosis, staging and rescreening of lung cancer, especially non-small cell lung cancer. Evaluation of pulmonary, nodule, endobronchial or peribronchial lesions. And to guide certain therapeutic interventions, like for example, airway stenting. So technique of curvilinear probe reverse TBN. So reverse may be performed under conscious sedation or general anesthesia depending upon the anticipated length of procedure. Local anesthetic may be administered to minimize cough, and the flexible bronchoscope is advanced for initial airway exam. Bronchial segments and subsegments are identified and secretion is suction. And 1 to 2% lidocaine is administered to further minimize the cough. So after initial airway examination via the flexible bronchoscope, it is removed and then the EVAS bronchoscope is advanced. While EVAS is performed, the bronchoscope is simultaneously visualizes the ultrasonic and bronchoscopic movement on the display. EVAS can help differentiate normal parenchyma from a malignant tissue by sonographic appeal. After sonographic confirmation of the biopsy site, the transbronchial needle aspiration, the TB needle is advanced to a 2.2 mm virtual channel of a bronchoscope. This needle may be 21 or 22 gauge and can be advanced up to 40 mm. A stylet or a wire is present in the needle at the time of insertion to clear the tissue that have been collected while crossing the bronchial or tracheal wall. The distal end of this needle is moved, rendering it hyperechoic and improving ultrasound visualization. So after lymph node or tumor is punctured, the needle is connected to suction and excursions are made in lymph node. Multiple punctures have been recommended to decrease circulation. So basically these are passes which are done via bronchoscope into the lymph node station. The samples obtained can either be analyzed on-site by the use of rapid on-site evaluation that is called as ROSE or collected in saline or cell culture media. The application of ROSE has been shown to significantly lower the need of for additional bronchoscopic procedures and punctures. ROSE is a particularly beneficial when performing focus in the operating room with expected need for further invasive exploration of surgical resection. Procedure lengths vary by the number of lymph node station sample. So when EMUS is performed in the outpatient setting, patient can be discharged home after they regain their diagnosis. So this is a lymph node mapping around the thoracic, mediastinal and hilar nodes. So anatomic lymph node stations that are accessible by EBUS are 2R, 2L, 4R, 4L, and 7. A unique advantage of EBUS is the accessibility of station 10R, 10L, 11R, and 11L, which are inaccessible by other invasive techniques like Radisson storage. So what are the contraindications for EBUS? So recent myocardial infarction or ischemia. So basically contraindications to EBUS are similar to those of bronchoscopy in general. Recent myocardial infarction, ischemia, poorly controlled heart failure, significant hemodynamic instability, chronic obstructive pulmonary disease, or asthma exacerbations. Life-threatening cardiac dysarrhythmia should immediately. So contraindications particular to EBUS TBNA are related to coagulopathy. So therefore, in order to go for EBUS TBNA, plan so the preparation of the patient is to go for PDI and other profile before forming this procedure. So the contraindications particular to EBUS TBNA are coagulopathies, medication use or inherent. The recommendation is to remove antiplatelet and anticoagulation agent prior to endoscopy to remove the bleeding risk. So what are the complications for this EBUS TBNA procedure? Bronchoscopy is generally a safe procedure with a low complication rate. Complications related to the bronchoscopy procedure can be related to sedation or for the procedure or directly from the bronchoscopy. So in general, what are the complications related to sedation? There are hypoxemia and hypertension while those related to bronchoscopy or bronchospasm. Laryngospasm, nausea, vomiting, fever, fluid, scope trauma, cardiac arrhythmias, vasovagal syncope. Complications specifically to EBUS TBNA including pneumothorax and bleeding from the head. There has been a similar reported of EBUS TBNA needed breakage without it. So that's all. So what are the summarize this topic of EBUS and the basics of EBUS. I'll call upon Dr. Anshu Maisida to proceed for this.
Would you like to put the questions right now or together? Together.
First, Dr. Anshu Maisida. Our chairperson is going to presentation before sir.
You now have the Dr. Vector from the Pulmonology Smart Specialty Hospital. Is a graduate from Aurangabad. I am just from Govardhan, a senior resident with academic medicine and one of DM Pulmonary and Critical Care Medicine from Delhi University. Currently working as consultant in the Department of Respiratory Critical Care Medicine at Saket Hospital. Has worked as a senior registrar supervisor, worked as associate consultant with Medfor, and this is Institute of Pulmonary Critical Care Medicine. Has been model of the in central government team for inspection at 5 and 1 outbreak in Gujarat. Every second year bronchoscopy workshop at Pentax India and the technical workshop on ventilatory management at IMET. It is a complex topic that we will read about the lymph nodes, which have been inaccessible for decades. Good
evening, everybody. It's an honor to be speaking in front of people who have seen the growth of this procedure in the ages, and now there is something new which is coming up every day in field of pulmonology. So here I would like to introduce a new procedure, which is the EBUS transbronchial cryovalves. So EBUS has been long there since 1999. Second endobronchial ultrasound guided transbronchial middle aspiration with EBUS TBNA is a technique of choice even currently for study of mediastinal and higher vision. Though initially it was started as a tool to stage lung cancer, now it is a diagnostic tool in both benign and malignant mediastinal masses. However, it being a needle procedure which only uses cytology instead of histopathology, there are issues of inability to obtain intact biopsy specimens which are fragmented and low volumes of sample size which our pathologists fail to comment on and leads to a non-definitive diagnosis. These sometimes require rebiopsy or additional diagnostic procedures such as mediastinoscopy and VATS when the tissue needs is higher or diagnosis immune cells. So this is some of the drawbacks I would like to share of the inverse TVNA. So when inverse TVNA was evaluated for a diagnosis of primary or metastatic pulmonary malignancies, so it has been an excellent diagnostic tool. But again, it being a cytology procedure, we believe it leaves a limited amount of tissue that might be insufficient to allow absolute diagnosis, specifically in case of liver or benign malignant tumors, which frequently requires a histopathology sample rather than a cytology sample. So in recent years, lung cancer has gone leaps and bounds over the other cancers. We are having newer drugs each day. So proper molecular characterization of tissue sample has become crucial in management of thoracic malignancies. Newer drugs are added each day, which require molecular testing and increases the need of tissue by pathologists and medical oncologists, which is usually not possible by cytology procedure like EBUS, and the patient ends up going under another biopsy procedure. When EBUS was evaluated in the use of lymphoma, so EBUS as a tool to diagnose lymphoma and subtyping has been off question since its advent. The recent research is highlighting that histological sample rather than cytological samples are required for diagnosis of lymphoma. Histological sample only helps in not only helps in diagnosing, but proper molecular application of biomarkers helps to plan the treatment further and better. In case of mediastinal lymphadenopathy and suspicion of lymphoma, still, by the medical oncologist, surgical biopsy is preferred as the diagnostic tool. For the good old sarcoidosis versus TB, which is the most common indication for reverse worldwide, at this time, several groups have addressed the use of many modalities to increase the yield. We use the rapid onset examination. We have used higher gauges needle. We started with 25. Now we have a 19 one also. The number of passes have increased. 3 passes. We have changed to 5, 6. And we try to sample as many nodes as possible so that the tissue is higher and the definitive diagnosis has been known. So if we compare all the studies which have been done on this system, still around 20% of the EBUS done in the highly trained setup fail to detect a granuloma or even a granuloma. They are not able to differentiate between a TB and sarcoid or a definitive way in a second line loss. So for all these reasons, now there is a need for a procedure which is less invasive than mediastinoscopy and VATS for getting a histopathological tissue with beyond cytology and cell block, which we use in EBUS to make a diagnosis and gives a larger volume of sample, which satisfy the needs of our medical oncologists because the need of tissue is growing day by day, I guess. So I introduced a procedure which is called EBUS guided mediastinal cryobiopsy. So before we go to the actual procedure, I would like to brush up the knowledge of cryobiopsy. Cryobiopsy has been there for now quite long, which utilizes the cryo probe. It uses compressed gas that decompresses within the metallic tip of the probe and causes a cooling effect. As a result, the tissue around the probe gets frozen and can be extracted. Two main cryogen are available: the gas, carbon dioxide, and nitrous oxide. Cryoprobe are available in 3 sizes. There is a 2.4 mm one, which is the largest one, which is usually used to extract the foreign body, blood clots, or mucus from the captive concrete. There is a 1.91, which is used to do biopsies from the lung or endobronchial tissue, and there is a 1.1, which is now available as a disposable one, which was initially done mainly to do pediatric lung biopsies. Cryobiopsy as a procedure has been applied for good effect for detecting INDs, doing transbronchial lung biopsy, for removing foreign bodies, blood clots, mucus, for biopsies of the endobronchial tumor, for biopsies of the small pulmonary nodules with use of fluoroscopy, radial levers, navigational bronchoscopy, or currently working the cone beam study. The complications of cryobiopsy include pneumothorax and bleeding inside the endobronchial tree, which was initially in the studies 9.5, 4.9%. But all these complications have come down drastically with more experience and more expertise we have now in technique. So, how to perform a mediastinal clamp? So, as good as the term looks, it's a bit of a tricky procedure or to perform a transbronchial mediastinal cryobiopsy. So that is just the basic steps which needs to be done. So we start with the neighbors, we identify the lymph node station as we do in all the neighbors. We perform 3 passes through the TBNA needle at the same site. The importance during passing of the needle is it should at the same site in the bronchial wall and at the same site in the loop. You should not change the sites frequently. After we have done 3 passes, the key is to identify the track of the TBNA needle within the lymph node. So this is the TBNA needle which is creating a hole in the wall of the bronchus, and this is the needle inside the lymph node which we see. Once we have created that trap, we try to push in a 1.1 mm cryo probe to the working channel of the ibis. So this is the probe which comes out to the working channel of the ibis. The cryo probe is advanced towards the puncture site and inserted gently to the puncture site by the needle. The ibis image is used to confirm the cryo probe location within the lymph node. Following this, the cryo probe is spooled, like we do in the biopsy scope for a 4 seconds. Then we can retract it and block with the scope. So a good amount of chunk of the tissue comes out of the So this is the hole which we visualize in the tracheobronchial wall, and this is the trap which we see, which has been created by the use of the needle. And then once we have done it, we pass the probe inside through the bronchial wall into the nose, and this can be easily visualized using the ibis. So the good thing is we have a correct visualization of the probe, and you have the vessel also localized. So you can always be away from the vessel. You have a correct localization of the probe inside the nose. It makes the real-time visualization procedure. We are not blind anymore. So the cryobiopsy, once we remove the probe, we envelope with the scope, we remove our tissue, and we again inspect the site for any major bleeding. The cryobiopsies can be retrieved in formalin or saline, according to the tissue. So this is the amount of tissue which usually get attached to the scope in the real-time photo, and this is the tissue. You can look at it. We cannot get this amount of tissue from the mediastinal growth by any kind of animals. Maybe whatever data we use. These are intact tissue, which are pathology find very well. So this is one of the videos. This is one of the real-time case which we did recently or demonstrating. So this is a mediastinal mask. So this is the needle which we have put through the channel of the scope through which we are trying to create a trap. The important is to jab the needle a bit with the force, and we have to do it from top to the bottom. We take out to the trichobronchial tree, we again insert in the node, we take out to the trichobronchial tree, again insert it into the node. So important is you do your Rose passes before we started transbronchial mediastinal cryobiopsy. It is only to be done when we have completed the ibis. It should not be done as the first procedure because the needle will get damaged. So once we have done the passes, now we can see a track within the node. So now we try to introduce our cryoprobe into the node. So it's a soft procedure. You put it into the cryo, you touch it at the wall and you try to jab it slowly. Because slowly the probe will pass. Because it's trying to coming out of the upper one. So conventional to the belief is more tricky to go through the node. Going to the bronchial wall is very easy. Because already a track has been created there. That track localization within the mask or within the node is the difficult and the tricky part here. So you just see the probe. So once you have pushed it, the tip of the probe is usually brighter than the tip of the needle. You will just be visible. So here we see. This is the tip of the probe. We are very well confident it is inside the node, and we know these two are vessels. We try to keep it away from the vessels. So this is clear cut probe, and you can move it up and down. You can take specifically in lymphoma. You want a biopsy from the periphery of the lymph node. If you take a biopsy from the center of the lymph node, you might miss the marginal bone lymphoma which they want. So it's very important you take the biopsy from the periphery, from the downside, and from the middle. So we try to take biopsies from other places. So, as easy or as difficult as it looks, there are some technicalities. Being a new procedure, only few centers in India doing it, and few people have been able to do it on a regular basis. The issues are regarding creating a track, which is more frequently seen in cases. So here, the problem that I found when once you started this procedure is calcified nodes. Patient has taken ABD for 2-3 months, nodes are calcified. In a calcified node, creating a track is a big problem. Even if you create a track, passing the probe 1.1 mm probe through a very PMC kind of a wire, which breaks easily to the node becomes a challenge. One place more which I found a problem is when the bronchial wall is rigid and the cartilage becomes rigid, specifically in old age patients. They're creating a track through the wall of the bronchus was more of a difficult thing whenever we created it got closed. Because one of the problems. So how to create a track? Different people have tried different needles. There have been studies with 22 gene, 21 gene, 19 gene. Initially, when we started it, we started with a 19 gene. But the problem with 19 gene is you get a very greedy sample of those. So now now the last 15 days which were done, we have all done with a 21 gene. So there is no need of a higher gauge 19 gene needle now. There have been studies in which they have used that wherever in Bangkok they were using in Thailand which was seeing the procedure, they were using the 49 to create a hole in the tracheal wall. But never ever, after doing the good amount of cases, 25 cases, are required to create that 21 gene needle works enough. 1 or 2 times we have to use a 19 gene needle, which we usually do to samples. So, like EBUS TBNA, TMC can be done in a short gene, use of an endemic. It can be done under your bronchoscopy suit. An occlusion blocker we usually keep on a standby. If needed, can be put if there is case of a bleeding, not needed till now. In all the procedures we have performed, till date we have not noticed any major bleeding, pneumothorax, or pneumomediastinum in any of the cases. The most common adverse effect which we saw was bleeding into the tracheobronchial leak, but that was controllable within few minutes, manageable in all the cases. So there has not been many supported data for TMC, it being a new procedure. So this is only the one of the large study in which they include the 50 cases, which was recently published in ERG in 2023. In that they found TMC was an effective, minimally invasive, rapid, safe technique, which yielded a higher diagnostic yield than EBUS, TBNA, especially in case of lymphoproliferative disorder, metastatic nodes, where the biopsy sample yield is higher for molecular typing. So, for better understanding, I would like to present two cases which we have done very recently at our center. This was a 36-year-old male, the usual history of fever, weight loss, loss of appetite for 2 months. Outside the CT scan showed mediastinal lymph nodes, A7 were normal, TB coded 1 positive. At an outside center, patient went under EBUS TBNA which was suggestive of granuloma. All TB markers, gene expert, ASP scores, culture were negative. Patient was started on empirical imaging. So, this is a PET scan. So, we did a PET scan here. So, this was a PET scan showing a plethora of lymph nodes within the mediastinum. Patient was not happy with the TB treatment given, neither there was much of a response. There were two options, either we go for a mediastinal or a EBUS wax, for a wax which was invasive. So we gave him a second option of an EBUS transbronchial mediastinal cryobiopsy. So like every EBUS, we did a roll. Our roll of pathology there granuloma, but the same problem, no necrosis, no caseation could be commented. So again, there was a gray area that TB has, sarcoid has, dono hai. So then we did a TMC. So this is the TMC in which the cryoprobe is inside the node. You got a good amount of tissue, and on TMC, the pathologist could clearly comment on a multiple non-caseating epithelioid granuloma, which are the telltale sign of sarcoidosis. Patient started on steroids, APT is not, and patient is doing well. This is an international question which we did recently. 58-year-old female with a cough and weight loss and hemoptysis. Evaluated in Iran, then they got a sputum positive report, they put on ATT. Then they referred to India because she was not getting any benefit from it. She was progressively deteriorating both on radiology and clinical. So this is the PET scan. So our medical oncologist thought that there might be an endobronchial lesion. We also thought that we went inside, there was no endobronchial lesion. The lesion was far away from the chest wall. Doing a CT guided biopsy would have given her a pneumomediastinum or a pneumothorax. It was also considered. So again, a transbronchial mediastinal cryobiopsy was planned. First we did a rose. In rose, they were non-small cell cancer.
So cancer was confirmed. The pathologist wanted a higher amount of tissue doing all the molecular markers. So again, inserted a needle, he made a crack, inserted a cryoprobe. To the cryoprobe, it came out to be non-small cell carcinoma. Tissue was adequate for IHC molecular testing. Patient turned out to be adenocarcinoma, EGFR found. So my take on TNC would be it's safe in lymph node size of 1 centimeter in experienced hand. I have tried not tried more than 1.2 centimeter, smaller than 1.2 centimeter. Definitely a better yield in lymphoma or rose negative lymph node. Adequacy of sample is higher, ensures the correct accuracy of malignancy with IHC and molecular testing. It is less evaluated for benign hand, but benign lymph node, but whenever we have tried, the success has been good till now. No major bleeding or complication has been seen till now. Looks of promising technology. Which will further with further data and study being added. Swapnil is one of the guys who did a study on it, who added TNT to it. So very soon we will have more data. We may be more sure about how the procedure is going to go further, but I think it's there to see. Thank you.
Thank you. Wonderful. Great presentation. We have given an option, as you said rightly. Would you go for a bleeding loss treatment first? Would you go for a EOBS first? Or would you go for a bronchoscopy first in these patients with mediastinal growth?
So with mediastinal growth, we always go for the standard technology. Right? With mediastinal I think now nobody is doing much. Even at our center, I think surgeon might not be confident because he has not done it since past 10 years. It was not required. But in the correct era of medical oncology, they want higher amount of tissue. They want to do all their molecular markers. Another report I saw it was 136. I don't know they have a treatment to it or not. Very confidently to the all. So they want a larger amount of tissue, which is not possible by this. Because that's cytology, which is a small amount of.
One question out of interest. Do you still believe in TB gold test because this is no more academically accepted? And but then otherwise, very frequently. So we accept it.
It's not a part of treatment, but it is an ancillary evidence. Then there is a conclusion. I would it is an ancillary evidence rather than being an actual starting a treatment.
Thank you, Dr. Mr. It's a wonderful presentation of EBUS and very good presentation. So the message is very clear. If you are having mediastinal lymph node in your patient, on the basis of contours or TB should not start immediately. You have to confirm by EBUS. And other modalities, definitely cytology. If you are not doing, anybody is doing EBUS here, at least do cytology, FNEC. That is wonderful to do the histopathology with the control was relaxed. Definitely, two techniques like previously they were using the electropottery knife to give a passive to not the passive incontinency, but that is lead to sometimes more bleeding. The important thing is when in immediate settings, when you are finding the lymph nodes, sometimes most of the time 90% or 80% you can find the total lymphadenitis. The high chance with histopathology, if you are getting the FNC experts and you can sign that if they are positive, sometimes you can find the track can lead to the sinus formation and can lead to the in setting. But if you are doing rules, then rules of the tuberculosis, and that is an important thing, important message, because one of my we having two cases with the mediastinal lymph node, actually the converting into the mediastinal abscess. So they have to be very careful. If you are finding an EBUS with a causation, necrosis, then definitely you should avoid. If you are having solid tissue like mass, lymphoma, that's wonderful for getting sarcoidosis. Again, question is that leads to chronic sinus discharge. After a few months, patient found this current situation. But the thing is, mediastinal abscess is difficult to treat. That is the complication. So in Indian setting, we have to, but you are doing a wonderful job by doing the rules and taking all the questions and avoiding just message.
So, first I wanted to congratulate Swapnil. Swapnil, I know how difficult it is to do a presentation in front of an audience who are all similar to you, and to stand up on a stage and make a presentation and speak confidently speaks volumes. I think there should be a big round of applause for Swapnil for very good. Actually, lovely presentation. Very nice to see your passion. I just have a couple of comments to make. So we have just reached double digits doing the procedure that you've described, and one of the challenges I have faced in executing it is that I've always found the 1.1 probe very floppy. The end flops around a lot. So irrespective of whether you're doing a cryobiopsy or whether you're doing a mediastinal cryobiopsy, it always ends up being very loose, lax end of probe, and to introduce it to the track becomes a bit of a challenge. So in lines with what Virottam said just now, what we do is we have access to rows. So if we find a malignancy, be that a lymphoma, be that a lung cancer, we would actually try and do it. But if there's any other diagnosis where we don't really need extra tissue, we probably won't go ahead and do it because, like you said, it's a procedure which actually requires quite a bit of skill and probably is 3 notches above doing an EBUS, my experience.
It's an add-on procedure, so it's an add-on procedure, not requiring every EBUS. Should start with an EBUS. If your EBUS is not giving you a definitive result, you need a higher volume of tissue. It's an add-on procedure. Luckily, it does not require any other add-on equipment except for the 1.1 mm probe. Using the Olympus system. It is an Olympus system, and the 1.1 mm probe is standard. I think always has patent also created that.
Therefore, thank you, Dr. Subnels, wonderful presentation. Thank you, Dr. Singh, wonderful presentation. Thank you, Dr. Abhishek sir and Dr. Swapnil. Now, I would like to call our organizing secretary, Dr. S.K. Pathak sir, to present memento and Vastram to our speakers. Let us speak, yeah. Dr. Anshul Mittal sir.
आप ऑडियो पकड़ेंगे यार
Definitely, sir. Dr. Swapnil Pathak.
हमारा
Dr. Anshul Mittal sir. We would like to give memento to our chairpersons also. So I would like to call Dr. N.K. Srivastava sir to present memento and Anvastram to Dr. Virottam Tomar sir.
ऑडियो हम पकड़ लें
Now I would like to call Dr. Akhilesh Singh sir to present memento to Dhoni Bhatia sir. Dr. Akhilesh Singh sir to Dr. Mohit Bhatia sir. Would like to call upon Dr. S.K. Pathak sir to present memento to Dr. K.K. Tripathi sir. Permission, Dr. K.K. Tripathi sir. Thank you, our speakers and chairperson. Moving towards session 2, we are running short of time, so moving towards session 2. For session 2, I would like to call upon chairpersons Dr. Anshul Mittal sir, Dr. A.K. Sharma sir, Dr. N.K. Srivastava sir, and Dr. Monika Gupta ma'am. So please come on the dais. Yeah. Now over to our chairperson for session 2.
इवनिंग एवरीबॉडी ये हम लोगों ने बहुत हाई टेक्नोलॉजी डॉक्टर सपने ने डॉक्टर से सुना और हम लोगों की जानकारी हुई कि इस तरह की चीजें हैं बनारस शहर में तो होती नहीं है। मैं उम्मीद है कि बनारस में भी सपने आएंगे तो शुरू करेंगे और हमको ये पता तो लगे कम से कम क्या हो रहा है। पहले हमें याद है कि अपने टाइम में हम लोग करते क्या थे कि 3 महीने का ट्रायल दे देते थे एक टीका और उसको फीवर कम हो जाता था तो सोचते थे मुझे टीबी है और नहीं तो कुछ दूसरा है। और ये मुझे याद है अच्छी तरह से कि हमारे एक डायरेक्टर हुआ करते थे एमएस के, उनको 9 महीने तक टीबी का इलाज चलता रहा और फायदा नहीं हुआ। अंत में डायग्नोसिस सार्कोइडोसिस को बढ़ी। तो इस तरह की लेटेस्ट टेक्निक जो आई है इससे डेफिनेटली बहुत फायदा होगा। अब the next topic is very practical topic, that is dyspnea, and I'm sure every physician, every surgeon faces this problem. Abhi I'm sure Dr. Pathak is here and he will justify the topic. There are so many causes of dyspnea like lung disease, tuberculosis, complications of tuberculosis, bronchial asthma, heart disease, renal failure, anemia, etc., etc. So, learned Dr. S.K. Pathak is definitely justify this, and I'm sure the audience will be benefited a lot. And Dr. Pathak is very long introduction, but the main introduction is Dr. Pathak is MBBS from GSBM Medical College, and he has done his DCH also, and after that he did his MD chest under Dr. Rajendra Prasad Sir, and he is sitting over here. चेला और गुरु दोनों सामने, इससे ज्यादा इंट्रोडक्शन की कोई जरूरत नहीं है और टाइम कम है। लीव ओवर टू डॉक्टर पाठक।
Thank you, sir. Thank you, all others and respected chairpersons. The topic is for general practitioner, medical emergency, dyspnea, management, how we can go for that. Topic well, and every doctor facing this problem in this clinic, in hospital, diverse. So we have to know this. First of all, I welcome all of you on behalf of Respiratory Conference. So thank you so much for this conference. As a topic, everyone knows that there's so many samples and common symptoms in general practitioner. Diagnosis can be challenging as it appears in the multiple disorders, most common respiratory or cardiac. Underlying disorders can range from the relatively simple to serious condition, and timely management, diagnosis, and initiation of appropriate therapy is required. At least your purpose, and every physician, including general physicians, should be equipped with evaluation like the patients. So there are many physicians working in the clinic and hospital, they have to know about this. What is the about the breathlessness? There were developing many groups and symptom wise and onset of disease. It can be acute breathlessness. It can be developing acute and chronic. The most common cause of the acute breathlessness are the pneumonia, or acute COVID bronchitis, congestive heart failure, pneumothorax, hypertension syndrome, foreign body aspiration, diabetic condition, or other metabolic disorders. As a chronic breathlessness, which is the more common, if the common chronic expected causes are not or I consider anemia, and important, and the hypothermia, and obesity, chest wall pathology, and neuromuscular disease. These are also the common causes for the chronic breathlessness. So, we can divide in chronic. You are as a causes of breathlessness group by the speed of onset. Very important. How times dyspnea and what time dyspnea presented to the patient is very important. As a dyspnea may present experience onset and the pneumothorax and pulmonary embolism patient came to the clinic or hospital with a short history after 1 hour, 2 hours. We have to suspect which may be the cause, for this availability. When acute minutes, hours, the patients come with hours, 10 hours, 10 hours, 8 hours. You have to suspect that COPD, the current which is pneumonia, pulmonary edema, pulmonary vascular diseases, regarding like acute myocardial infarction, arrhythmia, pulmonary heart diseases, and recommendations of hypertension. And the subsequent this patient comes with history after 1 to 2 days, 3 days, 1 weeks. You have to suspect that other others may be the lower collapse and respiratory pneumonia and CPA will obstruction, pulmonary vasculitis. But according to 1 to 2 years, 2 patients come with history of 1 year, 1 week, some those patients are. You have to suspect that similar and plus. COPD is one of the most common cause. The decreased temper, which is like ALD, and pulmonary vascular disease like chronic convoluted disease, and pulmonary hypertension, and hypertension syndrome, and chest tachycardia. The third actually one of the important cardiac chronic onset of this. The cause of breathless with normal action. First, we have to advise rule out the cause of dyspnea. The action is very important tools. So we have to segregate and breathlessness with normal action. The normal action related to dyspnea is the acute disease like asthma, upper respiratory infection, bronchitis, and pulmonary vascular disease, early parenchymal disease like sarcoidosis and pulmonary disease, and cardiac like angina, arrhythmia, located with normal X-ray and neuromuscular vascular spectacle disease within the thyroiditis hypertension. These patients are put in normal X-ray. The cause of epileptic and intermittent breathlessness. Patient are put in epileptic and intermittent. The asthma is one of the important causes. Pulmonary edema, angina, pulmonary embolism, and hypersensitive pneumonitis, vasculitis, hypertension syndrome. And that is one of the important causes. Additionally, if you rule out all other pathological causes. As a basic factor, from the police states how we define the tetrapenia, megaprenia, atropenia, you must know about this converse. Now the SOB grading, you already know that how you can give the SOB 0, 1, 2, 3, 4, 5. The pathology, as you know that it may be the control ventilation where the circulatory factors may affect the respiratory circulatory response, where the dichotomy in like pH, PSO2, living and respiratory, working on chest wall, and try to send is triggered to the vocal muscle smallness and chest wall and hypertension. So after the stimulation of the media, the breathing muscles and parts of lungs working as a hyperventilation and district ventilation. This is a very important part of the diagnosis. So we have to take history as a complete history. The complete history is the history of the cardiac or pulmonary problem, and determine the conversion, duration, and the occurrence of the arrest progressive. Cough may present asthma. Pneumonia and cough change the characters of symptom will be the acute examination. Pneumonitis should be the case of the sore throat, and children fever is often associated with pneumonia and throat bronchitis. So history must be seriously. The chest pain may be the cardiac, neuritis, and vascular skeletal. Pneumatic chest pain may be due to the bronchitis, pneumonia, and pneumothorax. And due to the pneumothorax, severe shortness of the 1 to 2 hours severity of congestive heart failure. Consider non-respiratory causes like anemia, acidosis, कुछ दिन पहले मेरे पास क्लिनिक का पेशेंट आया था और सांस लेने की प्रॉब्लम लेके आया चिकित्सक को संपर्क किया जनरल प्रैक्टिशनर को और सभी ने उसकी अस्थमा की डायग्नोसिस बना के ट्रीटमेंट शुरू जबकि उसका जब हेमोग्लोबिन सीबीसी इज द वेरी इंपॉर्टेंट थिंग hemoglobin was 73 grams after bleeding patient was operated. So after CBC is one simple tools with the diagnose and severe breathless situation severe shortness of breath 1 to 2 hours if you have taken and I know chest pain shortness of breath of myocardial infarction. But about the distributor will be about gravity and about important thing Please, the question of history of the best column है जो कच्ची गुजारे आती है उनको कैसा लगता है ये this may aspirate the lungs and the micro pneumonia and micromeningitis that cause the breathlessness. Anxiety symptoms may be a psychotic causes adverse effect like beta blockers. And we are not to be a beta blocker to the electric cardiologists generally use the beta blocker that signals beta blocker must be used for the patient with heart disease. History of alcohol and predicament according to PMD, so history of alcohol. Spectrum is a very important tool also called as the distillate. Why do we call spectrum in the customer of own temperatures? Well, the Korean clean aeros spectrum may indicate the respiratory infection. With the blood can be indication of the carcinoma of the lungs after coming to the process coming Protein white or pink spectrum indicate of fungal this cut spectrum is feature of silver light fatty customer. How this label spectrum is an indication of the respiratory infection. And the physical examination is very important after physical. We have to examine the thoroughly every part of the body, but it must be understood the respiratory system during the severe person correlation may present with asthma, COPD, with cardiac component, which item may indicate the upper respiratory access. The rigidity may be present with the component caused by the severe COPD, the cardiac component. Also, check the thyroid, get regular respiratory escalation as thyroid. The physical examination, cardiac and pulmonary, take the chest function, cutaneous emphysema and percussion of the pulmonary indication for the consolidation on future. Hypertension to the indicators are cholesterol. And so, expected the heart, lungs, are normal, for whisper, heart sound, absent of the sound, maybe the pneumothorax, very important. Patient with dyspnea, you have to not put the stethoscope on the chest, from the diagnosis for the check. And teacher the reaching sound may be projected affecting the digital, when the rapid will the heart may be the signify the dyspnea, unless the left and says to elbow destruction and to heart failure. The loud beating may be the sign of a pulmonary hypertension or PST or the cardiac. As a normal may be the indirect indication of the district or the failure, and the distant heart sound may be the presence in the cardiac component. Abdominal is a for the imputability and scientists, and especially in case of the CPT imputability will be observed. When the extremities are the access for the edema, sign as a finger edema, and this of the example by the clubbing and sinus is very important to examine the patient. Clubbing, there are many causes for the clubbing. It may be the ILD, it may be the CLS, and many other things. We have to practice in the clubbing causes. We have to examine the clubbing. Patient को फिंगर के लेंस को देखना से पेशेंट को कुछ समझ में आएगा लेकिन आपको बहुत कुछ समझ में आ सकता है. As a diagnosis workup was absolutely one of the important tools. Initial diagnosis, ready crops are opting the pneumonia, COPD, coming to heart failure. But this is what must be done for the patient of dyspnea. Myocardial infarction, rule out the angina thing, angina dyspnea. The detail can be taken for family important tools for diagnosing the patient of coming. For the clinical investigation, we have to order for the spectrum examination, appearance, microscopic culture and history and cytology, radiology, specifically and tomography, radiology screening, bronchoscopy, lung function testing, oscillatory, ABG, columns and ABCD and lung biopsy. These are the order. These different kind of this thing. For the initial assessment, we have to validate for the patient the initial airways patency, condition of the lungs, observe the breathing pattern, use the assessment muscles and monitor the cardiac rhythm, measure the vital signs and cause of after any history of the cardiac pulmonary or trauma, to the mental status of patients during the examination. If the further assessment is required, once the patient is to the emergency department, the teaching out the history of problem and determine the level of activity on the airways, mental status and ability of the speaker during the first process. History about the medication use, the lip of fever, chest pain, duration of breathlessness, and underlying cardiac problem disease is restricted. The physical examination done by the changing vital signs usually of the breast sound, abdominal, the skin color, and especially the signals are around the victim. Recognition of the management of insulin patient, the patient, so every patient with symptoms like hypertension, hypersensorial, hypoxia, unstable angina, spider, facial, illusion, and neurotraction, respectively more than 40. First, administer the oxygen, intensive integration is needed, urgent, and we establish the IV assess and start the IV boost, oxygen, and perform the new 4% C patient development. 4% is a pneumothorax, the critical technical, to relieve the patient in the case of the pressure pneumothorax. Administer the nebulizer solution, the patient of history of COPD or asthma, transfer the patient to emergency department, retain health care of them to save the patient life. At the clinical presentation and privacy, the patient presenting either of the breathless, the capilla, the price, mediation to determine the degree of emergency and the severity of symptoms. The following treatment trials will be utilized in the management of the patient. Oxygen therapy, as we have to start adjusting indication of oxygen, the cardiorespiratory arrest and hypertension, soft and respiratory distress, angina, and anxiety. The medical oxygen therapy, the renal cannula, oxygen mask, or venting mask, the oxygen delivery system, also supplied with oxygen cylinder, that will be white coupled with kilometers, oxygen TB, and delivery of the device, finding much complication who are identified more than 2 or 3 liters oxygen. As oxygen concentration with oxygen flow related to hydrogen for the 40% with the sprinkler and 32% with 46 liter and 4 liter with 38%. When we are utilizing the patient for the oxygenation, we have to suspend how what kind of the oxygen we are promoting the patient to. When the limit of patient is recommended, the patient is more than 4 liters oxygen required. When the oxygen toxicity is observed in some cases, especially in case of COPD, we have to arrive high oxygen for the suffocating largest. When you COPD, the COPD operations, we have to not use the right oxygen. We have to use only the limit of 90 to 94, 95, 94 to 100%. And we use electrolytic carbohydrates after and use the high rate oxygen or high level oxygen. As a different addition changes, that is usually the most common cause to include acute asthma, pulmonary infection, pulmonary system, some usually tension like epiglottis problem, and automatic asthma, and everything in the solution to the children. I will consider the foreign body special case of special for the children, people baccalaureate need some respiratory infections. And summary, respiratory people is the common preventive symptoms to the general practitioner. Crucial role of the GP is to assist in the respect of the need for oxygen inhalation and unstable patients often require intravenous access oxygenation or possibly the intubation and ventilator support. The cause of the risk of the include or coding of common respiratory disease. In a stable patient, the underlying cause of determined after the proper diagnosis and relation of shown. The management depends on study value. After oxygen, we have to use the wiper. The long lecture about the wiper. We have to choose if this is not maintaining oxygen with normal oxygen cylinder or normal oxygen. This is the second step. When patient failure to the wiper, we have to go for preventive support. The very important tools to save the life. We have recommend the patient is not responding with wiper or normal oxygen. We have to include patient as an object and look at ventilating problem. In the long lecture, the ventilating support or interval, if you need to short time, you have to just go this lecture here. Thank you so much. Thank you.
Very good lecture, Dr. Pathak. Congratulations. This happens to be the bread and butter for most of us sitting here. So I think his deliverance was perfect. I wonder if anybody has any questions. If there are no questions, there is one thing I want to add that for us physicians, even BNP we use as one of the markers, one of the quick markers to assess the respiratory, dyspnea cause. Dr. Ajay Pandey is there. He will tell us. Boss, I'm sure you will agree with me that BNP is one of the markers to assess the reason for breathlessness.
I think it was a great session after this. Partner has already planned a very good case discussion regarding that. But I agree with you that biomarkers are now very important tool nowadays, and there are no point of care devices now which we can use in emergency medicine as well. Anybody presenting to an emergency with partner of dyspnea, we can very well differentiate between the cardiac dyspnea and respiratory dyspnea and the help of DLP and other cardiac markers. We have one case presented, Dr. Sakshi is presenting in the upcoming session. We will have a great discussion during that time. But I do agree that these, BNP, anti-proBNP, and cardiac markers, types and CPLD, they all act as a very good tool for rapid diagnosis of cardiac versus respiratory disease.
Any questions for the chairperson?
Dr. Pathak, you answered everybody's queries actually. You were very good in your lecture. And I must congratulate you that the crowd, wonderful. All, you really put in a lot of effort. Congratulations.
So thank you very much, sir. Now I would like to call upon Dr. Deepak Kala, sir, to present momentum to our speaker, Dr. S.K. Pathak. Asia Pacific Alliance for Control of Influenza. He is Joint Secretary, Indian Academy of Allergy. He is founder member, Southeast Asian Academy of Sleep Medicine. He has 157 international and national publications in English journals and abstracts along with 21 book chapters. He is a lead author for Embark India. He is associate editor of Respiratory and on editorial board for multiple other journals. He has been awarded with Brahmacharya Award Excellence in CME in India, Indira Gandhi Gold Medal for Outstanding Clinical Achievement in Medicine. He is coordinator of DMB course for the last 8 years, and he started first DMB respiratory course in Bangalore. And there is one more thing which is not written there, which I know that he has represented his state in badminton.
Thank you very much. All of these credentials, big credentials. I would like to mention a few of his recent publications, obviously the Lancet as well as European of respiratory medicines. Those were the printed specifically in India, results from European Center Basin, I don't know, and another one, the clinical practice guideline, Indian consensus based on the recommendations on pneumococcal vaccinations. So you can understand is right from the not only the chronic disorder of respiratory, along with the every area of the only medicine, he has got the mastery. So please listen to his presentations.
Thank you so much. Thank you very much. I'm really touched with embarrassed. Thank you so much. Always a pleasure to come and speak in Varanasi. I'm sorry, the title of my talk is wrong. I started off thinking that I would talk about asthma and COPD, and then Patel Saab is very kindly invited me to every of the meetings, asked me to also speak on IL. I know we are running short of time, so I'm trying to give some half an hour. Bear with me, and if I'm running out of time, please tell me and I'll stop immediately. So that's what is on the angle. I'll talk a little bit about these individual diseases. I'll talk about chronic obstructive pulmonary disease, about asthma, and about ILD, and I'll put that in the perspective of cases, presenting the current guidelines in the perspective of that particular case. So let's start off with what is probably the most important challenge for us in the chronic disease scenario, not just in this village, but all over all global chronic diseases. That's COPD. When we think about the global burden of COPD, the prevalence in men is 11.8% of the global population. 11.8% of the global population, and more importantly, 8.5% in women, which is a sharp rise from what it was 10 years ago. If you look at non-smoking COPD, which is, like I said a little while ago, a bigger challenge in India, it's above 3% of the global population. So large numbers, but the impressive part of COPD as chronic respiratory disease is the mortality. And you can see the numbers there. The death rate is 4.72% in all-cause mortality, which is second after ischemic heart disease, and third is other areas disease. So low respiratory tract infection comes in third that particular way. So 3 million deaths globally is what we are looking at when we think about COPD, and that's the global birth of the disease data from 2019. This is what we were speaking about a little while ago. 2005 rankings versus 2016 rankings of the commonest cause of death. And I'll use my cursor and put the slide pointer shows up there, but you can see COPD at third about in 2005, on to second now as the largest killer of various diseases throughout the world. What's the number of years that are lost from COPD? For a 65-year-old man, you can see if you've got mild disease, stage 1 disease, you lose less than a year. But as soon as you get to moderate disease and then severe disease, it's close to 6 years of your life that you lose. And if you're a current smoker, so now 3.5 is current smoker. If you're a current smoker, or if you have a past history of smoking of more than 20 pack years, you've added another 3.5 years of life lost in that calendar. So
6.5 plus 3.5, that's about 10 years lost if you are a current smoker, if you've smoked beyond 20 back years. A little bit about the disease trajectory and what causes COPD. I want you to look at the green line first. The green line shows you the normal decline of lung function over a 25-year period. So that's the normal decline of lung function. Now, look at the red line beneath it. You can see decline of lung function starting at around the age of 30. And the red line dips downwards sharply. And that's the 6 years of life lost when we talk about patients with COPD. So these are patients who have smoked or have an environmental trigger like biomass or exposure to incense stick, air pollution, etc. That's the data that we see in patients with COPD. Look at the orange line next. That's another cause of COPD. That's COPD because you are born with small lungs. So it's small proteic lungs, but the decline of lung function is less precipitous, but you end up with the same level of lung function after 50 years. So two causes. One is environmental triggers resulting in decline of lung function. So we spoke about smoking, we spoke about biomass, air pollution, incense stick, all of which causes non-smoking COPD. And the second is small proteic lungs, which we are born with, that results in decline over a period of time. Both result in similar decline. What's the proportion? So about 70% of COPD is caused by decline due to environmental factors. About 30% is due to small proteic lungs, which causes COPD. This is from Gold, and this looks at etiotypes of COPD. So that's a new terminology. It was a new terminology for me and maybe for most of you. This helps in classifying COPD into various categories. So you can see I won't read through all of them, but this tells you that when we did medical school, we were taught that the only reason you could get COPD is by smoking. So you start off by looking at genetically determined COPD, which is COPD-G. Then you look at abnormal lung development, so that's the alpha-1 antitrypsin deficiency, etc. So that's COPD-G. Then comes the environmental factors, and we've spoken about these. COPD-C is from cigarette smoking. COPD-B is from biomass and air pollution. COPD-I is from infection. That's an important category in our country. If you have TB, and even if you have full treatment, post TB over a period of about 5 to 7 years, you start getting a precipitous decline in lung function, and you behave like you have obstructive airways disease akin to COPD. So we are just about to publish our data from a 20-center study on COPD, which shows that the decline is impressive and it carries over up to more than 10 years. So that probably makes us think. There's a lot of people who have advocacy, these people who treat TB, who make guidelines for TB, and maybe follow up TB even post-cure is something that we need to incorporate in our guidelines going forward. And that's an important point to remember. So COPD-I, COPD-A is the overlap of asthmatic COPD that we spoke about before. And then you have a category which is always there in all chronic diseases, which is COPD-U or COPD from unknown causes. So this is what I'm going to do in the COPD ambit over the next few minutes. I'll start off with this case study. So this is a patient we saw not so long ago, a patient that you would see here. There's nothing great about this particular case, but tells you about the life history of a COPD patient, and we'll try and discuss them in the perspective of guidelines that are currently available. So this chap complains of breathlessness over the last 2 to 3 years. He's 58. He's noticed breathlessness for the last 2 to 3 years and has been worse for the last 6 months. He's worsened significantly before coming in to hospital. He's got a current exercise tolerance of 50 yards. He feels breathless when he incline. He feels breathless on walking upstairs just a few steps. His cough is worse in the morning. However, there's no change in character, and he produces thick, tenacious sputum, which he says is difficult to expectorate. There's no hemoptysis, there's no paroxysmal nocturnal dyspnea. He does not have ankle swelling, there's no chest pain. Those are all the negative history in this case. There's a family history here, and maybe this is something to think about. He's got a brother who has asthma. So now makes you think whether you need to go back into the child history, whether there were symptoms of allergic rhinitis, wheezing in childhood, and this would actually be an asthma COPD overlap, the A category of COPD that we spoke about a little while ago. However, Given the fact that this guy does not have a child history, we'll treat this as COPD for the time being. And you can see he's got a trigger, the environmental trigger we spoke about. So he's a smoker of 20 back years, 40 back years of smoking with occasional alcohol. So this is from bone. And I want you to think of this slide in the perspective of the case that I described to you a little while ago. So these are symptoms which are thought to be important in the diagnosis of COPD. Symptoms which are important. So dyspnea, which is progressive, compared to intermittent dyspnea in patients who have asthma. It's worse with exercise and it's persistent. This recurrent wheeze, even though again, this wheeze is persistent compared to asthma, which is intermittent. There's a chronic cough. There's recurrent lower respiratory tract infections, which is similar to what you get in this particular patient I'm speaking about. And there's a history of risk factor. And in this particular patient, that risk factor is a 40 pack year history of smoking. So coming back to the patient again, this gentleman is short of breath on moving from the waiting room to the consultation room. There are no other general abnormalities. He's not clubbed. He's got a tracheal tracta. So for the youngsters, I don't know whether you're taught to check for tracheal tag anymore. But if you take the shirt off, if you look at the individual, you will see hyperexpansion of the chest. You will see indrawing of the subcostal region, and you would hear globally reduced breath sounds. So these were the investigations we did. And again, this is sort of our undergraduate teaching or maybe postgraduate year postgraduate teaching. But if you see an X-ray like this, you think COPD, hyperinflated lungs, tubular heart, wide intercostal spaces, all of this equate to emphysema, air trapping, and COPD. This gentleman had a normal ECG. This is the cartoon of the flow volume and the volume time group of this individual, and these are the numbers. And you can see on there FQ1 of 1.91, which is 62%, which represents moderate COPD. So again, the role of spirometry in COPD was something which was becoming a non-entity in 2022 and even before that. We wrote to goal, we actually as a group wrote to goal, talking about the importance of COPD outside the ambit of diagnosis. So till 2022, they would say that COPD diagnosis was only based on spirometry. The new COPD guidance, and we're proud to have a member from India in the whole committee now with Dr. Sandeep Salvi being there. So it has come out with a list, which is the role of spirometry in patients with COPD. Can be a little bit quiet because I'm getting this stuff. A little bit less of talking, please. Thank you. So the diagnosis is important when you're diagnosing COPD. Assessment of severe airflow obstruction is important. And then follow-up assessments, therapeutic decisions, etc. are important based on which spirometry is done on these individuals. So remember, for the juniors, the youngsters in the audience, it's not just for diagnosis, it's very important for diagnosis. You cannot diagnose COPD without doing a spirometry, but the assessment of airflow obstruction, follow-up assessments, especially when you do an intervention. So you heard Anshul talking a little bit while ago about mediastinal cryobiopsy. If you're doing lung volume reduction therapy of any nature, you would need a spirometry pre and post the procedure. If you're doing something simple like rehab, for instance, you would want a spirometry pre and post. And these are all factors that need to be remembered as indications for doing spirometry in patients with COPD. So the result of all these investigations, the history, the fact that this patient has a ratio of less than 70% and an FEV1 of 62%, shows that this patient has an obstructive airways disease, and with no bronchodilator reversibility, this patient has COPD. The clinician that the patient went to initially also did the transfer factor, and the transfer factor was 61%. Again, for the juniors, if you find someone with COPD and you happen to do a transfer factor in these patients and it's low, it's one of two factors, and that's important to remember. So either these patients have predominant emphysema because of destruction of the alveolar membrane, you get a lowered transfer factor, or it's an overlap of pulmonary fibrosis and emphysema, something which is called CPFE, the combined pulmonary fibrosis and emphysema. And here, something important to remember is these patients have preserved FVC, but a very low transfer factor. So if you see a spirometry which shows a preserved FVC, a very low transfer factor, think that on CT, you might see a combined pulmonary fibrosis and emphysema in these individuals. So what did we do? We recommended the importance of discontinuing smoking. We asked them to get vaccinated for influenza. We referred for public rehab, and we started these patients on an ICS and a LABA at this point of time. So this is a while ago. You wouldn't do that just now. For this patient who's relatively stable, you would actually start off with a LABA-LAMA combination at this point of time, rather than doing an ICS LABA, which was what was done back in 2016. So these are the gold grades that you see. We spoke about 62% FEV1. So you can see mild, moderate, severe, and very severe COPD. Gold 1. So the ratio, remember, is always less than 70%. But gold 1 is an FEV1 of more than 80. Gold 2 is an FEV1 between 50 to 80%. Gold 3 is an FEV1 between 30 to 50%. And less than 30% is gold 4. This is the current tool for assessment of COPD. You can see it used to be A, B, C, D at one point of time. Now you have A and B, and then you have E. So we'll start with E. E is the exacerbating population of patients. So if you require 2 courses of oral steroids or 1 hospitalization in the past year, you get classified as the exacerbating population of COPD, which is called Gold E. Gold A and B are based on the symptom burden in these individuals. So if you have less of symptoms and no exacerbations, you are gold A. If you have more of symptoms and no exacerbations, you become gold B. So going forward, I think the gold guidelines will have an S and an E. S being the stable population of patients and E being the exacerbating population of patients, because you treat these patients similarly. But that's sort of looking forward into the future. These are the vaccinations that are recommended for gold, and this is a major change in 2022-23. So in the 2023 guidance, we have gone beyond influenza vaccination, which is supposed to be an annual vaccine, and the pneumonia vaccination, where you have 2 different kinds of vaccine. One is the 13-valent vaccine, which promotes your humoral immunity, which is the Prevnar 13 vaccine, and then you have the 23-valent vaccine, which mediates your T-cell immunity, which is the Pneumovax 23 vaccine. These are now out of patents. I'm telling you commercial names, and these will probably not be allowed in a few days' time. But as of now, these are the only vaccines that are available. However, along with this, there are other vaccines that are now required in patients with COPD, which you need to remember. So one is the COVID-19 vaccine. We still don't have guidance about COVID-19, but for healthcare workers, it's probably wise to take an annual COVID vaccine for the next couple of years, and hopefully the government or the ICMR will come out with guidance in these lines in the not so distant future. More importantly, the shingles vaccine, so the herpes zoster vaccine and the whooping cough vaccine, which should be given to the at-risk population of patients. So patients who are above 65 qualify as being at-risk, and the ones with comorbidities, the ischemic heart disease, the diabetes, the hypertension, and so on and so forth, they are the comorbid population where these vaccines should be given. So 5 vaccines: influenza, pneumonia, COVID-19, whooping cough, and shingles constitute the 5 vaccines that you need to offer to patients with COPD above a certain age or people who are comorbid. This is important. This is an important science line for postgraduates for their exams, but it's also important for all of us. It's interesting to see that studies have mainly shown that it's the non-pharmacological agents which make a difference in mortality for patients with COPD. I'll say that again, it's important. It's non-pharmacological strategies which actually make a difference to mortality in patients with COPD. The first trial, which showed that there was a mortality benefit, were 2 different trials carried out in 2021 and 2022, which tried the triple and found that there was a mortality benefit. So when I say a triple, I mean a LABA, a LAMA, and an inhaled corticosteroid. Aside from this, you got a list there: smoking cessation, pulmonary rehab, long-term oxygen therapy. You heard Dr. Pathak speak about non-invasive ventilation. So non-invasive ventilation and lung volume reduction surgery are the modalities which are non-pharmacological, albeit one surgical, but non-pharmacological measures which improve mortality in patients with COPD. Important to identify and reduce risk factor exposure. That's primary prevention. So smoking cessation, well ventilated rooms. You heard people who were there during the press conference, heard a lovely little spiel about how you reduce exposure to things like fumes when you're doing puja, for instance. So all of that would come into reducing risk exposure in these individuals. That's pulmonary rehabilitation. That's something all of us need to do. As long as you give your patients an exercise prescription, it does not need to be rocket science. Even walking, climbing a few steps, doing upper and lower limb exercises, chest expansion translates into exercise and improves mortality in your patients with COPD. It reduces exacerbation, it improves mortality, it reduces symptoms in your patients with COPD. I'll skip a couple of slides and I'll go through the patient again. So this patient stabilized over the next 4 months, so stable COPD, we're talking gold B COPD here, but then had an exacerbation which brought the patient to hospital. Severe breathlessness, which had gone on for a couple of days, now was breathless in hospital on the hospital bed. Cough with yellow sputum, right-sided tultic, should read left-sided tultic, chest pain, difficulty to sleep and swelling of the ankles. So this patient has progressed rapidly and now has cor pulmonale along with having COPD. Sick patient, respiratory rate of 40, central and peripheral cyanosis, tachycardia with a heart rate of 120, BP of 130 by 80, features of heart failure with the raised JVP, and muffled heart sound, which is more because of the emphysema rather than any other effect. And edema up to mid-calf, which punctuates the cor pulmonale I spoke about. And this patient has left lower lobe tracheal. Let me show you the X-ray before I go on to the rest. So that's the X-ray, and you can see the left lower lobe infiltrates in this individual. So this shows you the classification of severity of COPD. So classification of exacerbations of COPD. You can see mild, moderate, and severe. This is the current gold guidance, and this was based on the Rome classification. Even if you don't read anything about gold from 2023, do this one particular slide, which I won't read out for the want of time, but see that between mild to moderate, there's a change in increasing of dyspnea, increase of respiratory rates, increase of heart rate, reduction of resting saturation, and a raised CRP. And between moderate to severe, if you develop acidotic hypercapnic respiratory failure, so as soon as you develop acidosis, respiratory acidosis, you go on to the severe category. So that's mild versus moderate versus severe. This is the first time ever in the history of COPD that an objective measurement for defining exacerbations of COPD has been given in a guideline. So we thought for our patient, this is my 58-year-old gentleman, we thought this gentleman might have one of these five. So those are the differentials: exacerbation of COPD, a pneumonia, pneumothorax, possible pulmonary embolism, and you heard about the overlap a little while ago when Dr. Pathak was speaking. So the overlap between cardiac breathlessness and respiratory breathlessness. So cardiac shortness of breath, maybe heart failure, maybe ischemic heart disease. So that is what you need to think through when you see your patient with COPD coming to the emergency with breathlessness. Not enough to take for granted that someone who's got a diagnosis of COPD has come into an exacerbation. That's the checklist that you need to go through in these individuals. And this again is from Gold. This shows you the differential diagnosis that Gold talks about when you think about differential diagnosis for COPD. So you need to do a chest X-ray in everyone. That's to exclude a pneumonia and also pneumothorax. You look at pulmonary embolism, you do a G-dimer in these individuals, stratify risk in these individuals, and then you have less frequent causes like pneumothorax, heart failure, etc. And you're going to hear more, I hear, about NT-proBNP and the role in distinction between cardiac cause and respiratory cause of heart failure in these individuals. So these were the investigations for this patient. Nothing to write home about. The chest X-ray I showed you a little while ago, but look at the ABG at the bottom here. So this patient has respiratory acidosis, pH of 7.29, PCO2 of 55, PCO2 of 72, and a PO2 of 54. So this is a sick patient who needs an intensive care admission. So these were the treatment measures that were given to this patient with COPD. So controlled oxygen, nebulized bronchodilators, IV antibiotics, oral steroids, prophylactic enoxaparin, so low molecular weight heparin. And this patient, a little while later, actually got worse. So the pH fell from 7.27 the pH to 7.27. The PCO2 went up to 76. So the patient was then put on non-invasive ventilation at this stage. After an hour, the patient felt marginally better. The ABJ improved with non-invasive ventilation, and 4 hours down the line, you can see the improvement. That's why non-invasive ventilation has a mortality benefit in patients with COPD. So you can see the pH has gone up to 7.36. The PCO2 has come down to 60 over a 4-hour treatment period. And over the next 3 days, this patient gradually got better, got shifted to a ward on day 5, and 2 days later went home, which meant a total stay of 8 days. An exacerbation takes out a lot out of the patient with COPD. It increases their mortality at 1 year, at 5 years, and hence trying to reduce exacerbations in these individuals is very, very important. Chairperson, can I have 10 minutes to talk about asthma? Yeah? Okay. So asthma, you heard a little while ago, is the commonest chronic respiratory disease worldwide. And look at those numbers, 358 million asthmatics worldwide, and that's the global burden of data. So 358 million, out of which 38 million asthma patients are Indian. So 38 million is about 11.7% of asthmatics are in India. However, think about the mortality. 43% of people who die from asthma come from our unfortunate country. So that's why talking about asthma, management of asthma, treating them right is so very important. Show you some interesting slides before I come to this case. So this is mortality rate for asthma in 46 countries over a time span between 1960 to 2012. So for 52-year period, you're looking at asthma mortality. I want you to see something. You see the spikes on the left. So on the left of the horizontal bar, on the left between 1960 and 1986, you see these large spikes of death. And then post 1980 to 2012, you see the higher mortality rates come down. And that's not because we have better drugs. That's because we understand asthma better now. So previously from the 1960s, even when I did my medical school, I was taught that asthma is a disease of bronchoconstriction. It's a disease of airway narrowing when the smooth muscles contract and these cause symptoms. And hence, the treatment for asthma was based on short-term beta agonists. It was SABAs, which mainly treated patients with asthma. Then over a period of time, over a period of many years, the understanding improved, and we now understand that asthma is a disease of inflammation, and hence anti-inflammatory medication in the way of inhaled corticosteroids are your treatment of choice for asthmatics. So paradigm shift. Bronchodilation being the main treatment of asthma shifts now to the fact that anti-inflammatory treatment, inhaled corticosteroids are your best treatment for asthma, and hence we treat asthma now with ICS. Any puff that an asthmatic takes should have an inhaled corticosteroid in it. If there's one message I can give the audience today to go back home, never give your patient an inhaler for asthma which does not have an inhaled corticosteroid in it. Right? So that's one important carry-home message. All asthma is life-threatening. So people perceive that mild asthma is not so risky, does not cause deaths. Look at the numbers on there. These are patients with GINA-defined mild asthma. And you can see more than a third of patients land up with an acute attack, at least one acute attack in any given year. About 16%, that's 1 out of 6 patients, will have a near fatal attack of asthma, even with a background of mild asthma. And then 15 to 20% of adults who die of asthma actually have background mild asthma. That's 1 out of 6 to 1 out of 5 patients dying of asthma has mild asthma. The exacerbating factors in our country are many. That's why deaths are so prominent. It's in the air that we breathe. Air pollution is one of the most important triggers. The PM2.5 that we inhale on a daily basis across our cities in this country are the important triggers of asthma that we cannot help but be with. But there are other triggers to think about. The risks of SABA-only treatment, important to remember, short-acting beta agonists should never be used alone in the management of asthma anymore. And what are the reasons? The Sigma study from 2019 showed that SABA taken alone increased exacerbations and increase deaths from asthma by a relative risk of 3.2. That's one of the biggest relative risk for mortality increase in patients with asthma. So remember, all of you, when you give your patients, if you give your patients a SABA as a reliever medication, you increase the risk of exacerbations and you increase the risk of dying early from the disease. This is what inhaled corticosteroids do for you. Inhaled corticosteroids reduce the risk of death. At the bottom, you see number of canisters of inhaled corticosteroids, and you can see if you're taking 12 inhalers a year, that's one inhaler per month, your chance of dying from asthma is next to nothing. You can actually prevent deaths in asthma if your patient is compliant to something as simple as an inhaled corticosteroid on a monthly basis. I've said mostly about what GINA 2020 recommends, but just very briefly, you can see that the reliever medication and the maintenance medication in asthma is the same in GINA track 1. I'll say that again. The reliever and the maintenance medication in track 1 of GINA is the same, something which is called single maintenance and reliever therapy or SMART therapy in asthma. If you look at track 2, there you have an ICS plus a SABA. So inhaled corticosteroid plus a SABA as rescue. You can take in track 1 your ICS for metron on an SOS basis. When you have mild disease, step 1 and step 2, you take the ICS and the formetron on an SOS basis. Thereafter, in both tracks, it's maintenance treatment. Just two more definitions before I come to the case. So difficult asthma and severe refractory asthma are two definitions that all of you need to remember. You don't need to remember them by heart, but you need to understand what the difference is between these two terminologies. So difficult asthma is when you are on maximal treatment, which is the maximum dose of inhaled corticosteroid, plus a LABA, but you have not corrected for things like compliance, technique, comorbidities, trigger factors, differential diagnosis, etc. So maximum treatment, but not corrected for these factors, is difficult asthma. Maximal treatment, but corrected for all these factors. So you corrected technique, you made sure the patient is compliant, you've removed the trigger factors for the patient, you address the comorbidities. If your patient's asthma is still refractory, that is severe refractory asthma. And GINA in 2018, for the first time, that's 5 years ago, identified 5 different classes of asthma: allergic, non-allergic, late onset asthma, asthma with fixed airflow obstruction, and asthma with obesity. I want you to remember 3 markers which are easy to do, cheap to do, in phenotyping patients with asthma. So the first is total and allergen-specific IgE, which proves atopy in individuals with asthma. So raised total IgE shows you that the patient is atopic. The next in line is exhaled nitric oxide, which is a marker for Th2 inflammation. You can go by the ATS or by the BTS guidelines. The ATS guidelines tell you that a pheno level of more than 35 shows Th2 inflammation. The BTS guidelines tell you that a level of more than 50 is Th2 inflammation. And then the last and the easiest is blood eosinophils. Blood eosinophils are a surrogate marker for yearly eosinophils, and hence again, they are a marker of Th2 inflammation. So I'll finish off in 5 minutes with this particular case. I'll whiz through the case. So please listen carefully. Something that will be helpful for you in your clinical practice. So this is a 36-year-old housewife who came to me from Rabindranath Tagore's native place. Shantiniketan is where this lady resided. She had a long-standing diagnosis of asthma. She had no addictions, but her husband was a smoker, so she had passive smoking, no biomass exposure. She weighed 77 kilos and she had a BMI of 27. So she was in the overweight category, but not in the obese category. So remember, this lady was overweight, no other comorbidities. This lady had had a diagnosis of asthma for the last 12 years. You remember, she was 36. She got diagnosed with asthma at the age of 24. And she had all through the year cough, wheezing, expectoration, allergic rhinitis symptoms, and sneezing. She was regular, and remember, this is one of the first tick boxes. She's compliant with medications. She uses the ICS LABA religiously. Initially, she was on a dry powder inhaler, and now she's on a meter dose inhaler. And we ensured that she's always taken her inhalers on a regular basis with the right technique. Historically, she used to have 1 to 2 exacerbations per year, and her GP gave her a course of steroids. She got better, and she went back to her inhalers again. 2016, the penny dropped in this individual. So, coincidence, the last patient was 2016. This too is 2016. But 2016, this patient required an admission to ICU, no mechanical ventilation. She was treated in outside hospital. And after stabilization, she decided to come to us as a referral from that hospital for further care. She was breathless and very unwell when she actually came to me in clinic. She did not come to the emergency. She came to clinic to see me. She was breathless, wheezing, lots of cough, phlegm, and we readmitted her because she was also hypoxic at the time of admission. This is an important slide, guys. This is how your clinical details should be written for your patients with asthma. So family history at the top, you can see she's got a positive family history. Asthma comorbidities thereafter. So this patient has allergic rhinitis but no nasal polyps. She has contact dermatitis. She's overweight. Remember, her BMI was 27. She has gastroesophageal reflux disease. And important to remember, she did not have depression, anxiety, which is one of the important coordinates, comorbidities that are important in asthma. Triggers, so those were the triggers. Dust, cigarette smoke, alcohol, cold, strong smells, all of these due to bronchospasm. They made her chest feel tight and she became breathless. She was on triple inhalation. She was on standard good going treatment for Gila step 5, maximum dose of inhaled corticosteroid, a LABA and a LAMA, which she took religiously. She was also on Montelukast for allergic rhinitis, and she was on oral steroids release salt. So we did these boxes, inhaler compliance ensured, inhaler technique checked, environmental triggers ruled out. She was overweight, so she had a sleep study done, and she did not have obstructive sleep apnea. These are the markers I told you about a little while ago. This is what helps us to endotype patients with asthma. So the serum Ig was very raised at 35. The absolute eosinophil count was 417. The exhaled nitric oxide was not available in 2016. And the lung function in young, don't have a graph to show you, but showed moderate obstructive airways disease with reversibility. So it was consistent with the definition of, spirometric definition of asthma. This is an allergic sensitization test. And the top bit tells you that this patient was allergic to house dust mite. The allergy to candida is not significant, but it's important that this patient is allergic, which is defined by house dust mite being positive. So that was the summary of this lady. Young lady with asthma, allergic rhinitis, GRD, and obesity being comorbidities, treatment exacerbations despite good compliance and technique, poor quality of life because of her daytime and nighttime symptoms, and oral corticosteroids for the last one. So the question I'm going to ask you, but to understand this patient is an Ig which is raised, a eosinophil which is raised. So this patient is atopic on the basis of raised Ig, is allergic on the basis of a raised blood eosinophil count. So the phenotype of this patient would be T2 high, overlap phenotype, overlap because both the Ig and the eosinophil is raised. So what is the next step? And to cut a long story short, to understand that this patient has a raised Ig, so you can give an anti-Ig to this individual, which in our country at that time was omalizumab, and you put this patient has a raised eosinophil, so you can give an anti-eosinophil drug to this agent, which can be in the form of an anti-IL-5 or an IL-5 receptor antagonist. At the time in 2016, there was only one drug available to us, which was omalizumab. So in 2012, we tried to optimize therapy by putting her on a triple, but then when we failed, we started on omalizumab. She was good. She improved even though she did not come to normal baseline. She took the drugs for a year, and over a year, you can see on that chart, look at 2017, 18, and then beginning of 19, she was reasonably okay. A couple of exacerbations requiring oral corticosteroids, but no admissions. And in 2020 thereafter, the penny dropped when she became COVID positive and then had significant worsening of disease. So symptom control got worse, went to another physician because she thought coming to me, I would insist about MABs again. So she went to another doctor, given oral corticosteroid, given a steroid sparing agent in the way of methotrexate, for which there is no evidence in asthma. But I guess you cannot fault the other physician because there was nothing that she could do to control her asthma despite good compliance. And then she had a very severe exacerbation and landed up with us in the emergency. These were her numbers at the time. So Ig is still raised, absolute eosinophil count still raised, FeNO is still high, and moderate obstructive physiology with reversibility. So practical problems in this patient with financial issues, no medical coverage, place of residence was away from the hospital, and lots of medical issues, symptoms, daytime, nighttime, psychological factors now to deal with. These were options that we academically, theoretically had. So restart omalizumab, try and mepolizumab or benralizumab had become available to us in 2021 and trying bronchial thermoplasty. But in our case, she couldn't afford anything. Thankfully, we had a trial for mepolizumab going on then and we restarted on mepolizumab. The trial went on for a year. She was fine for a year. However, thereafter, again, she's admitted to each day as we speak in the hospital with a bad attack of asthma. It's important to say that the effect of biologics will wane when you stop biologics. It will wean off patients of biologics over a period of time. And there are these overlap candidates when you've got a choice. And I think you need to make that choice prudently because these are expensive drugs for your patients. I'll stop there. I think I've taken more than enough time. So I'll speak about ILD to this audience another day. Thank you very, very much for listening.
Okay, sir. Listeners are requesting you to just go ahead with your slides.
I think 5 minutes. It's okay. I mean, I'll take
Well,
on parts. Yeah. So
everyone is listening very precisely, sir.
Okay. So very quickly, 5 minutes by the clock. So the incidence, so the prevalence and incidence data for ILD is far lesser as compared to what it is for asthma and COPD. This is a pan-European study. It's also got some countries in the Middle East in it, and it shows two different things. So this is the 2022 publication to which we also contributed from India with some cases. It doesn't show up on the slides because it was only our center that contributed cases. But this is a long list of countries which shows the incidence of ILD in these countries. And I want you to look at this slide, which is more important. It shows you the incidence and on that side, the death rate. So on the left of the bar diagram, on the left is when the incidence is reducing. And on the right is when the incidence is increasing. And you can see all the bars go to the right, none come down on the left, which shows that both the incidence and the death rate in interstitial lung disease is going up precipitously. So very briefly, diagnostic delay is a common problem in patients with interstitial lung disease, be that of IPF or the non-IPF category. So that's the important thing. The ILD India registry, our publication for the ILD India registry from 31 different centers showed that it took 4 years for the diagnosis of ILD. And you know the mortality from initial disease is about 3.5 years. So you understand why we never managed to diagnose our ILD. We will diagnose them, but we diagnose them only if they live beyond 3.5 years. That's the challenge with ILD. Many patients misdiagnosed, even ineffective treatment, and a timely diagnosis reduces unnecessary investigations and it improves outcomes in these patients. So this is a lovely slide from Dr. Lamas, one of our colleagues in Europe, who shows that later the diagnosis, greater the mortality. Look at the orange line which plummets downwards. You can see that from diagnosis, about 60% of people with ILD would be dead by 4 years. 40% of patients would actually be alive at 4 years if you had made a diagnosis of ILD beyond 4 years. So that's the result of delay in diagnosis. The reasons that we are diagnosed late, in my understanding, is insidious onset of disease, non-specific symptoms. These patients are breathless, and the symptoms are no different to what you would get in a patient with COPD, for instance, or an asthmatic, for instance. There's minimal symptom burden. There's scarce knowledge about fibrotic ILD amongst our primary care physicians and non-ILD experts, and there are few non-ILD experts in our country, and long waiting times at specialist centers. So what do we need to do? So we need to think about ILD when you have a patient who has breathlessness and a chronic cough. It's not always going to be airways disease. It can also be interstitial disease or parenchymal disease. Listen to the chest, and I'll come back to that in a moment. But listen to the back of the chest carefully with the stethoscope, an art which is being lost gradually as we're going past. If you manage to hear crackles at lung bases, That's something which is almost diagnostic of ILD in a population of patients. Look at the fingers. If you get crackles and you're clubbed, the sensitivity for diagnosis. So crackles plus clubbing, the sensitivity for diagnosis is as high as 90%. That's most CT scans. That's sort of diagnosis in most diseases. But a CT scan cannot do. Incidental identification of ILD, you bring a lot of CT, especially in the post-COVID era. So you will incidentally find ILD on imaging, and interstitial lung abnormalities are septal thickening that you get with the aging process. You need to prone these patients. If these septal thickenings go away, then this is fluid accumulation. If they remain, these patients need to be followed up in the long term, because about 60%, so 6 out of 10 people will end up having ILD at a later age. This is from the European Respiratory Journal, Vincent Cotan. Lovely words, I think. Very, very important for all of us to remember. The stethoscope is a genuine tool, probably the best tool for early diagnosis of IPF, the prerequisite for early treatment and improve long-term outcomes for this dreadful disease. And this is something I want all of you to remember. Doesn't require a lot of money. All you need to do is listen to the patient's chest. So look at quickly at treatment. And these are all the important trials that have been done in this area in the last 3 years, 2019 to 2022, all important trials. And I want you to think about these trials with me. So 2019, this is the Distler trial, which looked at systemic sclerosis interstitial lung disease. So scleroderma ILD, and they found over a 52-week, 1-year period, the drop in the antifibrotic group, which in this case for nintedanib, was about 40 ml lesser. Sounds a small number, but it's a significant number. 40 ml lesser in the antifibrotic group as compared to the placebo group. So that's the first trial. The second trial is from Flaherty. This looks at progressive fibrosis ILD, and again, this showed a whopping 150 ml reduction of FBC reduction. So the FBC reduced less in the nintedanib group as compared to the placebo group in the non-IPF progressive ILD group. In Lancet, Toby Maher showed that pirfenidone does something similar in patients with unclassified ILD. So Toby Maher Imperial showed that in patients with unclassifiable ILD, if you gave these patients an pirfenidone, they would cause a significant reduction in the downward descent of FVC in these individuals. And then again, in Lancet Respiratory Medicine from about 2 years ago, the same effect is shown with pirfenidone in patients with PF-ILD. So lots of data that these patients are helped by an antifibrotic. Last 2023 trial, they showed 2 drugs, tocilizumab. All of you would have heard of this drug during COVID. This reduces FVC decline in systemic sclerosis, and treprostinil, which is a drug which is used more by our rheumatology colleagues, shows improvement in 6-minute walk distance and FVC in group 3 pulmonary hypertension patients with ILD. So that's the summary of all the trials. But I'll finish off talking to you about ILD with this slide. I want you to remember and understand this slide. So the red bar at the top is patients with fibrosis. So this is patients with IPF, patients who have predominant fibrosis. The blue at the bottom is patients who have inflammation. So at the top, patients with IPF is all about fibrosis. There's hardly an inflammatory component, and hence there you would prescribe an antifibrotic in these patients. If you gave them a steroid or if you gave them an immunomodulator, these patients die quicker. So never use an anti-inflammatory drug in that class of patients. Now come down to the non-IPF ILD category, the CTD ILD, the chronic HP, the unclassifiable disease, etc. And you can see a transition from white to blue to red. And there's an overlap that you see between blue and red. And you can see in these patients, when this predominant inflammation, as in predominant blue, you give these patients something like a steroid and a disease-modifying agent like mycophenolate or isotretinoin, etc. And then when fibrosis sets in, you would prescribe these patients with an antifibrotic drugs. So when you look at these patients, think of the drugs that you give in these 2 different baskets, as an immunomodulatory drug and as a fibromodulatory drug. And you see a list on there on the left of drugs in development which you don't need to remember. But remember, when you prescribe it, make sure in your own head, ask yourself the question, does this patient have ongoing inflammation? If yes, they need steroids, immunomodulatory therapy. If they are fibrotic, if they have predominant fibrosis, think of giving these patients antifibrotic, and there'll be an important class of patients where there's both. And like so, the fact that we've got a massive load of chronic respiratory disease in India. COPD is the second commonest cause of death. However, if you combine the three diseases I spoke about, which is chronic respiratory disease, asthma, COPD, ILD, haven't spoken about bronchiectasis, also bronchiectasis, the cause of death, which is number one globally and in India, is chronic respiratory disease by far. And you go back to what Dr. Rajendra Prasad was saying a little while ago, too little attention on respiratory disease and too much attention on other diseases is something which is a strong carry home message from this particular talk. Classified diseases between airways disease and interstitial or parenchymal disease. And then airways disease need to be subclassified, asthma, COPD, then the type of inflammation and the phenotyping that I showed you with my 36-year-old lady from Shantini paper. ILD needs to be thought of as IPF and non-IPF, and then again non-IPF needs to be thought of as being progressive and non-progressive. And most important, irrespective of which disease, if you can diagnose the disease early, you're going to manage to treat these patients early and reduce a lot of morbidity and mortality that comes with the disease process. Thank you very much.
Dr. Bharat, thank you so much for this wonderful, creating wonderful flora and fauna, knowledge of flora and fauna around here. Friends, a legendary academician with his academic vista is here for your questions, if any. Yeah.
COPD exacerbation, you had ICU admission, but even why all the steroid one time very
The question is why oral steroids, why not IV steroids? So I agree with you. I think if you have a very sick patient, like my patient was, I would probably also give IV steroids. Just to say that from an efficacy point of view, the IV steroid is no better to the oral steroid. However, the reason we give IV steroids to these individuals mostly when they are very sick is because we worry about their absorption. We worry whether the patient is managing to swallow the pills properly or not. So all of those factors I agree with you. In most of my patients also, I would give them IV steroids for the first 48 hours, but de-escalate rapidly and come down to oral steroids. Point well taken. Absolutely. So question, very important question, and this is something which I should have said in my talk. So question is, should we continue the biologics for a very long time? The answer is a big yes. I mean, if you have no cost constraints, when I worked in the UK, we had patients on biologics for 10 years. So they would come, they would take an injection, they would be happy, they would go back home, and they would remain well for a very long time. The important thing with biologics to remember is you need to choose your patient well. It's not a magic bullet. It is a bullet which works like magic in the right patient. And that's very, very important. But in that category of patients, you need to continue long term. What happens if you stop? So that's also an important question. And that's been tried in various studies. There's a study which is called the INSPITAL study, which got published in 2021, where they found that 50% of patients, 50% of patients, after stoppage of the biologic for 3 years, you stop biologics after 3 years, the spike in exacerbations in 50% happens after 7.5 months. So these patients will exacerbate, but there's a residual effect which lasts for slightly longer. Some people have tried strategies like alternate months or half the dose in the long term, but that's anecdotal evidence. It cannot be used for clinical purposes in day-to-day practice or in the lecture for that matter.
excellent talk as usual. And the question raised by about the asthma, I always say from last 40 years I'm saying it's a chronic disease. It's a probably lifelong disease. And what Raja said, you get right, whatever drugs you are using, even you are using biological other things, probably has to be used for a very long time. And I say probably a lifelong. But how much dose, how to reduce, how to this is art. Thank you.
So I think it's status of this Conclave for type 2 inflammation.
So, question dupilumab in like TH2 inflammation. So, dupilumab is probably the most effective map. So, we don't have head-to-head trials, but if you look at efficacy, so FEV1, exacerbations, quality of life, dupilumab seems to have the best effect. It seems to have the best effect in patients who have a raised eosinophil count and IgG which is moderately raised, in patients who are obese and in patients who have concomitant atopic dermatitis. So that's the patient population who seems to actually respond best to dupilumab. And if I had a choice in the TH2 population, the eosinophil category of patients of dupilumab, I would probably put most of my patients dupilumab rather than depot and
The status of this inhalational biologicals.
Yeah. So inhalational biologicals, I don't think we have data as yet, but that's exciting. The oral biologics are also areas where we are looking at. Unfortunately, the last oral biologic, which Novartis was trialing, came back as a negative trial to the extent that Novartis has closed its respiratory division and made so much of losses. But I think this is a sort of a moving goalpost. Some of the trials are bound to be negative. However, most trials have shown positive results. Both the inhaled and oral area are exciting areas. Injectable drugs are difficult to convince patients for along with the cost. And I think we need to watch out. We don't have information both about oral and about inhaled biologics.
Dr. Raja, I have one question. Yeah. All right. I really enjoyed your talk. There was this about CLD associated with the type 3 pulmonary arterial hypertension. So, what is the main history of treating this patient with pharmacotherapy? Because alloprost, which works very well, but apparently it's not available in India. What about the insulin receptor agonist?
Brilliant question. So, question is group 3 pulmonary hypertension, which is chronic lung disease pulmonary hypertension. What is the treatment? So, the treatment, if I have to give you a one-line answer, I'll give you a three-line answer. But the one-line answer would be that none of the drugs which are pulmonary hypertension reducing agents should be used in group 3 pulmonary hypertension. That's the one-line answer. The three-line answer is recently these two drugs, one is Selexipag and the other is Yoshiga, have shown some improvement in the 6-minute walk distance in patients with group 3 pulmonary hypertension, especially in the ILD-PH category. So it's not iloprost, but it's Selexipag, which is also prostacyclin analog, and Yoshiga, which was previously licensed for group 4 pulmonary hypertension, which is chronic thromboembolic pulmonary hypertension, which has also been licensed for group 3. But these drugs should only be used in patients who have disproportionate pulmonary hypertension, as in they don't have a great reduction of LPC, but they're very, very symptomatic with their disease. They cannot walk 5 meters, right? And they become breathless. So that's the category of patients where you see an FVC of say 70%, but a pulmonary artery, mean pulmonary artery pressure of 70, where you feel that these drugs would be effective. Mainly, it's the treatment of the underlying cause.
So thank you so much for wonderful talk, and I'm sure. Yeah.
Excellent lecture, Dr. Radisson. If patient of the bronchial asthma having the absolute eosinophil count is more than 1,000 and total IgG is more than 1,000, you prescribe Omazolone.
That's a very good question. I'll give you a short answer. I can see Matak are gradually coming on to me. So I'll give you a short answer. If you get a patient with asthma with a very high eosinophil and a very raised IG, you think of another disease. Can you tell me which one that is?
Allergic bronchopulmonary
Wonderful. That's what
patient having the stress.
So there you wouldn't be able to get omalizumab for sure, because then you will have to weigh the omalizumab in kilos and give it, which no one can afford. You can go for an anti-IL-5 in those individuals, but that's only after you've excluded all the causes that you spoke about and more about raised eosinophil in patients with asthma, and you make sure there's no other disease, and then you would prescribe an anti-IL-5.
If patient having this problem, then how you diagnose the patient having the allergic bronchopulmonary aspergillosis or invasive aspergillosis? So many patients of the bronchial asthma presented with the bronchiectasis and not controlled by the maximum therapy and maximum.
So for ABPA, What I do as baseline screening test is a IG for aspergillosis. That's what I would do for baseline to screen for APA. I would of course look for the IG, the US record that you already looked for. I would do an IgG for aspergillosis. That's the other test. For SAPS, which is what you're asking, invasive aspergillosis would be a very sick patient. It wouldn't be someone who would walk into your clinic. It would be someone who's probably on a ventilator. So patients who've got SAPS, you would probably do a BAL in these individuals and see whether there's aspergillus, along with the other tests we spoke about. And you could do a BAL galactomannan in these individuals also. And if it's significantly raised, that also indicates towards SAPS.
The bronchial asthma patient,
And do the discussion outside.
Please. Okay, sir, I think we along with all this audience will be waiting for your next oration, and please do come here again. We'll have a lot of questions, and then.
Thank you, sir. Now I would like to call upon Dr. S.K. Pathak, sir, Organizing Secretary, to present memento to Dr. Radha.
Follow करिए
We'll be having email ID of Dr. Radha, sir. Later on, we can discuss our training project. Now, I would like to call Dr. Robin Dubey, sir, to present memento to Dr. Dheeraj Kishore. I would like to call Dr. 86 to present memento to Amit Chaudhary. Dr. 86. Dr. 86. Thank you all the faculty, sir. Please have a seat. Now moving towards fourth session, and for that I would like to call chairperson Dr. Rajin Prasad, sir, Dr. Patil, sir, Dr. Deepak Kalra, sir, Dr. K.K. Gupta, sir, and Dr. Raja Datta. This is a case study by Dr. S. Sakshi Patil.
Actually, we are running about 40 minutes late, 40 to 45 minutes late. The only option is to cut short the session, else you go for. And as you have heard, next it is a panel discussion on cardiorespiratory consciousness. And case presentation, something else. So before we have a case presentation, yes, go ahead.
Good evening, everyone. So let's begin the session with a case presentation on acute onset dyspnea. I am presenting the case of a 56-year-old hypertensive and diabetic female, resident of Babarpur, Varanasi, presented to Breath Easy Emergency Room on 2nd of June 2023 with a chief complaint of shortness of breath from past 5 days and cough from past 5 days. As stated by the patient's husband, she was apparently asymptomatic 5 days back when she developed shortness of breath, which was initially present on doing strenuous work, but later on progressed to such an extent that that her daily activities were affected. The shortness of breath worsens in spine position and relieves in sitting position. The shortness of breath was also associated with chest pain, palpitation, and excessive sweating. She also has a history of dry cough from past 5 days, which comes in bouts. Her husband also complains that she has been snoring loudly during the nights. In the negative history, there is no history of fever, no history of heartburn, regurgitation of food, no history of any recent new medication started, no history of acute blood loss, no history of recent trauma to the chest, no history of prolonged immobilization or recent surgery, no history of mood fluctuations or any such episodes in the past. There is no significant personal or family history present. In the general physical examination, the patient was lying comfortably on the bed, was in altered mental status, and was lying in the bed with labored breathing and following vitals. Her SpO2 was 80%. Her pulse rate was 110 beats per minute, regular and palpable. Her respiratory rate was 38 per minute, with the use of accessory muscles and tracheal cut present. Her blood pressure was 84 by 60 mm of Hg. Her temperature was 97.6 degree Fahrenheit. There is no parallel icterus clubbing cyanosis present. Bilateral lymphadenopathy is bilateral field edema is present. On auscultation of the chest, bilateral diffuse wheezing sound was heard and coarse threats were heard. In the heart sounds, S1, S2 was heard, no obvious murmurs heard. The initial X-ray is given below, suggesting a bilateral opacification of lung fields. The initial ECG done showed signs of tachycardia with no ischemic changes. 2D echo could be performed in non-availability of portable echo machine. In the lab works, her hemoglobin is 0.9 gram per dl, slightly low. Her DLC is 20,000 per mmq raised. Her CRP is 20 milligram per dl, also raised. OTPP were also raised. Serum albumin and total protein was below the normal limit. PT, INR, and APTT was within normal limit. D dimer was 1000 nanogram per ml. Raised. Her RDS was 220 milligram per dl and HbA1c was 6.8 gram per dl. Her ABG was suggestive of respiratory alkalosis with a pH of 7.4, PaCO2 of 32, and bicarbonate of 26 milligrammes. The initial troponin levels were less than 0.6, and the initial CKMB was 1.9 milligram per dl. And NT-proBNP was 350 picogram per ml. 2 hours later, her NT-proBNP was 228 picogram per ml. CHOP-I was 1.8 nanogram per ml, and CKMB was 2.3 nanogram per ml. So that was my case presentation. Now I would like to call Dr. S.K. Pathak sir to continue the further discussion.
Thank you, Dr. Sachi. You have presented a nice case. This question open for the final discussion. All panelists to discuss the diagnosis, what the probability product, what the malignant. Just comments from Dr. Radha that the
So, thank you, Sakshi. Well presented. Very nice, very confident. Well done. So, you got a 56-year-old lady who's got features or symptoms which look like heart disease. So, someone who has lying flat, breathless on lying flat. When the patient sits up, the patient feels less breathless. This goes on for a few days. The breathlessness gets worse. The patient has high oxygen requirement. So, like we were discussing before, your question here is this cardiac? Is this respiratory? You also saw that this patient is hypotensive with a blood pressure of 80. You also saw that this patient had bilateral pedal swelling, ankle swelling, which was significant. The chest auscultation showed both V's and crackles at both bases. So my first differential here would be heart failure secondary to a cardiac cause. So you also saw that troponin went up from 0.6 to 1.8, but the normal cutoff for troponin was 1, I think. So that's my first. So pulmonary edema, cardiac is my first diagnosis. The patient also has a raised white cell count, etc. So you would think about this being a consolidation and pneumonia, which is heard as crackles on both sides of the chest, and maybe the patient is septic because of which you have hypotension. So that would be my second differential diagnosis. And I think I would stop there. I can see on the screen that there's pulmonary embolism. I don't think you would see here so many cardiac signs in someone who's got pulmonary embolism. Even if this pulmonary embolism, it would be secondary to one of the other things that you've had, either the heart failure or the pneumonia that we spoke about. So that's my sort of broad outline of what I think.
Thank you. Sure. Dr. Preeti Gupta, sir, any medical points from your side?
हम जा रहे हैं मत परेशान
So this is the superficial presentation for this final discussion. Thank you, sir. From the Dr. A.K. Pandey, sir, the cardiac points were
The case was very interesting as we are discussing regarding the cardiopulmonary points. I have got two issues to be raised. That as a patient is having all those coronary risk factors, she is postmenopausal, she is diabetic, she is hypertensive, she has an acute onset symptom, and all these differential diagnosis has to be tested in this case. I have got a doubt that patient will have a normal ECG. Why? Because the patient is hypotensive and raised troponins and raised BNP. Patient will not have a normal ECG. Sometimes it happens that patients with left main disease, they got a diffuse ST segment depression that is missed many times. And the most important investigation in this group of patients in an emergency department, in spite of this others, is a bedside echocardiogram, which an MBBS registrar or any physician or any graduate or emergency medicine person can put on the probe over the chest of the person and can see what is the left ventricular ejection fraction. Emergency medicine physician, they're having point of care ultrasound and they can see that whether the patient is having a raised pulmonary artery pressure or the LV function is there or the patient is having a tamponade or whatever the cause is. And even you can do the lung ultrasound as well. So what I will need to investigate in this patient, I should have a bedside, at least an ultrasound machine to see for the LV ejection fraction, to see for the patient, the person who's trained enough to see for the lung ultrasound, even we can see the pulmonary edema in this patient. So I strongly agree with all my fellow colleagues that who are discussing the point of cardiogenic pulmonary edema. That's a possible diagnosis of this patient compared to respiratory cause itself. Yeah, sometimes it is pretty high compared to what we see in acute coronary or acute MI patient. Might be that patient is diabetic, she had some acute viral infection or
acute chest infection which has precipitated the acute coronary syndrome, and patient landed up in a hypotension and acute coronary syndrome. Sometimes we get a lot of intermixing. Yeah, as I keep that a patient nowadays with their underlying coronary artery disease or underlying LV dysfunction and develop some of the other respiratory viral infections, and they precipitate at the. What is the need of doing CPKMB when we are doing troponin I? These biomarkers are done in a series. Like if you do CPKMB only one point of time, it may be normal, as she has already said. Doing a set of CPKMB, in 24 hours, 3 sets at 8 hour interval can give you the rate of rise. Sometimes it rises, after 8 hours. Troponin I also has got a similar type of. These two are the biomarkers for the cardiac origin. Sometimes propelling may be rising a little faster. So if you do at least two, at least because doing a single propelling test or a single CPKB doesn't make any sense. Like patient comes to us in an emergency with a chest pain and we do a troponin, somebody has done a troponin and it says the troponin is negative, patient was sent home. That's a wrong practice. We should at least do another troponin or a CKMB at least 12 hours apart, and if both the values are in the same range, it's not rising, then only we can say that the patient is not having any acute coronary artery.
So DLB value is very important for this patient. How do you expect from the diagnosis and to correlate the diagnosis? So, Dr. Pali, sir. DLB value is higher here. Yeah. So normal 80, but we have the 2.
Patient has developed acute coronary event. Then, due to the acute coronary event, patient might have an LV dysfunction and acute pulmonary edema. That's the reason why the BNP level is high and troponin level is also high. There is an acute ischemic insult because of underlying coronary artery disease, which might be there for a pretty long time, and this chest infection or the acute coronary event and got precipitated. Patient has developed heart failure and acute pulmonary edema. That is why the BNP levels are also raised.
Do you think the BNP is slightly on the lower side as compared to what we would expect in someone who's coming with permanent heart failure?
Definitely, because the level of BNP levels are related to the LV function, LV dysfunction. As this patient has developed hypotension and she is so grossly in acute pulmonary edema, I expect a BNP of 1000 at least for her. Because it is said that if the BNP level is between 400 to 1000, these patients, if they are not having renal failure, because renal failure patient may also have a high BNP values. If they are not having a renal failure, then we should need to do a early echocardiogram to see what is the status for the LV function.
So, which question from the Dr. Sir, there is no any history of fever here. So, PSC was too high. And so, why that pneumonia?
What was the input now? Because there is a stress, leukocytosis does happen. And there has been a stress in this case because patient is already having two comorbid conditions. One is hypertension and another is diabetes related. So we cannot ignore any kind of infection whatsoever. Probably it can be the viral pneumonia which might have precipitated the coronary syndrome also. So in this case, so what we are thinking in this case, probably this could have happened. Further, यहाँ आने से पहले हॉस्पिटल में स्टेरॉइड दिया गया था या नहीं दिया गया था मुझे नहीं मालूम। तीसरा, जब हम कभी आईसीयू केयर में हमारे पास पीएलसी अप हो रही हो और प्लेटलेट डाउन हो, तो ये एरर होती है हमारी एस्टिमेशन की। जो हम लोग अपने यहाँ ऑटोमेशन से करते हैं तो उसमें स्मॉल साइज की प्लेटलेट मिल करके जोड़ करके लिपोसाइट बन जाते हैं। लिपोसाइट का साइज, क्योंकि वो आइडेंटिफाई नहीं करता, वो साइज को आइडेंटिफाई करता है। जो 5 पार्ट आपका काउंटर होता है। तो अगर मान लीजिए 2-3 प्लेटलेट्स मिलकर के
उन्होंने ल्यूकोसाइट का साइज बना लिया, तो ल्यूकोसाइटोसिस आपको जाएगी ट्रिपलेट डाउन, and that's what you call a pseudo-leukocytosis and pseudo-thrombocytopenia in ICTF. That happens very many. But in this case, I will suspect probably the patient is diabetic, must not mention specifically there. If you did diabetes, you take after.
This. So really comes from Dr. B. Thomas as a why is not with the RDS something pneumonia with reactors with 50 with radiological picture which look like the ARDS.
Look like ARDS, but overall clinical picture starting from orthopnea, low BP, and all these things more is just polygenic hypertension or starting from edema. And ARDS is basically from most of any insult. The patient don't have any history of fever, throat pain, no aspiration, no any inhalation history. So very unlikely it's ARDS. So and regarding the leukocytes, we found many times such type of raised leukocytes counts to be it's purely cardiac, I think. Because no history of any infection, this is not any history. They should not have any throat pains for any history of viral infection. They should not have it. Simply orthopnea, dyspnea, and white lungs. If you are not having equal immunity due to diabetes and other things, we should be so resolution occurs in within 12 hours or 6 hours. You can make a diagnosis without immunity. But because first thing we have to do, very well, in emergency, first thing, put the phone. Yeah, very important. Another thing you can ask the raise very important thing is others. Again, that can be true the one probability patient having all these features, raised housing dilemma can lead to remote possibility for discussion pulmonary embolism because if she is having hypotension count. Hypotension, this type of features, chest pain can lead to sometimes you can't rule out pulmonary embolism at this moment. But more in favor of cardiac. It's already decision.
So Dr. Marga sir, there is a D-dimer in this case. What the cause is a simple.
D-dimers may be falsely raised sometimes, and as Dr. Thomas has already pointed out this topic that, if we have got a bedside echocardiogram, we can even rule out acute pulmonary embolism as well. Because acute pulmonary embolism leading to a hypotension means patient has developed an acute cor pulmonale. Acute cor pulmonale patient will definitely have a severe TR, severe peer pressure, RV dysfunction. So with only one investigative tool having a bedside echocardiogram will rule out all the investigative, will give you all the answers to this query that the patient belongs to it's an acute pulmonary edema because of cardiac origin or it's a pulmonary embolism because sinus tachycardia may be there with pulmonary embolism also. I always have a concern for normal ECG in this patient because any person who is having such a type of presentation will definitely have some sort of ECG abnormality in the form of ST depression or widening of QRS. Sometimes we see the widening of QRS with tachycardia. Those all can be there.
So there is a waste of the problem. I personally for normal, but after 10 hours.
Yeah, that's what I said that, there may, what I have mentioned about that, the biomarkers over at least 12 hours of period you should always repeat it. First values may be normal. If the patient comes to you within 1 hour, 2 hours, 3 hours, maybe troponin values may be normal or maybe just borderline. But if you repeat it after 12 hours within 24 hours, at least if the second value goes up from the previous value, that suggests that patient has probably some myocardial insult and that the values are rising up. There is no value of a single unit of troponin or CKMB for the diagnosis of acute coronary syndrome. You need to do a serial at least. If you cannot do three, at least do two at an interval of 12 hours apart. That's
Sir, Dr. Rajesh Prasad sir.
So there's a diffuse, there it is difficult to comment upon the cardiac side because there's a soft, fluffy shadows and yeah.
So Dr. Rajan has some the X-ray, so we patients feel that without the X-ray is finding the opposite. What the probability from your side?
Has been discussed in earlier cardiac thing and that has all these failures. And as far as the size of the heart is concerned, it is very difficult to comment. But there doesn't appear to be a enlargement of the heart size. He says. Yes. It was ATP or PAP. Patient was lying down X-ray or
So it's a line down position. Line down position. You never see what
yes. So she has some I mean if it is lying down X-ray, very difficult.
Yes, you say that VC was
3, 4, 5, 6.
yes.
It means he has some background instead of some COAD like yes. Because patient is lying down and so heart is some weak. They appear all like yeah, something only.
So Dr. Rajan has some rate of CRP because of the
So I think we have said that this is probably underlying infection, which has triggered the coronary event in this case. So I think it goes with that. We have a raised total count, we have a raised CRP, and I think we often see these patients who either have a lung infection or UTI, as was said a little while ago, which triggers a coronary event because of ongoing bacteremia. So I think it's just a reflection of that.
overall comments from Dr. Rajan Prasad about this case. We have to discuss the conclusion.
First, I would like to congratulate Sakshi for in such a young age, and I believe she is an intern. So, intern presenting such an interesting case, I must sound so this. And overall, I thank all the panelists who has discussed case very well. Most of the points have been answered. In a clinical case scenario, it is difficult to say that you can answer 100%. But I believe in this case, most of the answers, most of the questions have been clear. And I just say thank you to all of you. We are running very late.
This is the correct diagnosis you have made the particular problem for this case. Patient responded to diabetes and patient treated well after a 3 and 4 days you are picture. So I thank you so much for this kind this discussion. If any comments from the Dr. Rajan Hassan, comments?
I think everything has been said. I think any patient who comes in breathless, this is the most important question to answer for the youngster. You need to find out whether this is cardiac or whether this is pulmonary. There are certain rare causes like pneumothorax, pulmonary embolism that you need to think of. And I always tell my juniors when a patient comes into ICU, very breathless, high oxygen requirement, go through this checklist in your own head. So you start off with thinking about heart failure, which even in my ICU is actually more common as compared to pneumonia. And I exacerbation of underlying chronic respiratory disease. So an exacerbation of COPD, an acute severe asthma, an ILD exacerbation, etc. So compartmentalize these causes in your own head and try and pick each of these and try to come to the correct diagnosis. And often you will have an overlap of causes. It's not going to come to you as a pure heart failure or a pure pneumonia. Often you will see a patient who's got bad COPD, comes in with an exacerbation but is very breathless because they have a pneumothorax, which you have not managed to pick up because there's reduced air entry in the lung. So that's the way to think about, I think, the differential. And I think, like Dr. Ajay Prashad said, very nicely presented this.
I think it's a perfect case for the saying that most of the diagnosis, 70% diagnosis we can make as clinical history, 15% by examination and 15% by the
in the future. So the ideal is affect this order. Clinical and physical examination. Please use patients. Thank you.
Just to limit to that, yes, 20 currents. 20 currents from that Diva closing comments for this case.
I think we have discussed all the things. I just want to add that we can do one other marker, that procalcitonin, to see that if there is any evidence of sepsis or such. That's all.
Thank you so much for time discussion.
One question from audience. What is the final diagnosis?
That is just one. Yes, I could cardiology community.
Acute cardiogenic pipe infection. I say patient having the sepsis, multi-organ dysfunction syndrome, that developed to the congestive heart failure without 2D echo. How you confirm? Your ECG is normal, sinus tachycardia is present, no ST changes and other changes. How you confirm the diagnosis from this patient?
Patient obviously started treatment and diagnosis.
That's what Dr. Singh has raised, that the question was framed to, question was framed to create a confusion among the audience and the panelists. And that's why when the cardiologist is sitting, the ECG was not posted here.
Patient having the sepsis and multi-organ failure, maybe patient having the developed.
We do agree with you, but as Dr. Radisson sir has said that we are running short of time. This question is for discussion, and hypothetical question is for discussion. But when it is impossible to have a hypotension without an abnormal ECG. There is a dictum written in any of the textbook. You cannot have a hypotension in acute coronary syndrome with a normal ECG, and this ECG is not normal. Patient is having sinus tachycardia. Sinus tachycardia is not a normal rhythm.
Now I would like to call first of all Dr. Sakshi to come here. And would like to call Dr. K.K. Gupta sir to Angvastram to Dr. Sakshi for presenting the case.
जा पकड़ ले तो
Would like to honor chairpersons also, so would like to call Dr. S.K. Patel sir to present Angavastram to Dr. Rajendra Prasad sir, Dr. K.K. Gupta sir, and Dr. Deepak Kalra sir. Now I would like to call Dr. J.K. Mishra sir also.
अपना नाम बताएंगे नाम बताएंगे
Would you like to call Dr. J.K. Mishra sir to present Angavastram, Dr. Raja Devi, Dr. Virutan Kovinsky, Dr. Mante sir.
सही बात है तो मतलब होना दावे ने उड़ाया तो हुआ ऐसे काम कर लगता है पार्टी का नाम की काम कर दे
Thank you, please. Please, sir.
I have taken.
Thank you, sir.
Yeah. Number. मैं मान रहा हूँ बाद में तो रिव्यू आप ज्ञान होता
Moving quickly towards our last session, that is fifth session. In every program, we used to have this special session of Dr. Radisson. Respiratory first in clinical drama. For this, I would like to call Chairperson Dr. G. Radisson, sir, and Dr. V.P. Singh, sir, to brief our class.
तो दूसरा मुसल जाना करो काम होना जो बाद में सिंगल पकड़ ले हाँ छोड़ दिए तू पकड़ लेना माथा जा जरा
Some for strong progress. And he did not all working country her country as an excellent test this one. He is a teacher of teachers. And for us, he is father of respiratory medicine. And I have no words for his introduction. And I will, without wasting any time, I request you, sir, to start your presentations. Thank you, sir.
Thank you, Dr. Musra, for the nice introduction. At the outset, I wish to thank for organizing such a wonderful 10 conference. And although my time has already over, I was supposed to speak 9:40 to 10 o'clock, but well, as it happens in most of the conferences, the time is little given. So I will start with this Japanese proverb that better than 1,000 days of a diligent study, especially for interns and the PGs. Study in one day with a great teacher. I don't say I'm a great teacher, but whom I said in the world is my friend. This professor is the reason, and I happen to work with him for more than 40 years. And so this word I have used for him. Why I have used these words for him? For you, it must be a story. I was in MBBS final year, 1973. He was professor and head department of Engineering at that time. And he taught us that there was a one special short clinic which used to be held in KTMC. This was MCI plus. It was not recommended in MCI, but KTMC has innovated this. And finally, the students are supposed to attend those short clinics. So KTMC का होगा तो शायद ये याद हो. And he taught me in 1973. Believe me, 1973. How to manage drug. So that was his duty. You know, he died in 2015. For 1 month before I did a one national level CME and drug resistant TB, and he was the who was the chief guest in that function in elementary college. And he asked me, he was really listen to me. The guy asked me, Rajen, क्या आया? ऐसे वैसे पूरा करते थे। मैंने कहा सर कुछ नहीं आया, जो आपने 73 में हमको एमबीबीएस पढ़ाया था वही आज भी ड्रग रेजिस्टेंट में 3 पॉइंट्स वही, नथिंग न्यू। इस वक्त कोई एमडीआर का नाम नहीं लिखा, तो वो that's why I say 1 hour with great mentor, but I happen to work with him for more than 40 years, so I was very lucky to start with somebody सब कुछ सजन, he was very tough person, tough guy, and उनके साथ काम करना बड़ा मुश्किल। Anyhow, these are my students, I love to show and so some of the pearls which I came across, I would like to share. Starting from simple one, that this gentleman said 45 years age, had a chronic smoker, and had symptoms like neuropathy, usual this one. And this was there. कोई हमारा इंटर्न कहाँ गया वो पीजी, कहाँ गया भाई, क्या करेगा इसमें, देखो ना अभी तो हाँ फिर से पढ़ लो उसको। Right, right. So naturally in India, tuberculosis comes either. अब हम लोग भी 40 साल 50 साल पढ़ाए हैं, any side with the upper zones, TB you must come out. So today 45. See the smoking history. Do you get some other idea apart from tuberculosis? Yes, it could be malignancy. How malignancy can produce shadow like this heterogeneous type of shadow? अबे तुम्हारा भाई भाई हो रहा समझ लो नहीं लिखा। No. My question, देखो ध्यान रखना। हम अभी रोज कुछ दिन पहले मैंने एरा वालों को पढ़ा रहा था, सुनो एग्जामिनर क्या पूछ रहा, how to answer that. क्या पूछा, why do heterogeneous shadow? Do you think this is a common shadow to malignancy? And if it is there, how this shadow is there? So, what I am trying to say, malignancy also can be. There is no doubt. Something like pneumonia like shadow. How the pneumonia can be produced? Any idea? They ask the sir को बैठे हुए हैं उधर भगवान बताइए so it could be something obstruction, fighting vestal, something like that. Begin that possibility. Anyhow, somebody obviously in India, 2001, very common disease. So, but when he finished with about 2001 and then after 2 months, what do you feel? What do you see? क्या चेंज लग रहा तो आज तुम्हारा वाइब्रेट हो चेंजेस क्या हो रहे हैं रिजोल्यूशन तो नहीं हुआ बल्कि थोड़ा मतलब अगर हम कहें तो प्लस साइड भी लग रहा और क्या हो रहा है और क्या हो रहा है so there is a very good there is a volume reduction Usually people don't recognize these things. 45 plus chronic smoker, 2 months of ATT not responding, and shadows increase, and there is a volume reduction. That speaks of the diagnosis. And this is the unfortunately without realizing all these facts. And it was too long. You know what has happened after about another 5 months? So he wanted to complete the ATT. And what has happened now? Swapnil? Now that should be very obvious. Yeah, obvious. What is the most important investigation would you like to do at this stage? Not दसों कराते हो मैंने ये पूछा आगे ये तुमने सारा पिक्चर देख लिया वो 2 महीना 6 महीने ट्रीटमेंट के बाद ये स्टोरी हो गई अब सिंगल मोस्ट इन्वेस्टिगेशन विच कैन क्लियर द डायग्नोसिस दिस इज व्हाट पीपल अनफॉर्चुनेटली डोंट लोग सोचते हैं what had been done on the first day. When his sputum was negative, he was 45 plus, he was chronic smoker. Ideally, this should have been done at the first instant to exclude malignancy, because one of the common differential diagnoses in our country, I'm not talking of any Western part of the world, but I'm talking of this country, it's very common. So I have taken this question, that's why, but we came to us with this. Excellent. What I said in my initial remarks also, lung cancer is really late diagnosed because of the poor perception of it by our doctor. So ultimately, you know, CT pictures, you can see there's a cross, even there's a fluid, something, and then what you see here, this is the liver. So Ranka Putti was done and that has shown the obstructive disease. Trying to say, this is day-to-day clinical practice. We see in and out in our clinical practice, we suspect in my point of view is, I have taught all of my students like it, think initially. जब वो 45 ईयर का आदमी आया क्रॉनिक स्मोकर था शैडो थी स्पूटम वाज अगर स्पूटम पॉजिटिव होता कोई सोचते ही नहीं अगर पॉजिटिव में भी ऐसी बात नहीं कुछ नहीं सोचना है तो डिजीज साफ भी हो सकती है लेकिन ये कि नहीं सोचना बल्कि आपने देखा आप कर लिया ठीक व्हाट आई एम ट्राइंग टू से प्लीज थिंक लॉजिकली थिंक अर्ली सो दैट हम कहा करते थे 10 साल पहले हम खाली रिकॉर्ड बनाते हमारे पास लंग कैंसर को बैठे हुए डॉक्टर साहब बैठे हुए I have more than 3,000 cases with me of clinical carcinoma was did diagnose and treated with the help of other people of lung cancer. So that was ultimately diagnosis. He was professor in KDM, Department of Anesthesia. At the age of 63 years, he came with progressive breathlessness 1 month. So I think with only this symptomatology, और अगर कुछ भी नहीं पढ़ो आप, believe me, she is still now she is retired. When I was professor, she was also a senior banker. She came to me with this. So what Rajadhar has talked about, very clearly he talked about a breathlessness. Weeks, months time, progressively increasing. What could be the diagnosis? I also say, Raja, like you, probably easiest disease to diagnose in lung is the iron. I say, let me repeat, it takes about 30 seconds. What you said is, see the fingers, Haskell tape, take history. That's all. But time you take for to this, because ILD is a group of 300 diseases. It's not a single entity. Raja, I think, has shown very clearly. And so what time we take is that to decide that out of those 300, what is the type of ILD? Otherwise, per se, ILD is a very simple disease. But believe me, she was a professor in medical college, like KG and C. I used to do boost because I had been a student of that place. What treatment she was given? She was, when she came to me, she was on inhale. That was those days very fascinating. To start inhale of breathlessness. And she came to me with her, मैं लगता है 2 हफ्ते 3 हफ्ते में ये मेरे को कुछ फर्क नहीं हुआ. That was the bit of catch one. And then we went into the history details and हिस्ट्री कोई लेता नहीं आजकल सबसे बड़ी प्रॉब्लम एक केस में आएगा we are forgetting history. तो लिए नहीं किसी ने डॉक्टर साहब से पूछा ही नहीं दीवार अक्सर मैं प्रोफेसर I was studying a program. I was given a availability 5 or 2 literally at that time for 6 cycle 4 months ago. And after that, I developed it. And it was actually also in those days, quality of X-ray was not digital, so you can see that something like some diffuse type of shadows you can see are visible. And then we got PFT therapy. उसको inhaler lava, even lava and ICS company. Right treatment, I must say, because you are professor in medical college. जितने भी लाभ लिखा है, कहीं लाभ लिखा है कि डायग्नोसिस सोचे कि अस्थमा है, रेगुलर मींस अस्थमा. Not the circle, but what it shows is the ratio is maintained. क्यों भाई बताएगा तू? क्या बताएगा? बता. तेरे सर भी बैठे बगल में. मुझे पीटी को पढ़ाने में बहुत मजा आता है. क्या कहेंगे इस पैरोमीटर देख के क्या कहोगे? अरे यार तो लिखने की जरूरत है. डॉक्टर साहब जाके हटाइएगा अपने यहाँ. और फिर उसमें पूछने की क्या जरूरत है यार? आई ब्रॉट वेरी सिंपल केसेस. जानबूझ के मैं लाया हूँ कि मेरे पास टाइम नहीं था, मैंने सिंपलेस्ट जो था मैंने लगा लिया. तो क्या बता रहा है यस restrictive language. जाओ भी ऐसी चीज जाओ भी ऐसी चीज अस्थमा. पहली बात ये चीज ना अस्थमा. तो मैंने कहा डॉक्टर को अस्थमा क्या है जो आप इलाज ले रही हैं? ये तो कुछ और है. तो then went into our TG went into two and this was the CT. Forgive me, that was the 50 picture of that time, 2008. Now we have got guidelines how to do a CT scan in ILDs. Unfortunately, हम भी कहते हैं अपने अपने शहर में चेस्ट फिजिशियंस को बड़े स्ट्रांग होने पड़ेंगे रेडियोलॉजिस्ट को ठीक करने के. हमने अपने शहर में ठीक कर लिया. हमने कहा हम नहीं भेजते आपके पास. Unless you comply with those guidelines, what is evidence based, you will not send people. अभी हम जब डायग्नोसिस नहीं कर पाएंगे तो आपके पास हम पैसा खर्च करा के मतलब क्या? So I always say in every meeting, it is we who have to be very strict, and we have to work together so that radiologists cooperate and provide a good quality HRCT, which is really required to diagnose. And that time this was very clear. I think she has like an IPF like picture. Bilateral, basal, subpleural. Yeah. Yes, some other thing. It's not exactly UIP. Yes, maybe. That is like this, right? So there was very rightly common. Very rightly. So we thought two possibilities. Could it be secondary for that? Although she has been operated and say she has given chemotherapy, or else she was on chemotherapeutic drugs. So is it some drug induced ILD, some drug induced ILD? So those are the two things in our mind. And yes, although the picture was not like sarcoidosis, because he has no other issues, she was very idle, she was a professor. ये दो हमने उस वक्त सोचा है, तो ये सेकेंड हो रहा है शुरुआत में वो लिम्फेटिक कास्टोसिस टाइप के पीछे जो आप कह रहे हैं नाट थिंकिंग, हाँ नाट थिंकिंग एंड वो सब. So we did what we did, we did a lot. क्या कौन सी दवाई इसमें कर सकते हैं, तो we found that ILD platinum was there in the literature that it can cause, and we used at that time that. डॉक्टर साहब बहुत, हाँ, और डॉक्टर साहब जो है बहुत ज्यादा फेडअप थी कि भाई मेरे को ठीक होना है, स्टेरॉइड भी नहीं खाना. हमने कहा मैडम खाना तो पड़ेगा, अभी फिलहाल कोई ऐसी दवाएं नहीं है. What we were thinking probably it is a drug induced type of ILD. What is our impression at that time? Yes, no, I told you, but all the investigation of sarcoidosis, she is still in my follow-up. She is alive, and so, and you know, after few weeks of you find that October 2008, and then after about 5 months of 5 months of therapy, you know, the shadows has quite clear. Even CT picture has become released. How clear, and even PFT wise, तो अपनी आप PFT क्या है? तो अपनी आप PFT क्या है? No, so she improved in all that. So what we thought at that time, Roman, probably it is a drug-induced ILD, because it is known fact that drug, you know, not sometimes they can present like UIP, but that UIP is a different. That UIP is not that UIP of IPF. So luckily she is with us now. Now she has about 10 years old further, and she is I keep her on follow up. Now she appears to be okay. Her CT, PFT, and everything, and she is happy. What I'm trying to say, ILD is not very difficult to diagnose, very easy to diagnose, and see this. We took a lot of time to diagnose what the type of ILD, and what we can would probably explain that it was possibly a drug-induced ILD, because other investigations was being thought of, and those investigations were known. So there is another case. You meet with me, 27-year female, had a symptom like ED, had a sputum positive, and I think that time it was 2018, although the gene expert has come, but it was not come at that time. So you will not, that was the CT picture, you know, category like this. So sputum was positive. There is no question of, any doubt. So 6 months of ADT has made all clear. I happened to see that this is clear, this was the CT killer. The patient who was symptomatically improved of 9 months of therapy, that was stopped before me. Patient again came to me in 21, I mean 2 years back, and with the help of developed cough, the sputum again positive. TB9 culture, second line LPA, whole new sequencing. She was very affluent lady. मैंने कहा डॉक्टर तो मैंने सारी जांचें उसको लिख दी. पेंडिंग द रिपोर्ट, टाइम तो थोड़ा लेता है, तो मैंने कहा भाई पहली बार तुमको हुआ था, ठीक हो गई थी, आओ जब तो रिपोर्ट आएगा तो देन विल चेंज एज यूजुअल। पहले ऐसे मरीजों को कैटेगरी 2 लिखा जाता था, अब तो नए गाइडलाइन में भाई कि सेम ट्रीटमेंट विल वर्क, you need not to change the treatment, so we put on the same treatment according to way. And to some every became negative. This was the city picture again, same place, literally. And you your Conclave that this film that उसकी सारी रिपोर्ट है। बाय द वे जो कुछ टाइम मिला जीनोम सीक्वेंसिंग में क्या था। I was I'm advisor to one of the company who was doing genome sequencing in this country. तो उन्होंने कहा हम करा देते हैं फिर आपका करो भाई, देखता हूँ कैसा तुम्हारा है जी सर। तो रिपेंटिटी में डिफरेंस आइसोलेटेड तो एमडीआर तो है, ब्यूटाइल रेजिस्टेंस, पैराडिनामाइड रेजिस्टेंस, सेप्टोमाइसिन रेजिस्टेंस। तो एमडीआर तो है ही है, मॉक्सिन प्रीएक्सडीआर हो गए, ओ प्लस मॉक्सिन तो डायटी तो सारा अप टू प्रीएक्सडीआर तक तो पहुंच गया। ब्यूटी ऑफ gene sequencing in one go you can know everything about it, but how reliable is that the big question. और भी ड्रग्स में कैनामाइसिन और ड्रग्स के रेजिस्टेंस नहीं थे, बट इट वाज वेरी क्लियर नो ड्रग रेजिस्टेंस नेचुरली प्रॉब्लम सो इट डज ऑल द ड्रग्स व्हाट आई ट्राइंग टू से। एंड देन second line LPA what it showed that there was particular fluoroquinolone then now you see the disparity with the Varanasi can be this second line of giving para 3x. Second line LPA is also showing that this is 3x. So this is the gene expert also has shown return to same resistance. LPA1 probably report is not here, but it was done, and LPA2 also had shown resistance to allogeneic phenotypic GST जो इसका हुआ, क्योंकि बहुत अमीर घर की थी, बोले साहब मेरा सब कराओ, क्योंकि सब करा देना तो मैं भी चाहता हूँ सब तुम्हारा हो जाए, क्योंकि दोबारा डिजीज आई है तो जब ये किसी में एंड जीन सीक्वेंसिंग की रिपोर्ट हुआ है तो कल्चर was those mycobacterium tuberculosis complex, no other atypical, nothing like that. And that was DSP report was again indicating that isomeric resistance, ofloxacin, pyridinamide, rifampicin. मेरा माथा ठंडा, मैंने कहा मैं क्या करूँ इसको, लेकिन वो ट्रीटमेंट खाए। तो व्हाट आई एम ट्राइंग टू से, हम लोग अपने इन्वेस्टिगेशन को खुला समझते हैं। These are the gold standard investigation. मैं कोई छोटा मोटा और ना छोटे मोटे लाया अभी जीन सीक्वेंसिंग ऐसे तो कोई बड़ा अच्छा ही लाइफ कर रहा है। What are we trying to say with this case? That we are over relying on the investigation. कभी-कभी मैं कहता हूँ don't treat investigation, treat patient as a whole. So see what has happened to this lady. Just एक्सरे after 3 months, वो बीच में जैसे यूजुअल होता है 1 महीना गैप मार दिया। मैंने डाटा आगे भेजा था, यार तुम्हारा पीएचडीआर टीवी तुम मेल कर रही हो, बाप को डाटा उसके पिता को डाटा, हमने कहा बहुत गड़बड़ बीमारी भाई, और तुम मेरे भी रेपुटेशन को स्टेक लगाने में बैठे हो, तुमको कहा था दिखाया करो रेगुलर, तो अब रेगुलर है डाटा नहीं मिलेगा। बट सी सेज कि हम तो बिल्कुल सही है, हमें कोई तकलीफ। मैंने कहा बात तो आप सही कर निकले जी, मैंने कहा बात तो सही कह रहे हैं, चलो नहीं बदलते देखते हैं, लेट अस सी, लेकिन ये समझ लो तुम्हारे रिपोर्ट्स अदरवाइज हैं। आई एम ट्रीटिंग यू बिकॉज यू इम्प्रूव, फर्स्ट थिंग। सेकेंड थिंग, ये तुम्हारे सिस्टम में नहीं इलाज, मैं तुम्हारे तुम भी चाहती हो ये इलाज से मुझे फायदा क्यों, नहीं है You have to go to the government. बोले नहीं साहब हम तैयार हैं, आप करिए जा. This with the 522 income became negative, fortunately, and culture became negative with those drugs, primary lending. Now our advice to report I is to negatively. Patient improved clinical. Despite the report, so has been advised continue the pain treatment. This is the latest X-ray, I think, this month, 4th of the picture also has drastically improved. Income became negative, culture also became a second time became negative. So what I'm trying to say with this case, please don't treat university. I saw such type of cases in many of the conferences, four culture reports, different reports. So I always say, please, अपना भी दिमाग लगाओ. Don't take as a even a gold standard test में गोरा. मैं ये कहता हूँ, अगर हमसे और राजा धर से गलती हो सकती है, तोमर से हो सकती है, मिश्रा जी से हो सकती है, पाठक से हो सकती है, तो लैब वाले की गलती है. They are not big nuts. As a clinician, you have to realize. So that is I think last case I may stop after this. I तो cases बहुत लेकिन अब ये केस को देखो आप तो सबसे देख. He was about 16-year-old boy, recurrent throat pain, but hemoptysis and epistaxis. This was found on the detailed history, which is hard to forget. On 12th March, he was the son of a मतलब STLS कहते हैं, जो डॉट सेंटर में काम करते हैं, उसका लड़का पिता वहां एम्प्लॉय. तो उसने कहा साहब मेरा ये आया बीन एक्सपर्ट, क्योंकि अब बीन एक्सपर्ट क्या कह रहा, MTB डिटेक्टेड लो, MTB डिटेक्टेड लो, माइंड इट, with rifampicin resistance. So doctor there, without having any thought, they started all oral longer regimen, consist of say, all the drugs like levofloxacin, linezolid, lidocaine. What is the regimen they started? Without thinking that what rule says if MTB detected is low, then the rifampicin resistance question mark. That too first timer. In कौन वहाँ अस्पतालों में कौन लगा? What happened next? What happened? Yes, gene expert. It was gene. Government में gene expert हुआ. ये government में सब चीज हुआ. After 20 days of taking ATT, he was a high student. Going to appear for board exam. उसको इतनी तकलीफें हो गई, उसका पिता ने जो कहा, दोनों आंसू छूट रहे थे कि साहब आई विल लास्ट माय सन, इस तरह इसको तकलीफें हो रही हैं, सब तरह की जाते. तो मैंने कहा बिल्कुल बेसिक रूल भाई, हमने कहा तुमको टीबी क्लिनिक, हाँ साहब, तो हमने कहा तुम हमारे पास कैसे पहुंचो, मुझे लोगों ने पूछा. एक बार मेरा सर रुपया खाओ वो पढ़ाते रहते जो कि क्या होगा, क्यों ऐसे ड्रग निकाल. Rule says that if any patient is not tolerating drug, stop for some time. कौन सा पहाड़ टूट जाएगा भाई? उसने कहा था तो डॉक्टर लोगों ने तुम भाई स्वप्न तो डॉक्टर लोगों ने मना कि तुम नए जनरेशन का डॉक्टर, इसलिए तेरे को बार बार नजर ले रहा हूँ. क्या पहाड़ रोजी बंद कर देते पॉइजन रोक दिया. रोकने के बाद अगली बार जब उसके माता पिता आए तो बहुत खुश आए, चेहरे से पता लग गया इसकी सारी तकलीफ तो दूर हो गई. सुनो मरीज क्या क्या है. मैं सुना देता हूँ वो क्या मरीज कह रहा है साहब। हमको सुना कह रहा है कि डॉक्टर साहब सुनिए सब कोई बात नहीं हुई और खाली रिपोर्ट देखी और दवाई चालू कर दी। अच्छा कोई बात नहीं फिलहाल दवाई बंद किया दवा उसने कहा आई एम targeting the art and science subject to take in. So I was compelled to put a YouTube lecture on how to take history. And then LPA, taken an LPA, not detected. Positive I installed due to adverse drug reaction. All those drugs, glutamithium was negative. Even whole genome shows no growth. तो इस स्वप्निल इसमें टीवी कहाँ है? मोबाइल ज्यादा देख रहा तुम्हारे माता पिता दोनों सुन रहे बहन भी सुन रही वो देखो ना होल जीनोम सीक्वेंसिंग अब मेरे पास क्या उसकी दवाई ये होल जीनोम सीक्वेंसिंग रिपोर्ट है WHO suggests that the deep being expert when MT2 detected low ये बड़ा क्लियर लिखा हुआ हर गाइडलाइन में लेकिन कौन कर रहा कोई नहीं करता बस जैसे ही हुआ तुरंत दवाई इसको मिल गई 22 even I got CT scan का मुझे लगा वो क्या कहीं गलती हो कहीं छुपा हुआ टीबी हो तो भाई हम हमारे पास आके हम दवा बंद करते हैं तो बड़ी बदनामी होगी मेरी भी है सर अबाउट दिस थिंग्स सो आई गॉट सीटी ऑलवेज कंटिन्यू क्योंकि उसको अपर रेस्पिरेटरी ट्रैक्ट के सिक पर तो किसी डॉक्टर को पूछते हैं कि पेशेंट वर्ड ऑफ हेल्थ पॉलिसी फाइना डिस्कस होते हैं पीएमए फॉर एग्जाम consultant was very famous teacher but something there otherwise nothing. So what is what I am trying to say इस मरीज को टीबी नहीं थी ऐसा बोल रहे हो आप किसे कह रहा हूँ बड़ी चेस्ट वाले बहुत बैठे हैं टीबी नहीं थी तो प्लीज टेक केयर ऑफ आवर अल्टीमेटली तो बताना तो हम ही लोगों की होती है इनफैक्ट देवर नो टू तो मैंने कहा भाई बंद हो जाओ आज भी माता पिता हर 3 महीने में मेरे पास आते हैं बहुत खुश के जाते हैं 10 साल आपने जानते क्या आपने दवाई भी लो हमने कहा तो डॉक्टर जाके बताना कोई ऐसी बात है नहीं तो इसलिए दवाई अब लोगी हो सकता है कभी कभी गलतियां हो जाती आई मुश्किल क्यों भाई बहुत समय होगा ना हाँ तो आई सम टाइम next time I will put it. There are many people that I want to skip and एक और प्रॉब्लम हो रही है मैं छोटा सा बता दूं बहुत क्विकली बता दूं ये देखो ये लड़की थी लगभग This was a girl, young girl, started with some lymph node in axilla, actually, that was investigated, nobody investigated chest. तो सबसे बड़ी प्रॉब्लम ये होती है अगर एक्सिला में लिम्फ नोड मिल गया हमारे भाई लोग चेस्ट एक्सरे कराते हम लोग साल भर 50 साल पढ़ाए हैं इन एनी साइन ट्यूबरकुलोसिस गेट चेस्ट एक्सरे डन तो मैंने कराया तो मैंने कहा तुम्हारे मीडिया मल्टीपल मीडिया एंड देन उसके बाद वो बीच में 2021 में उसको क्या हुआ आई प्लूरल डिजीज भी आई तो शुरू हुआ एक्सिला लिम्फ नोड से फिर मीडियास्टल लिम्फ नोड फिर प्लूरल डिजीज और अल्टीमेटली क्या हुआ इसको ये बेहोश हो गई लड़की थी अबाउट 7-8 years यंग गर्ल एंड शी डेवलप्ड न्यूरोलॉजिस्ट के पास हमने भेजा मैं जा दिखा के अरे क्या हो रहा है ये सब तो मुझे तो tell beware of suspicion whether it is a drug resistance or iris Probably it was part of Iris because I am teaching this young girl. He responded, even if you see the Wisdom side has declared Ural and even the tuberculoma has also vanished. So this I am repeated with the same word. We have not changed that. So you need to have a courage. हम क्या देख रहे हैं जल्दी से MDR का इलाज दिखे. So you need to have a courage. This was a case of IRIS, not the drug abuse. But you have to be fully aware about this and then with this my concluding thought has come. I have already said this sentence. I only want to say this sentence. Do not prove investigation. जब मैं PGI में जाता हूँ तो ये सेंटेंस जरूर बोल के आता हूँ. PGI में भाई मेरे दोस्तों मित्रों ही कहता हूँ भाई इन्वेस्टिगेशन इलाज करो मरीज का इलाज करो. So I take patient as a whole, then you will be probably a better clinician, more famous clinician in our area. And then finally, don't be. I have shown you all sorts of investigation. This thing I am taking MBBS KGMC for last 40 years. Don't सारे लड़के याद हैं जो हमारे से कहाँ गए थे डॉक्टर साहब आपने क्या शार्ट क्लिनिक अटेंड करी थी जब आपने एमडी किया था. हमारे एमडी स्टूडेंट भी वो शार्ट क्लिनिक एमबीबीएस वाला अटेंड करते थे. पाठक ने भी अटेंड करी होगी. तो हम लोग यही कहते थे ये सेंटर हमारा बहुत पुराना है. डोंट डू don't be dictated by any investigation. You have seen gene sequencing, LPA, 1, 2, gene expert. Everything may go wrong. What I am trying to say. So, with those, I say don't be dictated by anyone. I can talk hours and hours with all the cases I have with me. With regard keeping बहुत अच्छी. शुरू से ही तो मैं रखता हूँ उन सबों को. So I can talk on this subject. I say don't be dictated. Take them together. सब चीज मिलाओ. मरीज से बात भी करो. हिस्ट्री भी लो. तब फिर लाइफ. You will be better clinician. एक डॉक्टर साहब एक मैं अभी लखनऊ में एक मैं शेयर कर रहा था. मैं यही सेंटेंस बोला कि क्या बोला मैं रिपीट करूंगा कि पहले के जो हमारे टीचर्स थे वो बातें ज्यादा करते थे. बातें ज्यादा करने मतलब they used to take history very properly और number of drugs used to be very less. हमें याद है मेडिसिन का है 2 दवाई लिखता है. अब कौन सा मिलेगा मेडिसिन वाले अब कौन डॉक्टर मिलेगा जो 1 या 2 दवाई लिखे तो हमारे टीचर तो लिखते थे. तो what I say they used to talk more less number. उसी वक्त मेरे कोच ये था भानु मेरा कोच था. बोले सर एक पत्थर बदल लीजिए 31 drugs on one prescription. I will not name doctor. He was a very qualified. So what I'm trying to say, please think of the patient, take history, do physical examination, take help of investigation if it is required, and then decide what is your patient and how you are. हमने एक नया हमको शौक आया है बहुत साल पहले से कि यूट्यूब पे मेरे लेक्चर्स का होता है. ये मेरे पीटी स्टूडेंट मुझे प्रेरित किया. Some of the students who are now DG and director, they are my Facebook friends. उन्होंने हमसे कहा कि डॉक्टर साहब गुप्ता जी, उन्होंने कहा डॉक्टर साहब आप जो एमबीबीएस में हम लोगों को एक्सरे पढ़ाया करते थे वो है कहाँ. तो हमने जवाब दिया वो सब रखे हुए भाई. बोले सर वो रखे ना रखिए उसको put on some tube or some book. Lectures on YouTube. The one lecture I put on teaching MBBS students more than last 20 have seen I want. And this is another lecture which I was taken to the other again. There are student I was very fond of teaching X-ray. So at that I think how many you? बहुत different. ये यानी 2.5 लाख से ज्यादा लोग थे. Believe me, Thomas, this lecture, one of the error center is in Bavaria. When their students, there are 4 or 5 students come every year for exposure. I teach them, and that was recorded, and that was put on the YouTube. maybe about 3 years ago. And that's what I'm trying to tell you. I have this wonderful lecture on after totally for whole 1.5 hours. I will need to you with their saying. Now I am coming with Raja with their demand, great demand of my own student. So I was working on it last 1.5 years. This book is going to be released very soon. It will be because एक्सरे की जैसे हिस्ट्री रीडिंग की कला खत्म हो जा रही है वैसे एक्सरे रीडिंग की भी कला खत्म हो रही है तो this book is will be 2 volume. It is already been completed. I think with these words I would like to end my lecture by saying this. ये आप सबके लिए बच्चों के लिए जो बूढ़े नहीं होना चाहते हैं आप लोग अभी जवान हो हम लोग थोड़ा सा हम और मिश्रा जी पढ़े हम तो खैर मिश्रा जी से भी पढ़े ये हम लोगों के लिए है सब आपके लिए भी है और ना पढ़ो किसी के लिए मैं मोस्टली वीसीस को जब एड्रेस करता हूँ कभी कभी तो कहता हूँ भाई ये यूज क्या करो तुम्हारे स्टूडेंट लोग बंक नहीं करेंगे तो अपने हंस रहा 2 क्लास इसने बंक किए होंगे समझ गए because bunking is a new phenomenon in our time it was not there. So that is anyone who keeps learning stage and that's why to the end I say in my slides will be live and stage. Thank you very much. Thank you, dear Dr. for giving me this opportunity to share some of my thoughts. Thank you very much.
So, not taking you so much time, I would like to call Dr. J.K. Mishra sir to present Memento and Angvastram to Dr. Rajan Prasad sir. एक बार फिर से सर सर आपको 100 भी मिले तब भी कम है सर अभी हम लोग गोल्डन जुबली मनाना ना था रेस्पिरेटरी कॉन्क्लेव का
कैमरे मैन खड़ा हो जाए
would like to call Dr. Sanjay.
बढ़िया होगा यार मैं तो बस होने की
Memento to Dr. VP Singh sir. Would like to call Dr. Sanjay sir. Dr. VP Singh sir. Would like to call Dr. S.K. Pathak sir to present Memento to Dr. J.K. Mishra sir.
तो भटका नहीं करेंगे हम लोग खड़े हैं
Thank you very much sir. Dr. S.K. Pathak sir to Dr. Sanjay sir. Token of thanks. We would like to call all entire team of Respiratory Conclave Conference to please come inside. Entire team of Respiratory Conclave Conference coordinating team.
Dr. Ashishu Mittal sir, Dr. Saurabh sir, JTB. अभिषेक अब एक साथ 5-6 पीस लेंगे. Dr. Robin Dubey sir, expedition, Varanasi. Most handsome doctor of Varanasi.
Oh.
पूरी टीम को बुला लो. एक बार सारे स्पीकर्स को बुला लेते हैं सर, सारे फैकल्टी टीम को एक साथ कंबाइन करो. अभिषेक तिवारी थोड़ा साइड अलग कर.
बढ़ावा. इनके पास मनोज बाहर से खाना ले. हाथ से निकाल के ले जाइए ना. अरे हाथ से निकाल के ले जाइए. हाथ में लेके क्या हैंड. तो हमारा आइडिया बढ़िया लगे ना. आप कौन आइडिया है. आप कौन आइडिया है. हमारा कौन आइडिया करनी. हाँ लेके जी आ जाओ. बहुत ठंडा लगता है भगवान की बहुत ठंडा लग जाता है गर्मा लगे बड़े बड़े गर्म नहीं हाँ कोई ठीक रहे हाँ तो आपको लगा या खराब हो खराब हो दारू वारू पी के आए खाते हाँ हाँ क्या कर रहे हो क्या चला जा था आयो हो जाएगा लगा चार कहाँ गाड़ी तो और धन्यवाद अगले फोन आप दिलाएं आ रहा है ठीक है ये ला तो
Thank you for all here giving a valuable time, all the audiences, speakers, faculties, and everyone. Hello.
हमको समझ में नहीं आता इनका चीजें जुम्मों में पूछते हैं काम मतलब दूसरा सा
Thank you so much for all faculties here to come on my activities. And thank you so much for ideas and sorry. Thank you so much. Thank you so much.
खराब कट 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 कहाँ से ये है ना नहीं जाना नहीं जाना रिकॉर्ड कर देना चलो चलो मंडप पे क्या लगा मंडप को लगा दे दो मंडप क्या लगा